because today is Pediatrics and OB. You know OB, obstetrical emergencies. Guys, this actually used to be its own category on the National Registry exam. Back in the day, used to be its own category. But then they decided to take the OB, emergency childbirth stuff, out and put it in the medical emergencies category. Because I guess it's a medical emergency.
Medical emergency.
Right? And then they took pediatrics and they just sprinkled it throughout your 5 categories. Right? Now, something you guys should know from the get-go, because we already talked to you about this, are pediatrics, are they just little adults?
No.
No. Kids are what?
Freaks.
Freaks. Anatomically, they are completely out of proportion with the rest of the world. Right? Their heads are
huge.
Look at the size of its head. It's got its own gravitational pull. Their airways are tiny, tiny, tiny. Their tongues are big and floppy. Their epiglottis are big and floppy. And they do what with everything?
Put it in your mouth.
Don't put that in your... Don't put that... So, you need to just understand the basic differences between adults anatomically and pediatrics. You need to understand a little bit about growth and development. Yeah, I know you think you understand about growth and development. Why? Because that's really going to determine where your patient assessment is going to be directed. You need to understand about basic childhood illnesses and injury. Right? And then we got to talk to you about probably the 2 most depressing things ever in any EMT course. Yeah, turn it off. Right? Or take it off. I don't know, one of the damn 2. Right? 2 of the most depressing things. And we talk about them back to back. And my theory is, right, pretty much every EMT course does it. They don't want to depress you at 2 different times in the course. They just want to depress you one big time altogether. We got to talk about something that absolutely makes our blood boil, which of course is child abuse. You need to have the recognition. You have a responsibility as EMS personnel. If you suspect, you must report. Right? You need to know what your guidelines are. Every EMS agency has one. And then we got to talk about SIDS, sudden infant death syndrome. Again, 2 of the most depressing things we talk about. But then we get to talk about emergency childbirth. Wow, you guys seem about a little underwhelmed. Emergency childbirth! Woo! All right, guys, listen to me clearly. To get your your OB skills down, right? You get your OB stuff down, your obstetrical emergencies. All you're gonna have to do is break it down into 3 different categories. Just break it down to 3 different categories. Know everything in those categories. Number 1, pre-delivery emergencies. You need to be able to recognize and understand all of what we consider pre-delivery emergencies. Category number 2, delivery emergencies. No complication emergency childbirth and just a handful of the complications that we teach you guys about in this class. And guys, this is how we really tell whether you actually give a damn or not. How? Because when we come back and ask you, hey, if you see this happen, what you got to do? You better damn well know. Because guys, I'm going to tell you right now, emergency childbirth, when it's good, it's great. And most of the time, it's good. Oh, and by the way, you are not delivering a child. Mom is delivering the child. You're just assisting her. I'm delivering a child. No, you're not. right? And when it's good, it's great. But guys, let me explain this to you. When it's bad, it's the worst thing ever. There's a handful of things we teach you that you better darn well freaking get down and know. Because if things go south, do you have to know what the hell your responsibilities are?
Mm-hmm. Yes.
Yeah, and we're not just talking about an adult female. We're talking about a brand new baby what? Human. A neonate. A newborn. So, listen carefully. And then last but not least, last category, just neonatal resuscitation. Right? A handful of things. Know what to do by what you see. Straight up. That's it. That's all you're doing today. So, my question to you, as it is every day, is... Are you ready? Are you ready?
Yes!
Hi, guys. The one, the only, Mr. Vincent Conte.
All right, so we're gonna go ahead and get started with
There
our.
he is, and Bourbon. Come here, big dog. Come here, you big clean puppy. Don't linger over here.
All right, so we're gonna go over our pediatric emergencies first. All right, so with peds, okay, a lot of the stuff we've talked about or will talk about in this chapter we've already talked about. Okay, we obviously have to scale it down a little bit and change it because we're now talking about pediatric patients. Okay, so we'll be going over that. As Matt said, we'll be covering child abuse, right, SIDS, death of a child, all that kind of sad, depressing stuff. Of course, medical, traumatic emergencies, things like that. All right, so when it comes to our pediatric patients, okay, they are changing very quickly over a very short period of time. Okay, so we have to go over different lifespan development changes. We'll hit that in a little bit. So that way you can identify normal, so you can identify abnormal. Okay, so like, hey, kids of this age range, I expect to see these types of injuries, these types of illness, these types of activities. And if we don't see that stuff, that's probably going to be a bad sign. Okay, now we also, right, have to worry about their physiological and anatomical changes, as well as emotional. Okay, again, kids are freaks, anatomically speaking, and other reasons, right? But they got a big old fat round head, for example, okay, on a very, very small neck. So some people describe it as a bowling ball on a toothpick. Okay, so when we talk about traumatic injuries, we have to think about that analogy. Big old fat round head, tiny little neck, right? High risk of cervical spine injuries, right? Also, not only do we have to worry about the kid, who else do we have to worry about? Mom, dad, or parents, right? So we have to worry about the caretakers who are taking care of them, because if their child is injured or ill, are they going to be stressing out?
Yes.
Yeah. Okay, so who are they going to be looking to for comfort? Us. Okay, and when it comes to dealing with pediatrics, it's not the same as dealing with grandpa, all right? Grandpa, all right, grandpa's old and sick, whatever. Right, but when kids are sick, okay, it's stressful for us. Right, dealing with kids, in general, is again stressful. Right, just healthy kids running around. Right, let alone critically injured or ill kids, super stressful. Okay, and this is why we've been going after you guys, right, for your confidence. Okay, because if you're going there and quite literally shaking in your boots as you're taking care of this kid, are mom and dad going to trust you? No. Okay, so they're going to start freaking out. Kid's going to pick up on mom or dad's energy. They're going to freak out. Right, and this scene's going to be a lot more chaotic than it needs to be. Okay, but if you go and you at least show that you're confident in your abilities and your knowledge, mom and dad are like, okay, this person knows what they're doing. I'm going to relax a little bit. Kid's going, okay, mom and dad aren't freaking out, so I guess I'm not that sick. I'm going to relax a little bit. And it's a nice, easy call. Okay, but it all goes back to one of those fake it till you make it deals, right? Where, yeah, you're still going to be stressing the hell out for a kid, but you've got to be calm, cool, and collected when you're actually running your assessment. Okay? As far as most of our treatments for pediatrics, it doesn't really change all that much compared to adults, right? Airway, breathing, circulation takes care of everything. We fix area problems the same way. Breathing problems the same way. Circulation problems the same way. Okay, so we have to worry about other things when it comes to treatment, right? Which we'll be going over as we hit the different stuff. So, 5 different stages of development for pediatrics. First off is infancy. And that's going to be the first year. And within that, we have a little subcategory known as neonates. And neonatal is going to be the first month. Okay, so the first month is neonatal. The first year would be infancy. After that, we have toddlers. And that's going to be from ages 1 to 3. Then we have preschool, which will be from ages 3 to 6. School age will be 6 to 12. And then adolescents, depending on what source you're looking at, either 12 or 13, up to 18 years old. All right, we have to try to identify what is normal for kids of these age ranges. So we can go, okay, that makes sense as to why I'm seeing this. So we can identify what abnormal is. So we go, oh crap, that's not good. So for example, with toddlers, okay, would I expect some scraped knees and scraped elbows in toddlers?
Yes.
Yeah, right, because they're learning how to walk and they tend to fall on their face every once in a while. Okay, so a little minor trauma like that, not a big deal. But if I've got a kid who's covered in bruises on half of their body, is that normal for a toddler?
No.
No. So now what are we suspecting?
Child abuse.
Okay, and if we see it or suspect it, we report it. Okay, and as we cover that, we're going to be asking ourselves a whole bunch of questions, right, to determine if there might be child abuse going on. Okay, but that's an obvious one. If I see injury patterns that are not typical for that stage of development, okay, something's not quite right. Right? As far as preschoolers, right, obviously they're a little bit older, going to start seeing things that's different. And as the kid gets older, it becomes more like a traditional patient assessment. Okay, so starting off with infants, right, the first 6 months, they don't know who mom or dad are, so they haven't developed that stranger anxiety, which means I can take them from mom or dad and the kid wouldn't know the difference. All right, but if we can, wouldn't it be a bad idea to have mom or dad hold on, just makes the kid a little bit more comfortable, especially as they get older. Okay, obviously we have to worry about the airway, because can an infant maintain their own airway?
Oh.
Not really. Okay, and again, these infants are going to want to put everything and anything they can in their mouth. Okay, so super duper high risk of choking, right, in these really, really young kids. Now, as far as crying, obviously a crying kid is going to let you know that something isn't quite right. However, if the baby is crying, at the very least, we know they have a what?
Airway.
We at the very least know they have a patent airway, and they're what? Breathing. Yeah. So we like to say a crying baby is a relatively healthy baby in the sense that they have an airway and they're breathing. Okay, so the baby's screaming its head off. Okay, we know the baby's got a patent airway. We know the baby's breathing. All right, cool. Right, and then we move on to check the rest of our assessment. All right, persistent crying, on the other hand, where the baby's crying nonstop, right, obviously that's going to be an indication of a more serious problem. Right, and we'll just ask mom or dad how long things have been going on for, stuff like that. Obviously, this kid cannot give us any information about himself, so we have to gather it from mom or dad. When it comes to toddlers, okay, they most definitely know who mom or dad are. So at this point, if I were to take this kid away from mom or dad, what are they probably going to do?
Cry.
But at the very least, now they're crying, we know they got what? Airway, and they're breathing. Okay, but obviously, screaming babies is annoying. So, if we can, have them sit on mom or dad's lap, okay, make them feel more comfortable. Depending on the severity of the kid, we can even let them handle the equipment so they know that it's not going to hurt them. Right, obviously, they don't know what a stethoscope is and what the purpose of that stuff is. But if I give it to them and they're like, ooh, what's this? Right, and mess with it, they go, okay, it's not going to hurt me. I can also demo the equipment usage on a parent, right, showing that, okay, it's not going to hurt. Little teddy bear there as well, we can demo it. Okay, or we can just simply distract them. Right, kids are stupid, so we can just wave a little teddy bear in front of their face, right, and they won't know the difference. Okay, with these toddlers, again, minor bumps and bruises, totally fine. Right, super duper high risk of choking as well because they're very exploratory. They're learning a lot of stuff, so they want to try everything they can. Now, when it comes to poisoning, are kids likely to get poisoned?
Yes.
Yeah, and usually it's what?
Accidental.
Accidental. And what route is the most common route of poisoning? What is it?
Ingestion.
What is it?
Ingestion.
That's right, ingestion. Okay, so again, they want to put everything and anything they can in their mouth because they don't know what it is. Okay, so again, plant poisonings, medications, things like that, they go, ooh, piece of candy, and then put it in their mouth, and then they get poisoned. All right, as far as school age, or preschool age kids, rather. Okay, same thing, still worried about putting stuff in their mouth. All right, but with these kids, they can now start giving us a little bit of information by asking them directly. Okay, so at the very least, they might be able to tell us something like a chief complaint. All right, they can be like, it hurts here. All right, and they point to where the pain is at. Other than that, though, that's probably the most I can get out of this kid. They don't know their medical history. They don't know what medications are on. They don't know if they're allergic to anything, right? Probably can tell you what they had last to eat. Maybe be able to tell you what happened, but that's about it. Okay, all that other information, who do we get it from?
Supervisor.
Get it from parents.
Yeah.
Supervisors for kids.
No.
Tell your boss. All right, so we want to go and get that information from the caretaker, right? And be like, oh yeah, my son's allergic to peanuts. He does have an EpiPen for it. Right, and he did have hives the last time he had some type of peanut butter, right? So we want to look out for that kind of stuff. Now, for the physical exam, For kids that are preschool age and younger, okay, we do a toe-to-head assessment. Kind of assessment?
Toe-to-head.
Kind of assessment?
Toe-to-head.
Right, so we start at their feet and we work our way towards their face. Now the reason why we do a toe-to-head assessment for these younger kids, right, if I start palpating around their face, they start squirming, right, start putting up a fuss, and it makes our job more easy or more difficult. Right? But by starting at the feet, we can distract the kid, hey, look over there, right, as we start palpating, right, and then once we get to the face, then they start squirming and start putting up a fuss. Okay? Now when we get to school age kids, right, now it becomes more like a traditional assessment where the physical exam is a head to toe. All right, these kids are old enough now to at least know that we're the good guys and we're there to help. All right, whereas kids that are younger than that don't really know what we are. Okay, as far as their assessment, we can start asking them more questions. And obviously the older kids in this age group, I'd ask more questions compared to the younger kids. All right, so for example, I'd ask an 11-year-old more questions related to sample, possibly even OP-QRST, than I would a 6.5-year-old kid. All right, because the 11-year-old understands better what we're asking. Okay, any information that I can't get from the kid, who do I get it from? Get it from the caretakers, right? Mom, dad, whoever's looking after them. Okay, so we'll try to get as much info as we can. And then once we get to adolescence, right, now it's pretty much like a full-on regular patient assessment. All right, now depending on what source, again, 12 or 13, neither here nor there. Okay, but we're going to treat those as regular adult patients. Okay, so it's going to run just like the regular assessment we've taught you. All right, now there's other things we have to worry about in this age group that I don't necessarily have to worry about in other pediatric age groups. Okay, for example, right, female patients may be pregnant, right, whereas I don't have to really worry about that with younger kids. Okay, higher incidence of drug and alcohol abuse, right, in this age group. Okay, motor vehicle accidents since they're learning how to drive. Okay, a lot of sports injuries now that they're getting more involved in sports. Right, and a lot of the injuries and illnesses are going to be managed the same as they would for adults. Right, if possible, we can have an EMT of the same gender do the physical exam. Right, so for example, female patients, preferably female EMTs will do the physical. For male patients, preferably male EMTs, but it doesn't really matter. They don't really care who touches them as much. Right, sometimes they'd rather have a female EMT do it. But, right, we just want to go and try to accommodate that as much as possible. All right, now as far as our assessment, okay, the primary assessment does not change for anybody. Okay, it doesn't matter if they're pediatric, geriatric, medical, or trauma. Okay, the primary assessment doesn't change. However, with pediatrics, we are going to add an additional tool to kind of look at different things in the primary assessment, right? But as far as order, we do the same thing. BSI, pen man, general impression, right? Hold head if we have to, do our AVPU, et cetera, et cetera, et cetera, et cetera. So what we use is the assessment triangle, right? And this is done pretty early on in the assessment. So the appearance is done as I do my general impression in AVPU. Breathing is obviously done in B, and then skin circulation is done as we go through COPS, specifically referring to which letter in COPS? S, which stands for?
Skin signs.
Skin signs. Right, so by the time we're done with ABCs, we've already done our assessment triangle. Okay, so it runs parallel to the beginning part of our primary assessment. So for the appearance, I want to see if the kid is awake and they are aware. All right, and that's obviously done during AVPU. Or if I approach them and they look at me, cool, we know the kid's aware and that they're awake. All right, also, we want to see if they are sitting upright if they have the ability to do so. All right, so those kids are a little bit older, right, where their babies can actually sit up. Okay, I want to see if the kid's doing that. Now, keep in mind, if a kid is sick, are they still going to have energy?
Yes.
Yeah. Okay, think about kids when they're sick, right? They're not just going to sit in bed all day like we are, like, oh, I need a rest. They're going to be like, oh, cool, I don't have to go to school and make a mess. Okay? If a kid is not having that type of energy and just in bed, feeling really lethargic, that's a problem. Okay, if that kid is staying still in bed, not doing anything, you should be concerned, right? But if that kid's being a little shit and running around all over the place, okay, cool, this kid's relatively healthy. Not 100%, but we know the kid's not circling the drain. Right, just like a crying baby's a healthy baby. Yeah, baby's obviously crying for a reason. Right, baby's probably sick or hurt, but we know the baby's not critically dying right in front of us because they're crying and they're breathing. As far as work of breathing, we're going to be looking out for retractions, right? We saw a little bit of that in that group kid video. Okay, we kind of see a little bit of the shading of the rib cage. Okay, that's because we have the intercostal muscles that are contracting, right? Indication of respiratory distress. And as far as abnormal noises, it's the same abnormal lung sounds that we'd hear. So, George, what is one abnormal lung sound and what does it indicate?
bronchi.
Okay.
Like they indicate like fluid in the lungs, like the sickness.
Like what?
Like the illness. Like
Okay.
mucus in the lungs.
Okay, and what part of the lungs?
The
Which part of the airway, at least?
lower airway.
Okay. So what's one infection? I didn't realize. So my son last
Pneumonia. Pneumonia.
Yeah, pneumonia is one of them. Right. What's another lower airway infection?
Bronchitis.
Bronchitis. All right. What's another lung sound? What does it indicate?
Wheezing, like a lower not dilation. Constriction.
Okay. So what conditions can cause bronchospasm?
An asthma attack, anaphylactic shock.
And what kind of shock?
Anaphylactic shock.
Right, an anaphylactic shock. Okay. Now, as far as asthma, is asthma common in pediatric patients?
Yes.
Yeah, right. In fact, that's the primary age group that asthma is going to be affecting. Okay, so we'd have to worry about that with kids. All right, Shannon, what's another lung sound?
Stridor.
Okay, what does that indicate?
An area obstruction.
Where?
An upper airway obstruction.
Okay, so what are the two airway infections that can cause stridor? Nope. Darge?
Inhalation of toxic gas.
No. Erica? Two upper airway infections that cause stridor.
Oh. It's heard in the treatment, right?
Okay, yeah. Do we know? No? Daisy? Chris?
Epiglottitis and croup.
Right. So if a kid has epiglottitis, how would I know they have epiglottitis over croup?
Croup, they have the barking seal cough.
Okay. Whereas epiglottitis would have.
Excess drilling.
Right, excessive drooling. Okay, so if the kid's got excessive drooling, just doing all that, crap, this kid's got epiglottitis. And can we suction out the airway?
No,
Why not?
because it's really, really fragile. Their epiglottis is really big, flappy.
Okay.
And we don't want to. We don't want to mess it because if we mess with it, it can kill them.
Okay, how? How is it going to kill that?
Doesn't it swell up and like completely shut
Shut what?
their airway?
Which tube?
Kind of. The trachea.
Right. Okay, so the epiglottis will spasm shut, okay, and then block off the trachea. All right, it's not going to swell up and block the whole thing. It's going to spasm and specifically block the trachea, like the epiglottis is supposed to do. Okay, so if we do any type of stimulation to the airway, it can cause it to spasm shut. And then what'd you just do to that kid?
Kill him.
You killed him. Okay, so with croup, right, with that barking seal cough, we can be a bit more aggressive with the airway and manage it as such. All right, and what's the other lung sound?
I forgot which one they said.
Okay, well, what are the 4 different lung sounds?
Okay, so it's rails.
That's the one we're missing.
Oh,
So
okay.
what is going to be, what indicates rails?
Fluid in the lungs.
Okay, what do we call that? What do we call that?
Pulmonary edema.
Right, and what are the 5 medical causes of pulmonary edema?
Inhalation of gases,
What kind of gases?
toxic gases.
And
I'll come back to that one. Near drowning.
okay,
Pneumonia.
mm-hmm.
Toxic gases. Did I say that already?
Yeah.
Super gases.
What do you mean super gases? Like superhero gases?
No, I remember that one. I don't know how much that.
Okay. Well, what can cause production of toxic chemicals?
The chemicals in there.
That may be released because something's on.
Something exploded.
Therefore, something might be on.
Fire.
Right. So if it's caused by a fire, it's super smoke. Super smoke. fire is hot, right?
Superheated chemicals.
There we go. Superheated gases. Okay. Don't know the last one. What's the last one?
Left-sided heart problems.
All right, left-sided heart problems. Okay, so we start getting that fluid back up from the left side back into the lungs, creating pulmonary edema. Okay, now of those, right, pediatrics are prone to quite a few of them, especially near drowning. Okay, because do young kids know how to swim? No, right? And if they have unsupervised access to water, could the kid fall in the water?
Yes.
Yeah. Okay. As far as chemicals and superheated gases, it just depends on if they're near fire or something like that. Okay, we really don't have to worry about pneumonia. Well, actually, we do have to worry about pneumonia in kids because it's the #1 medical killer of kids, right? And we have to worry, don't have to worry about left-sided CHF because kids generally have healthy hearts, right? So they're not likely to have AMIs. Okay. So we do have to look out for those lung sounds. Now, as far as the different lung sounds, they indicate the exact same thing in kids as they would for us. So I hear wheezing, I know that kid's got bronchospasm, probably due to asthma, but they could also suffer anaphylactic reactions, right? If that kid's got rhonchi, kid's probably got some type of lower airway infection, right? If they got stridor, they got some type of upper airway obstruction, right? They could be one of the infections, or kid simply choking because they put everything and anything they can in their mouth, right? And they also have high risk of choking, okay? So the different lung sounds don't mean anything different. It's just, okay, that's what we see and we treat it the same way. And as far as skin circulation, we're going to look out for color, temperature, and moisture, and they would indicate the same thing in them as it would in us. So if they're pale, cool, diaphoretic, we suspect they might be going into shock, right? Or if they're hot, flush, and diaphoretic, they might have a what? Infection. If they're hot, flush, and dry, stuck out in the heat, what is that?
Dehydration.
Heat stroke?
Heat stroke, right? So again, we're going to be looking out for those things in addition to the rest of coughs. Now, when it comes to kids and their ability to compensate, okay, kids are able to compensate a lot longer than we can, but once they run out of those compensatory mechanisms, they just crash. Okay, so these kids will fight and fight and fight and fight and fight and fight and fight, but once they can't do it anymore, they tank, right, and then they die. So when it comes to shock in kids, if we see it or suspect it, we treat it. Okay, so when it comes to shock in kids, if we see it or suspect it, we treat it. Okay, so if the MOI or NOI indicates, hey, this kid might be going into shock, let's just go ahead and do this general shock treatment. That way, at the very least, we can pause it right there before it gets any worse. All right, now as far as the treatment of shock, okay, it doesn't change for us. High flow to blanket, proper positioning. Okay, so everything we do in terms of shock and everything we see in terms of shock is going to be the same for us as it will be for them. The only difference is they can fight it off a little bit better than we can for a little bit longer. Okay, so they have a much longer stage of compensated shock, a much shorter stage of decompensated shock before they go into irreversible shock, and now the kid's pretty much dead. Okay, now as far as the way they compensate, again, the exact same way. So what are their blood vessels going to do? What are they going to do?
Constrict.
They're going to constrict. What's the airway going to do?
Dilate.
It's going to dilate. What's the heart rate going to do?
Speed up.
What about respirations? Right. Okay, so when they kick the sympathetic, it does the exact same thing in our body as it will do in theirs. Okay, they're just a little bit better at it, so they can do it a little bit longer. All right, but again, once they can't do it anymore, they just crash. Okay, so we like to say they can compensate until the bottom drops out. All right, now as far as pediatric patients go, okay, this kid, obviously kid's sick, okay, but does this kid look critical?
No.
Not really. All right, again, we know the kid's not 100%, but the kid's able to keep himself holding upright. Okay, he's alert, eyes are open, at least looking at the person. Okay, so right there, yes, we know the kid is sick, but I know this kid's not super duper critical just by looking at them. Okay, as we keep going through the rest of our assessment, we'll look out for other signs, symptoms, but just by looking at the kid at face value, we know they're not super duper sick. Okay, now as far as the primary assessment, again, doesn't change for anybody. Pediatrics, geriatrics, medical trauma, we run the exact same primary assessment. Okay, it's just, again, we run things parallel, rather, to the beginning part of our assessment with the assessment triangle. All right, and if we find any life threats, we see it, we treat it. We see it, we treat it. See it, we treat it. Again, kids are no different. Now, as far as transporting, we don't have to worry about writing this stuff down, right? But as far as transporting, if mom or dad have a car seat that's intact and available, we can use it. Right? We'll strap it up to the gurney, okay, and we'll just go ahead and transport the kid to the hospital in that car seat. If we don't have the car seat available, so it's damaged or just unavailable, okay, your company will have different devices for transporting pediatric patients. Right? It does vary depending on the company, and obviously they will train you on how to use it, right, if you have to transport kids. Okay, we don't really want to have mom or dad sitting on the gurney holding the kid because the kid's not restrained. Okay, so we want to make sure we have the kids seated down, and we can have mom or dad in the back, depending on company policy, right, and severity and criticalness of the kid. So with our assessments, again, those younger kids, school age and below, we do a toe-to-head assessment, or preschool age and below, rather, toe-to-head assessment. Okay, so we start at the feet, work their way up towards the face. Whereas school age and above, we do a head-to-toe assessment. Okay, so we run it the exact same way as you would for us. Right, we can demo the use of equipment on mom or dad or the little teddy bear or whatnot. Let the kid handle the stuff as well, as long as they're not, critical. Okay, if the kids, call out for something, or we get called out for the kid for something minor, okay, here's a blood pressure cuff. That way they can mess with it, see it's not going to harm them. All right, again, using a mom or dad. That way the kid goes, okay, mom or dad aren't freaking out. I guess it's okay for me to use, right? And then we can go without that further incident. We can get down to the kid's level as well. That doesn't mean we lay down on the floor next to this infant, right? But we have mom or dad pick them up and sit them on their lap as we kneel and run our assessment that way. Okay, especially with a little bit older kids, those preschool and school age kids, right? We don't want to be standing towering over them, right? Because it's going to make them a bit more scared. All right, like we talked about in patient assessment, if something's going to hurt the kid, do you want to tell them?
Yes.
Yeah, tell them ahead of time. Okay, if you freak them out and surprise them, then yeah, it's going to make it a lot more difficult because now they start screaming. Okay, so with our vitals, again, don't worry about writing down every single number, but the younger the kid is, the faster their heart rate and their respiratory rate is, and as the kid gets older, right, those things start to slow down. Okay, and we usually see that change right around the age of puberty. Okay, so right around puberty is where we start to see the vitals start flip-flopping to where kids are more dependent on blood pressure as opposed to cardiac output. All right, now when it comes to cardiac output, Brent, what is cardiac output?
The amount of blood that circulates in the body in a minute.
Right, and how would I calculate that?
Stroke volume times heart rate.
Perfect. Okay, so that kid's got to continuously pump blood around the body, right, at all times, hence why they're going to have faster heart rates, and to keep it freshly oxygenated, faster respiratory rates. Okay, now when it comes to pediatric patients and bradycardia, that's obviously really, really bad. Okay, when the heart rate gets too slow, right, that's where kids start decompensating, right, and that's where they start to crash. All right, now as far as airway issues, okay, remember the kids are?
Freaks.
Kids are what?
Freaks.
Kids are what?
Freaks.
Right, kids are freaks. So they got a big old fat round head compared to everything else in their body. Okay, as well as a longer occiput, okay, where it's going to jut out. Now, when this kid is laying down supine, okay, when they're flat on their back, their head is naturally going to be flexed down like this a little bit. Okay, so when we have to open up the airway, George, what position would I use to open up their airway? Nope. What position do we have to use?
That's when they're facing straight out.
Nope. Okay. Mm-hmm.
Would it be the sniffing?
I don't know, sir. This isn't Jeopardy.
It's the sniffing position.
Right, it's a sniffing position. What is it?
Sniffing position.
Right, technically a neutral sniffing position, but yeah. Okay, you want to pull back in there just a little bit, right, to go and open up the airway. Okay, again, kids are freaks. So if I were to do a full-on head tilt chin lift, right, I take the trachea, right, where I go bending down like this, okay, and I hyperextend it, and I do this with the airway, where we're kinking it going from down to up. Okay, by doing a neutral sniffing position, I pull back a little bit to keep it straight while we're flexing back on the head. Okay, now one way we can make that job easier is by taking a rolled up towel and placing behind their shoulders. Behind their what?
Shoulders.
Behind their what?
Shoulders.
Right, behind their shoulders. Okay, by doing that, I bring the chest and kind of bring it out a little bit, right, and that causes the head to tilt back a little bit more into a neutral sniffing position. If I were to put that towel behind their head, I'm going to cause it to flex down, right, and block that airway even more. Okay, so we take a rolled up towel, place behind their shoulders to bring that chest out more into a neutral position, neutral sniffing position. As far as their trachea, the trachea is a lot more flexible as well, hence why it can kink going up or down depending on positioning of the head. Okay, it's smaller because kids are smaller. So with that smaller airway, the object to block it doesn't have to be as big. And of course, kids like to put anything and everything they can where?
In their mouth.
In their mouth, okay, which can lead to a high risk of choking and therefore poisoning. Their tongue is also a lot larger in their mouth compared to that of an adult. Okay, so the tongue is more likely to be an airway obstruction. All right, and their epiglottis is longer, floppier, and more of a horseshoe shape. Right, so that too can also cause some airway obstructions. right? So we have to think about all these different airway aspects, right, when it comes to management, because of course airway is king. Now, as far as treatment of airway issues, we use the same things: positioning, sweeping or suctioning, and airway adjuncts. Okay, try for neutral sniffing position. If not, we'll still do the jaw thrust. Okay, if that doesn't work, we can try to sweep objects out. We can suction, and if we are suctioning, Erica, how long would I suction for if we have a pediatric? What about infants? Right. Okay, so we suction for the proper time. Always suctioning on the way out, never on the way in. Okay. So, as far as the differences in the airway, so here we have a pediatric epiglottis. So again, it sticks out a lot more compared to the vocal cords right here, and it looks more U or horseshoe shaped. Okay, and because it's longer and bigger, when it inflames, it's going to take up more of the airway, right? And if we cause it to spasm, it's going to block over that, and then we basically killed that kid. Our epiglottis is more of like a flap. Okay, so we're not likely to see more epiglottis issues compared to that of pediatric. Right? As far as smaller airways, we can see it's a smaller diameter compared to our trachea. Right there's the carina where it splits. Okay, but we can see that it's simply smaller because they're smaller. All right. Now, when it comes to respiratory issues, okay, just like circulatory problems, kids will compensate until they cannot do it anymore. Right? When we breathe, what do we have to use?
Intercostal muscles.
Muscles. Right? We use muscles to breathe. And if you use muscles for too long, what happens to them? They get tired. Okay. Now, for us, we have backup muscles in case the intercostals and the diaphragm start to fail. Right? So, Holden, what muscles do we use as a tertiary backup for adults to breathe? Traps. Okay, kids, especially young kids, don't have well-developed trap muscles. So if their diaphragm goes out, their intercostals will compensate for a little bit, and that's it. Okay, they don't have trap muscles they can use to compensate. Older kids, they will, but again, they're not as well-developed as ours, so they'll start tanking a lot quicker. Right, now when it comes to respiratory issues, okay, if a kid were to die from a medical cause, it's going to be respiratory in nature. Okay, so if the kid were to die from a medical cause, it's going to be respiratory in nature. Okay, it's not cardiac because generally kids have relatively healthy hearts. All right, barring any genetic conditions they have or anything they're born with, right? Kids are going to have healthy hearts because they don't have the time to eat like shit, right? And therefore cause cardiovascular issues like atherosclerosis, hypertension, arteriosclerosis. They're not going to have those problems. Right? Now, as far as early signs of respiratory issues, okay, anxiety, restlessness, agitation, just like early signs of shock, right? And with kids, again, it's very easy to overlook that because if a kid's scared, they're going to be overacting and crying and doing all that kind of stuff, right? So that's why if we see it or suspect it, we treat it. Okay, so we want to pay attention to things like other signs, so that's what we see here. So when it comes to retractions, right, those are relatively early to moderate signs of respiratory distress, okay, because the severe signs are really, really bad. Right, so we're going to see a drawing in of the intercostal muscles, right? So we can see an outline of the rib cage every time they breathe. Right, so again, we'll see the Croup Kid video later on, right? But we'll be seeing some of the retractions as well. Right, some older kids are going to have grunting respirations as well. So as they exhale, they're going to be breathing like that in an effort to try to keep the alveoli open. We talked about with emphysemics. Okay, once the alveoli collapse, are they relatively easy to reinflate? No. Okay, so it's pretty difficult to reinflate them. So with that grunting, it puts back pressure in the lungs to keep them inflated. Right? For emphysemics, they blow it like that to accomplish the same goal. Right? Other kids are going to have nasal flaring, especially younger kids. Okay, because younger kids primarily breathe through their nose. Right? So young kids are nose breathers. So to try to suck in more air, they open up those nostrils and try to suck in as much air as they can. Okay. Older kids are going to be sitting in the tripod position, so they'll have their hands on their knees bent forward, right, as they're trying to catch their breath, just like we saw with that emphysemic patient. Okay. Now, when it comes to kids in respiratory distress, okay, if the respiratory distress is not treated, they're going to go through a pretty consistent decline all the way through to cardiac arrest. Now, remember, the difference between respiratory arrest and respiratory failure, respiratory distress and respiratory failure. Respiratory distress, the kid is having a hard time breathing, but are they able to get enough oxygen?
Yes.
Yeah. Okay, so they're compensating for the respiratory issue. They got to work harder, but they're still able to get enough of what they need. With respiratory failure, are they now getting enough of what they need? No. Okay, so think about it as decompensating, right, for respiratory issues. Okay, so respiratory distress, if left untreated, then goes into respiratory failure. Because they're no longer able to get enough of what they need, this kid starts showing signs of hypoxia. And what is a late sign of hypoxia? Cyanosis. Doesn't matter to the patient. If they're blue, they're severely hypoxic. Okay, now if this kid's hypoxic, the body starts slowly shutting down and therefore causes bradycardia. Do kids have faster or slower heart rates compared to us as adults? Faster. Okay, now for us, right, if we have a heart rate of 48, it's not perfect, but it's okay for us. For a kid whose resting heart rate is like at 130, if they have a heart rate of 48, is that okay? No. Okay, that's way too slow. And remember, for them to maintain perfusion, they have to keep up decent cardiac output. Okay, where again, heart rate times stroke volume equals cardiac output. If that heart rate starts to tank, the stroke volume is not able to compensate because they have tiny little hearts. Right? So they're not able to move that blood, and eventually they go down to cardiac arrest. All right, Chris, can we do compressions on somebody who has a pulse?
I'm asking you, but I feel like there's a special.
Is it yes or no, sir?
Yes.
Yeah? Okay, who?
Someone who's choking, who's gone unconscious.
So what do we call that? What do we call that? Daisy? If they're unconscious and they're choking, what do we do for them? No.
Is it?
Brent?
Is it modified CPR?
I don't know, sir. Are you asking me or telling me?
I was asking, but modified CPR?
Right. Okay, it is modified CPR. Right? So what makes it modified? Besides the fact they may have a pulse.
Checking their airway when you're checking their airway before giving ventilation.
Right. We visualize before we ventilate. Okay, so we're going to take a look at the airway, right, to make sure the object's not in there before we provide ventilations. Okay, now again, we do that with the patient's unconscious and they're choking. So if they were conscious and we saw them go out, they more than likely will still have a pulse. Right? But can they lose that pulse?
Yeah.
Absolutely. But again, CPR is not going to change.
What was the modified visual?
We'll get to that later. All right. Who else can I do compressions on that has a pulse?
Someone who has a pulse but not breathing.
Mm-mm. George?
Say that again?
Who else can I do compressions on that has a pulse besides unconscious choking patients?
You're not breathing now?
Mm-hmm. No? Erica? No? Daisy? Back to you? No? Chris?
Repeat the question one more time.
Who else can I do compressions on that has a pulse?
Is there pregnant ladies you do chest thrust instead of abdominal thrust?
Mm-mm. Axel, back to you? No?
Do you do it to a patient who is conscious and choking?
Nope.
Neonates with a pulse rate of less than 60, or 60 and below.
Perfect. Right? Not just neonates, but pediatrics and infants. Okay? So pediatrics, infants, and neonates with a heart rate less than
60.
heart rate less than
60.
heart rate less than 60, right? And signs of poor perfusion. Okay? Now, as far as the signs of poor perfusion, that's what I like to refer to as an umbrella term. Okay? Because there's a lot of different things that would indicate signs of poor perfusion. Things like pediatric patients who are bradycardic and have an ALOC, or infant patients who are bradycardic and showing signs of shock, or neonates who are bradycardic and showing signs of like cyanosis. Okay, so any one of those things that go, oh crap, this kid's not perfusing properly, and they're bradycardic, okay, we start doing compressions. Because again, if the kid's got a heart rate of 48, is that okay for them?
No.
No. Okay, because the only thing that's going to happen after bradycardia is cardiac arrest, where their heart is stopped. Okay, now when kids die, again, from medical issues, it's usually what in nature?
Respiratory.
Respiratory. Okay, which means that if they're having problems breathing, they're going to become hypoxic. So they're already going to have low O2 levels as it is, right? And then because of that, the heart starts slowing down. Okay, brain's not getting perfused as well either, right? And so on and so forth. Okay, it's not a heart problem that tends to kill kids. The heart stops because it can't get enough of what it needs. That being what?
Oxygen.
Oxygen. Okay, so we really, really, really have to emphasize, right, doing compressions on peds with a heart rate less than 60 and signs of poor perfusion, because I want to get to the point where the heart does not stop, because it's a lot harder to restart at that point. Whereas when we're doing our compressions, we're able to go and take over function of the heart. Okay, and when it comes to compression rate, Brent, what is the compression rate for pediatrics or infants?
15 to 2.
No, that's the ratio. What's the compression rate?
One compression every 2 to 3 seconds?
Nope, it's compression rate.
One breath every 2 to 3 seconds.
We're talking about compressions, not ventilations. If I'm doing compressions on somebody, what's the rate, especially for peds and infants?
Is it 32?
Nope.
15 to 2?
Just talking to Ignacio. Not sure.
What's 120 beats per minute?
Just 120 flat?
No, isn't it like 100 to 120?
Right, it's 100 to 120 compressions per minute. Okay, the same I would do for anybody if I have to start pumping on their chest. Okay, you guys are confusing with the ratios, right? And again, I didn't give you any information about ratios because it will change depending on one person or two person CPR. If it's one person, our ratio is always what?
30 to 2.
What is it?
30 to 2.
What is it?
30 to 2.
Whereas if we have two person with peds and infants, it's what?
15 to 2.
15 to 2. Okay, but the compression rate is always the same. 100 to 120 compressions per minute. Okay, and we do that, again, regardless if they have a pulse or not. So, when it comes to breathing problems, okay, we have to ask ourselves the same question when we get to B, that question being,
Does my patient need oxygen, and if so, how do I administer it?
God, that was terrible. What is it?
Does my patient need oxygen, and if so, how do I administer
Right,
it?
and if they have chest pain, shortness of breath, ALC, major trauma, the answer is yes. Okay, now when it comes to administration of O2 for kids, it doesn't change. Okay, the only difference is the size of the equipment. Okay, and as some of you guys found out the hard way, right, a pediatric non-rebreather mask is not the same as the adult non-rebreather mask simply because it's too what?
Small.
It's too small. But as far as setup and operation, it's all the same. Okay, you take your pediatric NRB, hook it up to the Christmas tree, dial into what flow rate?
15
liters.
liters per
You
minute.
take your, place it inside the mask on top of the valve, let the bag inflate, and you place it on their face. Okay, so setup, operation, flow rates, all that stuff is the same. Okay, we'll come back to the slide in a second. But even percentages of oxygen they get, it's all the same. Okay, so when we talk about administration of O2, the numbers are the same. The numbers do not change whatsoever. The only thing that changes is the size of the equipment. Because these kids are smaller, the equipment is
Smaller.
Right? So, going back, there are other alternative methods to giving the kid oxygen because not every single kid is going to tolerate a non-rebreather mask that's hissing in their face. Okay, so what we may have to do is administer oxygen via the cup method. Right? It's an alternative form of kind of blow-by technically, right? But we're still getting it close as we can to their face. And the reason why we use this is because the kid is more familiar with a cup than they are with a non-rebreather mask. Right? So they're able to let it get a little bit closer to their face. Right? We can even have mom or dad administer it because the kid trusts mom or dad. They know they're not really going to do anything that hurts them. So they'll give them the cup. Okay, I'm familiar with this thing. So what we do is take a disposable cup, shove some tubing into the back, seal it off, give it to them, and we can go and administer oxygen that way. Another way of giving blow-by is with the O2 teddy bears. Right? Now the theory with this is kids love teddy bears, so they grab it and they want to cuddle it and hold it like that. Right? As a little O2 vents, you're administering blow-by oxygen. Okay, I'll let you use your imagination as where you hook up the tubing, but as far as where the actual oxygen comes out of, right, it's like a little Care Bear where it's coming out of the belly. Right? So we can go and give oxygen that way, but if they're critical, right, we just go ahead and just give them oxygen the same way you would for adults. Now for circulation differences, okay, again, these kids are more reliant upon cardiac output to maintain perfusion. So they have to constantly move that blood around their body at any given time. Hence, they have faster respiratory rates and faster ventilation rates, or heart rates, compared to us as adults. Okay, their blood pressure is going to be a little bit lower, right? Because they're not as dependent on that blood pressure. Okay, when it comes to shock, they're going to compensate the exact same way we do. Okay, so they're going to cause vasoconstriction, bronchodilation, tachycardia, tachypnea. Okay, when they activate their sympathetic, they do it the exact same way that we do. And whatever can cause shock in us can cause shock in them. Okay, so they're subject to the same types of shock: hypovolemic, right, obstructive, distributive, not so much cardiogenic, but again, kids with certain heart conditions, that can be the case as well. All right, and treatment and management is all the exact same. And we'll talk about that a little bit later on in the lecture. Now, as far as blood pressure, okay, we don't have to take any kids that are less than 3 because are they dependent on blood pressure for perfusion?
No.
No. Okay, but we're going to use the assessment triangle to be like, okay, this kid seems to be doing all right. As I walk into the room, the kid looks at me and stares at me, and he's sitting upright. Okay, appearance looks fine. Okay, the kid's crying as I walk in, so I know they got a patent airway. I'm not seeing signs of retraction. I do hear a little bit of stridor though, right? I'm going to go and check their skin signs. They're a little flush, a little dry, right? Okay, and mom or dad saying they have an infection. So, kid's sick, but not critically sick, right? Okay, all right, so let's take them to the hospital and get evaluated. But if I have a kid who's just laying there in bed, not doing anything, is that cause for concern?
Yes.
Yes, because again, kids are always going to have energy to run around when they're sick. And if they're staying in bed doing what they're supposed to, that's not a good sign. All right? Now, if the kid is critical, then we want to go for the blood pressure, right? Because they don't have the energy to fight, might as well just take the blood pressure to get the most accurate set of vitals. Okay? Because obviously, kids that are less than 3, they don't know what's going on. They just feel pain and uncomfort, right, when we start taking their blood pressure. Now, as far as cap refill, okay, again, cap refill is a decent sign of perfusion for kids that are less than 6 years old. Okay, so for those younger kids, if I check delayed cap refill, I already know they're in what? Already know they're in shock. Okay, if that only applies to kids that are less than
6.
Kids that are less than
6.
Right, so you got a 4-year-old kid, right, with a history of nausea and vomiting for the past 2 days, and you got delayed cap refill. Ah, crap, this kid's in what?
Shock.
What kind of shock?
No.
Non-hemorrhagic.
Right, non-hemorrhagic hypovolemic shock, right, because of vomiting and diarrhea. Okay, and do kids get sick a lot?
Yes.
Do kids have vomiting, diarrhea a lot?
Yes.
Yes. Okay, so that's a very common concern we got to think about for kids. That infection, of course, can go widespread, and then what kind of shock is that?
Septic.
Septic. What kind of shock?
Septic.
What kind of shock?
Septic.
Right, and we have to worry about that in kids too.
Kids younger than 6, if they're cold, will cap refill also be delayed? Or?
Yeah. Right, but if they're not in any type of extreme environment where they don't do so well anyways, right, that's going to an indicator of shock. So, when it comes to their skin, right, as I just said, kids don't do well in extreme environments. What other special patient population doesn't do well in extreme environments? Geriatrics. Okay, and then, of course, those that are sick and those that are injured. Right, now as far as kids, one reason as to why they don't do well in those extreme environments has to do with the thickness of their skin. Right, kids have relatively thin skin compared to that of adults. Right, so when it comes to cases of them being cold and hypothermic, right, there's not as much insulation for these kids. Right, also younger kids like babies, they don't have the ability to shiver. Right, so little tiny infants can't shiver to generate their body heat. Right, which is again the main way that we generate body heat. How else do we generate body heat, or at least try to compensate for cold?
Breathing?
No. Well, that's one way, but what else? Another main mechanism besides shivering.
Sweat. Oh.
Wait.
So how else do we compensate for heat loss? So we shiver to generate more heat. What else?
Vasodilate?
No.
Vasoconstriction.
Right, vasoconstriction.
Shunt it back to the core.
Exactly. Okay, so the other mechanism is what?
Vasoconstriction.
It's what?
Vasoconstriction.
Right, vasoconstriction. Okay, again, that's why in cold we have delayed cap refill, right? Because our blood vessels are shunting from the extremities to bring that warm blood back to the core of the body to make sure we have a nice core temperature. Okay, kids, right, don't really, they can do that, but they don't have the ability to shiver. That's why in the wintertime, infants are always bundled up because they can't generate their own body heat. Now, on the flip side, okay, if it's too hot, these younger kids don't have the ability to sweat, okay, because their sweat glands are not mature enough to actually produce sweat. That's why now in the summertime, babies are pretty much butt naked, right, as they just simply radiate body heat. Okay, and that's why kids who are left in hot cars do what?
Die.
Pretty damn fast, okay, compared to that of an adult who'd be locked in that same car, okay, because they just overheat, right, and they have no way of cooling themselves down. Okay, and we'll talk about geriatrics tomorrow as to why they don't do so well in those extreme environments either. Okay, but with these kids, they haven't developed those mechanisms to compensate yet. Freaks. So, as far as their skin, when it comes to burns, okay, because it's thinner, it tends to go deeper a lot easier. So whatever's a moderate burn for us will be critical if these kids are under the age of
5.
5. Under what age?
5.
Under what age?
5.
But for geriatrics, over the age of
55.
55. Okay, so we'll be covering that as well in a little bit. Now, as far as the airway, again, we take a rolled up towel, place behind there,
Shoulders.
behind there,
Shoulders.
to bring that chest up and out. Okay, to bring it into a more neutral sniffing position. So I'll show you guys in a little mannequin here. All right, but it's going to go ahead and show why it's going to be a bit easier. So as far as taking the kid, okay, we'll say my hand is a rolled up towel. If we find the kid down like this, take that towel, place behind their shoulders, and by lifting it up, okay, it brings the head back a little bit into a more neutral sitting position. Okay, so here, neutral, right, pulling back, more of a neutral sitting position. Now I don't want to do that head tilt chin lift, right, because then I take that airway and I kink it up like this, and we block it off, right? So we want to make sure we're going back just a teeny tiny bit, okay, to let that towel do most of the work, right? Then we can use our hand, perform a little bit more of a hyperextension, and that's about it, right? Now as far as doing compressions, okay, if we're by ourselves, we use a 2-finger technique on one hand, and I can use my other hand to hold the BMV and hold that airway. That we don't have to keep going back and forth, putting it up, putting it down, all that kind of stuff. All right, but we take our rolled up towel there. Now, as far as choking, okay, is choking common in kids?
Yes.
Because they put everything and anything they can where?
In their mouth.
In their mouth. All right, and these young kids, again, don't know how to maintain their airway. Okay, since their trach is a lot smaller, the object to block it doesn't have to be that big. Now, as far as recognition of a patient who is choking, okay, they may have an ineffective cough if they're a little bit older. Right, and that's the first thing we try to do to somebody who's choking, is encourage them to cough if they have the ability to do so. All right, but once they can't, now we have to start taking action. In the case of infants, they may not be able to cry, or they may have a very soft cry. Okay, so they cannot cry, or they have a very soft cry. That will be an indication of airway obstruction. We may also hear stridor, and we typically hear stridor upon inhalation. So if this kid or person were choking on something, you hear that as they're inhaling. Of course, it can go all the way down to loss of consciousness, where we have to do what kind of CPR? What kind of CPR? Where we visualize before we ventilate. Okay, so we take a look at the airway first before we start providing ventilations to see if that object came out. All right. Now, in the case of conscious pediatrics, okay, we take a knee and we start performing abdominal thrusts. Okay, so in the case of pediatric patients, we're going to go and take a knee and start doing abdominal thrust until they either cough the object out or they go unconscious. If they go unconscious, we start what kind of CPR?
Modified.
Right. And if they do cough it out, cool. We just run our assessment and keep going from there. All right.
After they get the object out of their throat, would it be good to give them like water or something for their throats and so agitated?
Nope. We'll just give them oxygen and that's about it. Yeah. All right. So, Brent, my baby's choking.
Okay. Oh no. So everyone can see. I'm going to take a knee. I don't see anything. Start with the back.
My baby's choking, sir. I don't know. I'm freaking out.
Your baby's choking.
Yeah.
Oh my gosh. I wanted to
Please
do the
save it. I don't want it to
5-5.
die.
I wanted to do the 5-5 visualize. We
Anytime
just
you're
did
ready, sir.
modified.
Please save my baby.
Okay. 5. Nothing. Crying?
Nope.
No crying yet?
No crying yet.
Gotcha. 1, 2, 3, 4, 5. Visualize. Not yet. 1, 2, 3, 4, 5. Visualize.
My baby's sir. My baby's choking. Please help.
Okay, 5-5 visualize. Black strokes. One, 2, 3, 4. Oh no. 1, 2, 3, 4, 5. Visualize. Clear?
No.
1, 2, 3. Oh my god, that was bad. 1, 2, 3, 4, 5. What? Oh my.
Too late, sir. My baby's quadriplegic already.
Okay. Oh my god.
Well, same thing, 5-5 visualize. 1, 2, 5. 2, 3, 4, 5. Take the airway. Take the airway. 1, 2, 3, 5. Take the airway.
Alright, pass it down the line, sir.
I'll do the same thing differently.
All right, you do see the object. Now what? Pass it down the line, sir.
Maybe alert.
Yeah, maybe still conscious and choking.
5. Visualize.
Pass it down the line, sir.
Visualize. 1, 2, 3, 4, 5. 2, 3, 4, 5. Visualize.
Okay, you see the object. Now what?
Blind sweep.
Sorry?
I'm doing a blind sweep.
Oh, you're gonna do a blind finger sweep?
Yeah.
Pass it down the line.
Hey, still choking?
Yep. Hasn't died yet. I don't know how.
1, 2, 3, 4, 5. Visualize. Still choking. Still choking.
Yeah, let's say you see the object.
See the object. I would keep doing compressions until whatever's in the mouth comes out.
Give it to Erica. So I have a conscious infant who's choking. Please say it. Nope. Go and give it to Mr. Fox.
So it's conscious, baby?
Conscious infant. Yep.
Okay. So 1, 2, 3, 4, 5. 1, 2, 3, 5. And is it dislodged by now, or is it?
How would you know, sir?
You would visualize it, and
Right.
if it was, you would do a sweeping motion to get it out.
Okay, if you don't say anything. Okay, you do see the object.
Sweep there.
Right. Okay. Come on, baby, sir. So, as far as our 5-5 visualize, okay, we go ahead and do that. We 5 back blows, 5 chest thrusts, and then visualize the airway, and then we go from there. Okay. Now, as far as doing your back blows, okay, you want to support the baby's head. Okay, by taking your index finger and your thumb, grabbing the lower jaw, keeping that mouth open, right? Because if you face hug the baby like you were, sir, okay, right? If I were to clear that object, okay, it's going to hit my hand and possibly go right back where? Into the mouth, right? And now we're right back where we started, okay? So by keeping that airway open, if I dislodge the object, it's able to clear out, okay? Now, when you're doing your back blows, okay, they are firm back blows. What are they?
Firm.
Right, not this, okay, limp-wristed crap, okay? Like I say, this is the only time you can legally hit a baby, so take advantage of it, okay? So you want to go ahead and give 5 firm back blows, aiming right between their shoulder blades, okay? Do not worry about causing harm to this baby. Do babies have bones?
Yes.
No, they're mostly cartilage, okay? So it's often squishy, right? So if I were to do back blows, right, their bones are going to give a little bit. And even if I were to break something, can a broken bone heal?
Yes.
Can a blocked airway heal?
No.
No. Okay, so you want to go and do that, right, nice and firm, and keep that head low so you can use what to your advantage? Gravity, right? 1, 2, 3, 4, 5. And you want to support that head as well, okay? Because if you guys are doing that limp wrist crap, okay, the baby's head starts doing this, right? And then we start causing cervical spine injuries as well as contra injuries that are the same as shaken baby syndrome. Okay, so you need to make sure you're holding onto that head, okay, as you're doing those back blows to prevent that head from whipping back and forth. Right? Once we flip it over, put his trachea back in here. Right? Once we go and flip that baby over, okay, we want to do 5 chest thrusts, okay, right between their what? nipples down the middle of their
Sternum.
sternum. Okay, some of you guys are going down here by the patient's abdomen and pressing down over here. It's not what we do. Okay, we go and provide chest thrust, right, as we're trying to clear that object out. 1, 2, 3, 4, 5, and then we take a look in the airway. And if we see the object, then we go and sweep it out. Okay, again, we don't do any blind finger sweeps. Okay, because again, you saw the object, like, I'm going to do a blind finger sweep. Okay, we don't do that. Right, we only visualize and sweep it out, right, at that point once we actually see it. Alright, so as far as our 5-5 visualize, okay, guess what we're going to go and knock out for those conscious infants who are choking. Alright, so when it comes to modified CPR, alright, we're going to go and perform compressions, and then we visualize before we ventilate to see if the object came out. And if the object did come out, we sweep it. If I don't see it, do we do any blind finger sweeps?
No.
No, right? We just keep going back from where we started. And if we end up losing the pulse, then we call for what?
AD.
And then we just keep doing modified CPR. Okay, and then once the AD arrives, then we go ahead and defibrillate the patient. All right, now when it comes to our pediatric BLS, all right, Brent, what is the definition of a pediatric patient when it comes to the purpose of BLS? So things like CPR and rescue breathing.
Between the ages of 1 and showing signs of puberty.
Perfect, right? So between the age of 1 and puberty, okay, we're going to be doing pediatric BLS, right? Ramon, what about for the AED? What's the definition of a pediatric patient?
Would it be years 1 through 8?
I don't know. Would it be?
Yes.
So, what is it?
It would be any pediatric who's in the age of 1 through 8.
Right. Okay. So a kid between the age of 1 and 8, we're going to be using pediatric pads. Right. So if I have a 10-year-old kid who hasn't hit puberty, what kind of CPR are we doing?
Pediatric CPR.
Pediatric CPR. What kind of CPR?
Pediatric.
Because they're 10, but they haven't shown any signs of puberty. Okay. But what type of AED pads would I use? Adult, because they're over the age of 8. Okay. And we have to note the distinction between the two. Right? Because I can have to do pediatric BLS, but have to use adult AED equipment. Now, if I don't have pediatric pads, can I use adult pads? Yes. Okay, so if the pediatric pads are not available, then we can use the adult pads. But is it going to be the same and the opposite? Can I use peds pads for an adult? No, okay, because there's not enough energy coming out of that for an effective fibrillation for us, but we have more than enough for the pediatric patient. Okay. Now, as far as AHA, again, they're the ones that say if the heart rate's less than 60 with signs of poor perfusion, what do we start?
CPR.
What do we start?
CPR.
What do we start?
CPR.
Okay, because we have to try to get that heart to keep pumping before it stops. Right, and that is pediatrics, infants, and neonates. Okay, and we'll talk about neonatal resuscitation when we talk about childbirth. Because Matt was saying, if something goes wrong, do you have to know what to do and when to do it?
Yes.
Okay. Now, as far as other things per AHA, if we have an unwitnessed pediatric arrest, so nobody saw the kid go down, and we're off duty, okay, then we have to go and start doing 2 minutes of CPR first before we go call for help. Okay, off duty. Okay, so let's say you're at a party or something like that, right, and you go into the room and you see an unconscious kid on the floor who doesn't have a pulse. We do 2 minutes of CPR first, and then we go call for help. Okay, does anybody know why we do that? Go ahead.
Because you don't know how long they're down for, and since their circulation runs off of their heart pumping, you need to make sure they have proper perfusion and proper blood flow throughout the body. Circulation.
Well, that's why we do CPR for anybody. But as far as them being down and not knowing how long they're down for, what are we really concerned about that?
The brain.
Because it's not getting enough what?
Oxygen.
Right. And when kids die, what kind of problem is it usually caused by?
Dead. Oh, respiratory.
Respiratory, which means they're already what to begin with?
Cardiac.
No. Think about that decline.
Oh, they're already hypoxic.
Right, they're already hypoxic. Okay, so because these kids generally die from a respiratory issue, okay, they're going to go down that different chain. Respiratory distress, that goes to respiratory failure, that causes hypoxia, bradycardia, and then cardiac arrest. So again, that second stage of hypoxia, they already don't have a lot of oxygen to begin with. Right, so that's why they're dead. And again, we don't know how long they've been down for, so we don't know how long they've been hypoxic. Okay, so by doing 2 minutes of CPR first, we can at least pump some blood, give some oxygen before we go leave the patient and call for help. But if we are on duty, okay, we work them up the same way as you would any other cardiac arrest patient, which means you go right to work.
Quick question, because I know that you can kill people with adult AD pads. Can you kill someone with peds pads?
Well, they're already dead to begin with.
Well, no, I mean, like, you know how you say if someone's touching a patient and you shock them with adult pads, you can kill them. Can you kill people with peds pads?
It depends.
Or is it just like a tickle?
It's not going to be the tickle, right? It's only a tickle with the implanted defibrillator, right? Because it's putting out just a couple of joules of energy, whereas the PEDS pads are giving out between 50 to 75.
So it's like a taser.
Yeah, it's going to hurt, right? That's why we still want to go clear anyways. Okay, now if it's a witness full arrest and we're still off duty, then we just go and work them up the same way you would, right? So you go call for help, call for EMS, because again, we're off duty, because otherwise we are EMS, right? So we go and call for help, and then we go from there. Now, as far as infant CPR, okay, our depth of compressions is going to be about an inch, inch and a half, or 1/3 the depth of their chest. Okay, so for infants, we push down about an inch and a half, or 1/3 the depth of their chest. Okay, and when I push down 1.5 inches, the chest has to come back up. How far? 1.5 inches, right? And Axel, what do we call that? If I push down a certain amount, let it come back up, that same amount.
It's not a recoil?
Is it?
Yeah, it's recoil.
All right, we call it chest recoil. What do we call it?
Chest recoil.
Right, and whenever we do compressions, we have to allow for complete chest recoil. So however many inches I push down, I got to make sure the chest comes back up that same amount of inches before I go and I press back down again. Okay, because if I don't let that chest come all the way back up, let's say go down 1.5 inches, but only come up 1 inch, right? We're 1/2 inch short, so the heart's not going to refill all the way before I go back and press it again. Okay, as far as our rate, same for everybody, 100 to 120 compressions per minute. Okay, before it used to be different numbers, and the reason why they keep it around this range now is to kind of find that happy medium between all the different age groups, right? For us, yeah, 100 is the maximum, 120 is a little tachycardic for us, but for these kids, that's kind of about where they need to be, right? So if we're pumping a little too fast for adults, it's not really that big of a deal as long as we're allowing for that complete chest recoil, right? But for kids, we need to have it a little bit quicker. Now, as far as the ratio, okay, that's all dependent on how many rescuers that we have. If I'm by myself for any patient, what's our ratio? 30 to 2. But obviously with peds and infants, it changes to 15 to 2. And when we talk about neonatal CPR, it's an entirely different ratio altogether. Okay, but we'll talk about that when we get there. As far as our technique, before moving on, if I'm by myself, I use a 2-finger technique to go and knock out my compressions. Now the benefit of the 2-finger technique is, again, I only need one hand to do compressions, and I use the other hand to go and maintain the airway into what position? No, neutral sniffing position. So again, 2 fingers, 1, 2, 3, 4, 5, 6, 30. 1, 2, and I'm right back on the chest. Okay. Whereas if I were to do this, then I have to go pick it up, do all that kind of crap. It's a waste of time. Or I can just use that one hand, maintain that CE grip, maintain that sniffing position, knock out my compressions, bam, bam, right back to it. Okay, we got to be really careful about over-ventilating too, because it doesn't take a lot, okay, to inflate the lungs on a kid. Right? So we got to make sure we're not causing gastric extension in those pediatric patients. Now, if I have a partner, okay, we're going to switch it up. We now use our 2 what? Thumbs, okay, to knock out those compressions. So if we're doing the 2-thumb technique, the compressor will be at the baby's feet, the ventilator at the baby's head. So they use their hands to grab the baby like a video game controller, and then use their thumbs to go ahead and compress. And how many compressions are we doing? 15. After that, the partner is going to go and provide ventilations. Okay, 1, 2, and then we're right back on the chest doing compressions again. Okay, now the reason why we switch it up, okay, has to do with kids and their ventilations. Do kids breathe faster or slower than we do? Faster. Okay, so by doing a ratio of 15 to 2 instead of 30 to 2, right, I'm basically doubling the amount of ventilations they get in the same time frame. Okay, because I'm stopping to ventilate twice as much. Okay, now as far as our technique changes, right, as you guys hopefully figured out on the first day of class, what's easier to compress with, 2 fingers or 2 thumbs? 2 thumbs. Okay, but our positioning, right, has to be at a certain spot. Okay, I have to be at the baby's feet to properly grab onto them and do my compressions the right way. Okay, now the reason why AHA doesn't like us doing it by ourselves is because we have to get up, walk around, take a knee, pick up the BMV, ventilate, put the equipment down, get up, walk around, take a knee, grab the baby, and start doing compressions. Okay, and how much time do I want to interrupt my compressions for?
None.
It's less than 10 seconds. Okay, so we're not going to be fast enough to do that consistently every single time on 100% of the patients. Okay, and no, you're not going to have the dead baby breakdance in front of mom or dad, right, spinning around like that as we go. No, we just spin slowly. No, we don't play with dead bodies. I don't know what you do at home, but that's not what we do here. Okay, so, right, as far as pediatric patients, okay, our depth of compressions is about 2 inches. What is it?
About 2 inches.
What is it?
About 2
Right,
inches.
it's about 2 inches. And ironically enough, AHA is very specific about you saying about 2 inches. Okay? We're just going to follow that diameter of 1/3 the depth of their chest. Okay? Now, as far as techniques, right, we're going to do either one-handed compressions or two-handed compressions based on what you feel is a small kid versus what you feel is a big kid. Okay? So it's completely subjective, right, in that sense. Okay? So if you have a smaller kid, let's say the kid's 18 months, you can go ahead and do one-handed compressions to get to about that 2 inches. Okay? If you've got a bigger kid, let's say that 10-year-old kid who hasn't hit puberty yet, you're probably going to have to use 2 hands to go and compress. Okay, and that's completely subjective. Right? If you're really, really big, that same 10-year-old kid, you can easily get away with doing one-handed compressions. Right? So it's entirely subjective as to, again, what you feel is a small kid versus what you feel is a big kid. All right, we're going to go and have the same ratio changes. Right, so again, if I'm by myself, 30 and 2. If I got a partner, 15 and 2. Okay, but our technique doesn't change when we have multiple rescuers. Right, we just go and knock it out at these certain ratio. So with the AED, right, our AED pediatric pads, okay, typically one in the front, one in the back. Okay, so we sandwich the heart anterior, posterior. Okay, and we go ahead and follow the AED instructions. All right, now just a little pro tip: whenever you see anything that has a teddy bear on it, either on equipment or protocol, that means it's for who?
Kids.
Because we just assume the kids love
Bears.
teddy bears. Okay, so that'll let you know. Now, as far as other pediatric pads, probably can't see in this picture, but they have what's known as a pediatric dose attenuator, which is basically a regulator for the amount of energy coming out of that AED. Right? Instead of the 300 joules it comes out for an adult, it'll be somewhere between 50 to 75, depending on the AED pads themselves. Okay? That's why we can't use the peds pads for us, because it's not enough energy to be able to deliver an effective shock to the heart. But for kids, can you use adult pads for them?
Yes.
Yeah. Okay, because they're already what?
Dead.
They're already dead. Can you be any worse off than that?
Nope.
No. Okay, so we just put the adult pads, and the adult pad placement, the pad that goes here is the anterior pad. The pad that goes here is the posterior pad. Okay, so we put those pads on, plug it in, and you fry the fucker, right, as we prefer with. Bang.
I know we don't want them to be dead, but is there any damage we can cause by if they're really in the
They're gonna have burns anyways.
Okay.
So, yeah,
It's electricity.
it's gonna burn the patient.
Can you repeat how many joules you get shot with versus the kids?
300 versus 50 to 75.
So if you get a tizzy, that's 1,000 joules.
It's not joules, it's
50,000
watts.
Oh.
It's all watts. Yeah, joules is a measurement of energy. I don't know what the calculation is between
So,
joules and
yeah.
watts. It's a lot.
Something.
Double
So-
up.
No. All right. So,
Double.
as far as pediatrics, again, definition of 1 to 8 years old. Okay, now if you don't know the kid's age, just look at him. Okay, this kid looks like he's about 8, maybe 9. I'm going to go ahead and use adult pads, right? Or this kid looks about 4. I'm going to use pediatric pads. Okay, now if you got a big ass 6-year-old who looks like he's 9, well, the kid looks like he's what?
9.
So we'll zap him with the adult pads. Or you got a small 9-year-old, yeah, it looks like he's 7. We use the pediatric pads.
If you are uncertain about the age, like say that you have a big ass 6-year-old who looks like he might be 9, is it even if there are 9-year-olds, say, would it at all be harmful to do one on the back, one on the front, just in case they are under the age of 8?
Well, the pediatric pads won't fit on most.
Well, I'm saying, like,
for adult
so
pads.
say they are gonna, like, it's a big ass 6-year-old and they think they're 9, but like they could, you don't know which one it goes to. Would it be safe for us to just put one on the front, one on the back?
It doesn't matter. The adult pads are too big to put traditional placement on a kid. Even if they're a big ass, 6-year-old, it's still too big.
Oh,
Yeah. Okay, so we just go anterior posterior.
Okay.
All right. That's why, again, even if they were smaller kids, we still go and do that. All right. So when it comes to OPAs, okay, measurement of the OPA is the exact same as it is for adults. So we go from the anterior portion of the
Ear.
or the
Tracheus.
to what part of the mouth?
Corner.
Corner of the mouth, or we go from which part of the jaw?
Corner jaw.
No. Angle of the jaw to what part of the mouth?
The middle of the mouth.
Middle of the mouth. Okay. Of course, you guys screwed that question up. Okay. Angle the jaw to the middle of the mouth.
We're talking about.
Right. Yeah, sure. Right. So we go and measure that out. Now, as far as insertion, okay, we don't have room for all that sweeping and swooping inside the mouth like we do for adults. Okay, because kids are freaks, and they got a big old fat tongue in the mouth, so where it just takes up too much space to be able to do that. So instead, we'll take a tongue depressor, pry up the mouth, and then drop the OP straight in. All right. If I don't have a tongue depressor, you can potentially use a smaller OP as a hook and open up the airway, and then drop it down that way.
Use your finger.
No.
Put your finger.
Are the OTAs disposable?
Yes.
Okay.
Yeah, we don't share with the patients.
Good.
Okay. So, I mean, they're dead. They're not going to complain anyways. But, right. We go and drop that in. Okay. And it's still going to do the same stuff. So, same indications, right? To create and maintain a patent airway in an unconscious patient with no
Gag reflex.
In conscious indications, they have a
Gag reflex.
And if they do have a gag reflex, what do we use?
Nasolabial
NPA. Okay. Now, as far as measurement NPA, same deal. Anterior portion of the earlobe or tragus to the side, tip, or septum of the nose. Okay. And we also have to take a look at the width of the nostril as well. And if they still have them, we can use the patient's what? Pinky, right, to go and hold it up and be like, yeah, it's about the same size. Now, as far as the contraindication for NPA, again, it's just what kind of patient?
Infants.
Infants. Okay, infants are the only contraindication for NPAs, right? Because the NPA has to be a certain diameter to work, and infants are just too damn small to make that happen. Okay, so we forgot how old is the kid. Oh, they're 10 months old? Oh, well, we can't use the NPA, right? And that's that. Okay,
Damn, that sucks.
pretty much. All right, so then we just go and provide the airway as best we can, and we'll just continue from there. So when it comes to rescue breathing, right, ventilation rate, 1 breath every 2 to 3 seconds for peds and infants. And we do that if they have but they're just not breathing. Okay, and again, when kids die, it's usually because of what type of problem? Respiratory, right, when it comes to medical issues, it's respiratory. Okay, so they may experience apnea before going into cardiac arrest. Okay, going all along the lines with that decline. Respiratory distress, and then respiratory failure that leads to
Cardiac
arrest.
no, eventually, but steps in
hypoxia.
between. Hypoxia, which then leads to
Bradycardia.
bradycardia, which then leads to
Cardiac
again,
arrest.
you have to know that decline so I can see where they're at along that chain. Okay, hey, this kid's looking blue, right? So I know that they're in their earlier stages of it, but it's not going to take long before they start crashing. Okay, or crap, this kid's bradycardic, he's got a heart rate under 60, and he's cyanotic. We got to start doing what?
Ventilation.
No.
Modified CPR.
Kid's got a heart rate under 60 and he's cyanotic. Right. Okay, because he got a heart rate less than 60 and they're showing signs of poor perfusion. Okay, so we start doing compressions on them. Question.
Every 2 to 3 seconds, is that inhale, exhale, so like squeezing and opening?
No, it's squeeze, 1 breath, and then we wait 2 to 3 seconds and we do it again.
Okay.
And then we wait 2 to 3 seconds and we do it again. All right. So we want to do that just up until they have adequate chest rise and fall. And to help keep that airway open, what can we place where?
A towel.
The towel underneath their shoulders, right, to
Shoulders.
bring them back into that neutral sniffing position. So, as far as altered mental status, okay, whatever causes us to be altered can cause them to be altered as well. And we use that same mnemonic of AEIOU tips. Okay, as far as alcohol, right, can kids get into alcohol?
Yes.
Can they be giving it intentionally?
Yeah.
Yeah. Okay, parents may be doing that, right, to shut that kid up so they can go ahead and get a night's rest. Obviously, that's not how parenting works. Okay, so we have to worry about that. We don't have to worry about withdrawal from alcohol because these kids aren't going to be chronic alcoholics, right? So we don't have to worry about what condition.
Delirium tremens.
Delirium tremens, right? Where again, that kid's going to be suffering from withdrawal, right? Anaphylaxis obviously can happen in kids. Anoxia can happen in kids. They can have electrolyte issues. They can have epilepsy. Okay, so again, all of the same things can be present in pediatrics as they could be in us. Okay, and we treat them the same. Now, as far as pneumonia, okay, pneumonia is the leading cause of medical death in pediatrics, okay, but not the leading cause of death overall. Number 1 killer of kids overall is trauma, specifically head trauma. Okay, so head trauma is the number 1 killer overall for pediatrics. But if it's a medical death, it's going to be caused by pneumonia. And pneumonia is what kind of problem? Respiratory. That's why we say if a kid were to die from a medical issue, it's respiratory in nature because pneumonia is that number 1 killer, right, medical killer of kids. So with pneumonia, the kid may have rales, they may have rhonchi, just depending on the cause. Okay, they'll have those fever-like signs or symptoms. They'll have respiratory distress. Okay, so our treatment is just going to be supportive for those pediatric patients. Okay, we've kind of brought this up before, right? But the likelihood of us dealing with a critical medical pediatric patient isn't all that high compared to an adult patient. Because as soon as the kid gets the sniffles, where do they go?
Hospital.
They go to the doctor. At the very least, a doctor. Okay, so they go, okay, kid's got sniffles, started last night. All right, here we go. All right, they go and treat them. That's it. But if we get called out for a medical emergency, it's usually pretty what?
Bad.
It's usually pretty bad. Because again, they've skipped that treatment initially, right? Let it get worse and worse and worse and worse. And now, crap, mom or dad have to call us. All right? As far as asthma, very common in pediatrics, because again, that's the most common age range that we see it. And asthma is what kind of system response?
Immune system.
That only triggers what system?
Respiratory.
Respiratory. Okay, so we only get the bronchospasm of the whole immune system reaction. Okay, we don't get vasodilation, we don't get anything else, just the body's trying to protect the lungs by shutting down the airway a little bit, giving them wheezing. So as far as medications, Daisy, what medication could we possibly assist with the administration of for this kid?
Could be
Not if it's really, really bad. So what other medication could we give them? It's not as bad. Erica?
albuterol.
Right. And what is the contraindication, or what are the contraindications for albuterol?
If they can't like follow our motion commands,
Okay.
and if they cannot maintain their own airway.
Obviously, but what else?
Altered level of consciousness.
To what point? You've already said it. They can't do what?
Follow motion commands.
Simple commands.
Simple commands.
But what else? So they can't follow simple commands or
Oh, they have already taken the max dose.
right. Okay, so they've already taken their max dose. Right? Now as far as pediatrics, who would I ask if they've taken their max dose?
Parents.
Parents, right? And Erica, let's say I'm a parent. How would you know if they've taken their max dose? What questions do you have to ask?
Dice.
We dice out the medication. But what questions would we ask? Again, let's say I'm the parent of this kid.
Oh, 6, right?
No.
No.
Darge?
I'm drawing a blank right now.
What was the question?
How would I know if the kid succeeded their max dose?
If you've already asked the parent,
Okay, so I'm the parent. What would you ask me?
has your kid taken a pump already?
I'm sorry?
Has your kid already taken a pump from their inhaler?
Yeah.
How many?
They took about 6.
How many does the doctor recommend that they take?
Like 3. Yeah. Okay, so how many can you take and how many have you taken? Right? And in the case of asthma, okay, do you think mom or dad are going to give them more before calling us?
Yes.
Yeah. Okay, so with pediatrics, right, we definitely have to ask that question, right? Especially if the kid has asthma and they're like, okay, it happens pretty frequently. We give them a little bit and it goes away. Well, they keep on administering. Okay, past the max dose, 1 or 2 more isn't going to hurt. We keep going. Crap, it's not working. Okay, now we need to call 911.
Is there any dangers that come with? Oh, can you overdose on albuterol? Or?
You can overdose on anything, but it's a lot that you have to take before you overdose.
Okay. Is there something like a more reasonable amount that can cause problems, or is it just going to be like?
It's going to be excessive amounts, like multiple times the amount they actually can take over prolonged periods of time.
Cool.
Right. So that whole they can give 3, right? But we giving them 6, it's not going to harm the kid. But
Okay.
we already know that it's not working after their prescribed dose. There's no point in us giving any more.
Makes sense.
Right. ALS, they may be able to give epi or albuterol, and we'll talk about that tomorrow. Right. But as far as the dosage, we just want to not exceed their maximum prescribed dose. We'll go ahead and give them the albuterol. Now, if albuterol doesn't work, then we can stick them with what drug? Epi, right? Because the other indication for epi is severe asthma. So severe anaphylaxis or severe asthma, those are the indications for epinephrine. Now, if we don't have the pharmacological treatments available, then we can use our BMB. Okay, because the BMB applies positive airway pressure. So what we're going to do is we're going to take the BMB, and for pediatric BMBs, we have what's known as a pop-off valve, known as a what?
Pop-off valve.
Right, which is basically a pressure release valve on this thing here. Okay, normally I want it open, so when I ventilate, okay, all that air is coming out over here. But as I shut it down, let's see if this one actually works. If I grab the wrong one. Yeah, I'm grabbing a different one. It's not quite working. But if I shut it down, okay, we're not able to vent out that extra pressure, all right, and therefore it's going to move all that stuff down the airway. Yeah.
So when you're doing it that way, I know that the bronchioles and all that is constricting.
Mm-hmm.
are you pushing the mucus in it down to the bottom of the alveoli when you do that?
So there's going to be a little bit of mucus production with asthma, but it's not enough to really cause too much of an issue.
Oh,
Yeah, because my main concern is to get the airway open so we can actually move air in there.
okay.
Right? So with the pop-off valve being open, right, every time I squeeze, again, all that extra pressure just gets vented out from the top. But when I close it, okay, it's not going to be vented out. So all that extra air, it has to go through the mask. Okay, and that's what we want. So we're going to go and place it over here, create a CE grip, and then I want to ventilate up until we get chest rise and fall, okay, and force that air through. Right? So as we go, ventilate it until we see it, right, and we'll just do what we need to do to open up the airway. Okay, so I'm going to pass this around for you guys to go and take a look at it. Right? With this, it's just a half turn in either direction, right, either opening it or closing it. Okay, this is a little pressure release valve where all gets vented out as well as the top. So what you have to do is simply close it with your thumb as you're pretty much doing a little CE grip on the mask, just pushing straight down, and then you ventilate just like that. And you'll feel the difference, right, with it closed and it open. Okay? So that's what we'll do if we don't have the medications available for this patient. All right, status asthmaticus. Do not get it confused with status epilepticus, because with status asthmaticus, there is no specific criteria to be met. It's just, we've given them all their albuterol, it doesn't work. Okay, that's status asthmaticus. So it's just a severe asthma attack, and that's usually when we get called out. All right, so we just want to go and manage the airway as best we can, provide ventilations using the pop-off valve, right, make sure it's closed, so that we can force open the smooth muscle, right, of the bronchi. With CPAP, we don't really use CPAP for kids because it has a high risk of causing air to get where?
In their potential space.
No, not in the potential space. In their what?
Oh, their
stomach, leading to what condition?
Gastric
extension. And you fill up that stomach with too much air, what's that kid going to do?
Vomit.
Right, they're going to puke. Okay, it's not like we're going to just blow out their lungs with CPAP, right? It's more likely to get to the stomach first, causing gastric extension. All right, with bronchiolitis, with these other infections, you don't have to worry too much about it because there's not much we do specifically for it. It's just a matter of looking out for signs of dehydration and whatnot with these kids. Okay, so it's the complications of the infection that we're more concerned about than the actual infection itself. All right, it's usually brought on by RSV. Okay, and RSV can be spread very easily amongst the pediatric and geriatric populations. Not so much within regular adults because we have relatively healthier immune systems, so we can fight off that infection a bit easier. Right, with croup and epiglottitis, right, croup, we have what kind of a cough?
Seal.
Right, that barking seal cough. Okay, whereas epiglottitis, we have the kid who's got excessive drooling. Right, both will have stridor, nausea, vomiting, right, fever-like signs or symptoms. Okay, but those are the differences. If the kid has epiglottitis, do we suction the airway?
No.
Do I insert OPAs?
No.
Do I throw the kid on the gurney?
Yeah.
No. Okay? Because any type of that excessive movement, right, is going to cause the epiglottis spasm and kill the kid. All right. With croup, however, can we be aggressive with airway management? Yeah. We can suction, we can drop OPAs, and yes, this kid we can throw on the gurney. All right, because nothing we do is going to exacerbate that issue and make it any worse. All right, so let me go and plug in the audio again. Might get a little feedback at the end. All right. So, again, that barking seal cough. It's going to have that higher pitch. And then as they inhale, there'll be stridor. And again, we'll be seeing some of the retractions right across, right around here, right just below the nipple line. All right, so see a little bit of retractions right around that region right there. All right, and right out here. So, with that, we just do whatever we can as far as airway management. When it comes to pertussis, that is going to be whooping cough. Okay, so that bacterial infection, just supportive treatments. Airway, breathing, circulation. And that's about it. All right, just make sure we're wearing proper BSI so that we don't get sick, because everybody's what?
Nasty.
Right, especially even pediatric patients. All right, when it comes to dehydration, okay, do kids get sick?
Yes.
A lot. Okay. Now, when it comes to dehydration, vomiting and diarrhea is the #1 cause of dehydration in kids. Okay. So for pediatric patients, vomiting and diarrhea is the #1 cause of dehydration.
You can give kids Pedialyte, right?
No. Okay. So they need it, but we can't give it. All right. What's up?
Why not?
Because we don't want to give kids anything by mouth. Because kids do what all the time?
Choke.
Okay. So we don't want to give them anything by mouth, but we do have to be mindful of vomiting, diarrhea. Now, as far as questions we want to ask, okay, we want to ask how many wet diapers has a kid gone through, so we can know if they've been peeing or pooping a lot more than usual. All right. So apparently 6 to 10 diapers per day is normal. That's average. Kids are expensive.
Mm-hmm.
Right? They're little shits, but they shit a lot. So, as far as changing, okay, we want to go and ask, okay, what's their normal? And let's say for scenario's sake, it's 8. Okay, so 8 diaper changes per day is the kid's baseline. When they're having diarrhea, they're going to get changed a lot more frequently. So they go from 8 to, let's say, 14 different diaper changes in that 1 or 2 days. Okay. Now, once they start running out of water, what's going to happen to that number? It's going to start going down. Okay, so it goes down, 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 down. Okay, cool, they're back at 8, but then it gets lower, lower, lower. Right, now the parents like, oh, you know, we normally change them 8, we went from 14, now we're changing them 5 times a day. Right, so kid's obviously dehydrated. All right, we also want to know what fluids the kid is taking. Okay, so what are they taking to replenish that fluid, like Pedialyte? Are the parents giving them that? Are they giving them juice or milk? All right, if the kid's old enough, water. Okay, so we want to know what they are taking to replenish that. Okay, what was the kid's weight before the symptoms had started? So usually, if they're not weighing the kid every single week or whatever, they may tell us what the last weight is when they went to go see the doctor, right? And then they'll just compare that to when they actually get weighed in the hospital. They'll say, oh yeah, we went for a checkup 3 weeks ago and the kid was 30 pounds, right? So 3 weeks ago, we'd obviously expect to be the kid a little bit heavier, but we get them to the hospital like, oh yeah, they're 27 pounds, right? So now we're like, oh crap, that's a fair amount of fluid considering they should be gaining weight instead of losing weight. When it comes to the kid being normally active, again, when kids are sick, do they have energy to run around?
Yes.
Yes. Okay, but if that kid is just laying there like they are here, that's not a good sign. Now, as far as where they're checking here, they're pinching the skin. What do we call that? We're assessing.
Pinting.
Well, that's what we're looking. That's what we don't want to see.
You're seeing if how dry the skin is.
Turgor. What do we call it? Turgor. What do we call it?
Turgor.
Right. So we're assessing turgor on kids. For them, we check their belly, not the back of their hand. Right, especially for infants because they got short little fat hands, so it's really hard to go ahead and check, right? But for them, we're going to go for the belly to check for tenting. Okay. Now, as far as ALS, they may have to go in and provide IVs, right, or even IO. What does IO stand for?
Osseous.
Intraosseous. Okay, where they have to drill into the bone, right, to give fluid via bone marrow. Okay. With kids, it's hard to get veins, right, because they're really, really small. So the medics just go, screw it, and they drill right to the leg, right? So we want to go and take a look at that. Now, the reason why kids get commonly dehydrated is because when they throw up, they may not know that, oh, I threw up, I have to replenish fluid, and I'm losing electrolytes. Whereas for us, we throw up, we're like, oh, damn, I got to go get some Gatorade, right, because I peed stuff up. Right, Rondo, there. Okay, so, again, it's talking about us. So, as far as patients, we don't use anything. Okay, no brand names for patient treatments. So, as far as that, okay, that's why that happens. Again, these kids, they go, ugh, Mommy, I threw up, right? And the parents have to be going, okay, well, I have to give the kid Pedialyte, right, to go ahead and replenish that stuff. So when it comes to signs of dehydration, okay, mild, right, dehydration, okay, is going to present with dry lips and gums, decreased saliva output, and a decrease in the number of wet diapers. Okay, so these kids just aren't as wet, they're not as drooly as they normally are. Right, so they start drying up a little bit. As far as moderate dehydration, okay, that patient's going to start to have sunken eyes. Okay, so the eyes start to sink in, just like SpongeBob here. That's why I put the picture in there. All right, so the eyes start sinking in a little bit. Kids are going to start getting sleepy and irritable, and they start to have that loose skin. Okay, so when they have poor skin turgor, right, now we know they're in the moderate stages of dehydration. As far as the severe stages of dehydration, okay, they're going to be cool, clammy, and have delayed cap refill. These are all signs of
shock.
Shock. Specifically, what kind of shock?
Non-hemorrhagic hypovolemic.
Yeah, non-hemorrhagic or metabolic because they're losing a lot of fluid, plasma. Right, so now they're in a state of dehydration. Okay, now these kids are cool and clammy because it's generally a little bit slower, so they still have a little bit of fluid to sweat out. Whereas heat stroke patients, right, again, they are sweating out to the point where they have no water left, hence why they are going to have what skin signs? Dry, hot, and flushed. Okay, So CRT, again, is cap refill time. And again, delayed cap refill time in kids that are less than 6, right, automatically indicates they're in shock. All right, they're going to have increased respirations, again, part of the sympathetic response. You're going to be breathing a little bit quicker. And they're going to have sunken fontanelles. Okay, so after the break, we're going to talk about fontanelles, right, and what they actually are, so we know what this means by sunken fontanelles. All right, so we're going to look out for those signs, right? And if we see them, okay, this kid's in different states of dehydration, there's really not much we can do. We don't give them anything by mouth. Obviously, we can't start IVs. But we go and assess this and be like, all right, patient showing these signs, and then ALS or the hospital will take care of it, whatever they got to do. All right, remember, number one cause of dehydration in kids is
Vomiting or
vomiting and
diarrhea.
diarrhea. All right, so go ahead and come back at 6, and then we'll move on to the rest of the stuff. Okay, that we're going to see on the baby's head. All right, so we have 2 different fontanelles. There is the frontal fontanelle and the posterior fontanelle. Okay, the frontal fontanelle is larger, so therefore it takes a bit more time for it to close up, somewhere around 2 years. All right, whereas the posterior fontanelle takes about 1.5 years, all right, since it's a little bit smaller. Okay, now the fontanelles are going to either sink or bulge out depending on what's happening inside of the head. All right, in the case of dehydration, okay, we're going to see the sunken fontanelles because that kid's losing a lot of what? Fluid, specifically water. CSF, it's fluid in the body, primarily made of, what do you think?
Plasma.
Water, right? So if that kid's losing a lot of fluid, they're going to be losing CSF, and they're have negative ICP. What kind of ICP?
Negative ICP.
Right, hence why it's going to sink in, and we're going to see the sunken fontanelles. Where if the kid were to have increasing ICP, they're going to have bulging fontanelles. Okay, so we just have to look out for that, right? Just assess it. Obviously, do not palpate the fontanelles, okay? Because if the fontanelles have been palpated, right, you know, we have some long-term deficits that some people of you may be showing, right? Okay. So, you two. Right, so with the sunken fontanelles, okay, we're going to see a little something like that. So we have a little baseball diamond-shaped dent in the head, okay, and that's going to be the shape of the fontanelle. And if it's sunken in, right, that is going to be a sign of severe dehydration. Now, as far as fevers, okay, do kids get sick?
Yeah.
Do kids get fevers?
Yeah.
Absolutely. Okay, so we have to use that as an indicator to be like, okay, kid's got some type of infection. All right, now if we see a fever with a rash, okay, as it says there, that's an ominous sign. Okay, because that's an indication of a very specific type of infection, right, that tends to go septic. Okay, we'll talk about that in just a second. As far as febrile seizures, okay, that is going to happen when kids get sick, have a super high fever that then cause them to have seizures. Now, when it comes to febrile seizure, the seizure itself is not really the main concern for us. It's what caused them to get the fever in the first place. That's what we're really concerned about. All right, so why does this kid's temperature jack up so much to cause the kid to have a seizure? I usually call febrile seizures one and done because typically they have the one seizure and that's it. All right, when it comes to treatment for a febrile seizure, Axel, we'll start with you. What is the LA County treatment for a febrile seizure?
To expose the body.
Okay, so what kind of cooling method is that?
Passive.
Passive, whereas DOT says we do.
Ice packs and axillary, groin, and neck.
And what do we call that?
Active.
Right, it's active cooling. Okay, and now, so who else can I do active cooling for? Anybody else just for the hell of it? You look kind of warm. Let's throw some ice packs at him. Mr. Fox?
Heat stroke patients.
Right, heat stroke patients. Okay, because we want to actively cool them down. Regardless of protocol, we do active cooling. Okay, but again, for febrile seizures, there is a difference. So, as far as meningitis, okay, where we have infection of the meninges, right, one classic sign of that, and a later sign in infants, is that bulging fontanelle, and that's what we see there. Okay, so because of that swelling that's happening inside of the head, that fontanelle begins to bulge. So, here we can see that up in front. And this is the baby's face. Took me years to figure out what it is, right? But they just blurred out the eyes so that we, because you can clearly identify what baby this is by their eyes, right? So, no, you can't.
Oh, it's just a famous thing.
All right, so, right, they just go and blur out the eyes. So again, that's what gave it away. Oh, there's a nostril and a pacifier. All right, so we're gonna have that little bulging fontanelle, right? Now, because the frontal fontanelle is larger, it takes more time to close. We tend to see that. Whereas if they're under 18 months, they may have a bulging posterior fontanelle, right? If that's the case, I like to call them little camel heads because they have 2 bumps, right? Whereas just frontal fontanelle, a little unicorn bump, where just have the one up on top. All right. Now, in addition to that, okay, the kids can have the other signs of meningitis, which would be
nuchal rigidity and photophobia.
Right, nuchal rigidity and photophobia. Now, with the infant, are they going to tell you like, "Oh man, my neck's really stiff," and turn off the light?
Not.
No. Okay. So instead, what they're going to do is they're going to roll away from the light, okay, and not turn their head, but simply roll the entire body as it is. Okay. Also, with infants, we may see the bulging fontanelle, and because they're altered, they're going to have increasing irritability. Okay, so those babies are super duper fussy, but they're not going to cry. Okay, so super fussy babies, but they're not going to be crying because they have an ALOC. Right, you partner that with bulging fontanelles, right, photophobia and the nuchal rigidity, where there's kind of just rolling away. Right, and then we know this kid's got meningitis. Now, as far as bacterial meningitis going septic, okay, we're going to see this type of rash. And again, rash around the body with a fever, not a good sign, okay, because that bacterial infection's not gone throughout the entire body. When we talk about SIDS, we're going to see something very similar to this, right, all around the kid's body. Now, again, we know what causes this. It's sepsis, causing rupture of capillaries throughout the entire body, giving us that pinpoint rash. With SIDS, we don't know why it's there. It just is. Okay, so we can use that to our advantage, and we'll ask the parents, has the kid been sick recently? If they say yes, okay, it's probably this. If they say no, then that may be an indication of SIDS. All right, so we need to look out for that stuff and just manage it as best we can. It's all just supportive treatments. Okay, when it comes to GI problems, okay, gastrointestinal issues, right, kids for whatever reason are at a higher risk of developing appendicitis. So they're gonna have that pain to the right lower quadrant with what kind of tenderness? What kind of tenderness would they have with appendicitis?
Pulse, no.
Yes, sir.
Rebound tenderness.
Exactly. Okay, it's rebound tenderness, right? Where we go and press down, okay, it doesn't hurt, and then when we let go, ow, that's when they have that pain. Okay, and the appendix is what kind of organ? Hollow, because it's full of nasty stuff. So when the appendix ruptures, okay, we have all that leakage of nasty contents into the abdomen, which then leads to what type of infection? Peritonitis. And peritonitis can eventually go widespread around the body and cause what kind of shock? Septic shock. Okay, so we have to worry about that in those pediatric patients. Now, with appendicitis, again, they're going to have that pain in the right lower quadrant. And when the appendix ruptures, what happens to that pain? It goes away. So they're going to have pain, and then, oh, it's gone. Okay, cool. Right, and they think things over. But then, about 24 to 40 hours later, now they have that widespread diffuse abdominal pain with rigidity, distension, right, hot flush diaphoretic skins. Okay, indication that it's now gone to peritonitis and can go septic from there. With gastrointestinal issues, vomiting, diarrhea, right, is common, and again, very, very common in kids. All right, when it comes to poisoning, okay, of course, kids are likely to get poisoned. Is it usually intentional or accidental?
Accident.
Because the number one route of poisoning is ingestion, and kids like to put everything, anything they can where?
In their mouth.
In their mouth. So kids may start vomiting, okay, when they've been poisoned, and they will not have a history of recent illness. Okay, so no history of recent illness, vomiting, no diarrhea, and if the kid's been unsupervised for any period of time, okay, we can suspect that they have been poisoned. Okay, so vomiting with no diarrhea, no recent history of illness, and if they've been unsupervised for any period of time, okay, we can suspect that they've been poisoned, and again, usually it's accidental. So a kid sees something, goes, ooh, piece of candy, they put it in their mouth, right, and then they get poisoned. If that kid has ingested anything by mouth, Daisy, what medication could we possibly give to fix it?
Activated charcoal.
So what would be the contraindications for activated charcoal?
If they ate something poisonous, so they have something bad in it.
So that would be a contraindication for activated charcoal?
No, I don't know.
Erica, what are the contraindications?
If it has something acidic.
Okay, such as.
Aspirin.
Okay, what else?
Something alkalized.
Such as.
Can't think of any off the top of my head. I know the other one's petroleum, which is like basically, but then alkali.
Sarge, what would be an example of alkali? Tums, right? Antacids. Okay, so again, kids can be like, "Oh, candy." Start eating a bunch of it, and then OD on that stuff.
So I got yelled at because Matt said we don't administer charcoal. So for the sake of our test here,
We don't administer in LA County,
yeah.
right? California, we can, right? So we have to be able to actually carry the medication.
So how do I answer it on my questions though?
Again, all questions are based on what standard, unless it specifically states LA County. So if the question says LA County, that is asking about LA County protocol,
Okay.
right? If it doesn't say anything about that, then we default to national standard. Okay, so as far as activated charcoal, Cheyenne, how does it work?
It stops the stuff from being absorbed, and it's another substance in there that I can think of that makes you poop.
Right. Okay, so it's going to go and act as a laxative, right, and absorb whatever it is. That way we can flush it out of the body. Okay. When it comes to poisoning, do we ever want to induce vomiting?
No.
No, because if they throw up, right, it can cause some airway issues like aspiration. Okay, so we never ever want to induce vomiting or give them anything that can induce vomiting. Okay, we just want to give them activated charcoal and bring it out the other end, right? Not the intake, but the outtake. Okay, so we'll go and give them activated charcoal if we have it. All right, as long as they do not meet the contraindications of any acid, alkali, petroleum-based products, and of course, if they cannot maintain an airway, do we ever give them anything by mouth?
No.
No. Okay. For dosage, for the pediatric dose, all right, and this what's the pediatric dose for activated charcoal? George?
12 to 25 grams.
Not just 12 to 25 grams.
12.5.
Right. Okay, so 12 and a half to 25 grams of activated charcoal, right, is what we're going to give that kid. And as hard as we need to, okay, try to have that kid drink all of it so it can actually do its job. Okay, if they're showing signs of shock, i.e. metabolic hypovolemic shock from the excessive vomiting, okay, then we got to treat them for that shock. Now, when it comes to seizure activity, okay, younger kids are not going to present with your typical tonic-clonic, right, full-body convulsions, right, especially those infants, okay, because they don't have the ability to actually contract their muscles, right? So because they're so young and so immature and so freakish, right, they actually can't seize. Okay, instead with infants, they're going to have a very specific presentation of having an abnormal gaze. So the eyes are typically looking up in one direction. They have a sucking motion, and their extremities are bicycling in a circle pattern. Okay, so sitting in their carrier just doing that as they're having a seizure. But as the kid gets older, right, then they actually have the ability to convulse, and then we see, bless you, the typical seizure activity. All right, they're also prone to what type of seizures?
Febrile seizure.
Well, besides febrile, because that is still tonic-clonic activity.
Petite mal?
Yeah, petite mal, aka absence. Okay, so again, kids are gonna have those absent seizure where they're playing and just, and then go right back to it, right? So we just have to look out for that. And again, we're not gonna get called out for those because typically they go unnoticed, right? But we may get called out if they're prolonged periods of time, right? Where for it to be considered status epilepticus, Brent, how long would they need to have that absent seizure for to be considered status epilepticus?
For over 30 minutes?
Right, for over 30 minutes. So you got a kid who's zoned out for more than half an hour, that's a problem. Okay, so we want to go and transport those kids. As far as febrile seizures, again, we've already covered that. DOT, we do active cooling, taking those cold packs, placing them to their neck, armpit, and groin, right, where we cool that body down, Ramon, via what heat transfer method?
Conduction.
Conduction, right, where we lose it through touch. Okay, so that cold pack is going to be absorbing heat, right, and cool the blood down as it pumps through different parts of the body. Here in LA County, they don't allow us to do that, so we just do passive cooling, remove the clothing, right, and get them to a cooler environment so we can turn on the AC in the back of the rig, right, as we're transporting those kids. Now, as far as those that are having full-on tonic-clonic seizures, we treat them the same as any other active seizing patient. Okay, so if they are actively seizing, do we put a mask directly on them? No. Where do we put it?
Blow by.
Right, blow by. So we put it right next to their face. Okay, let them seize, protect from trauma, and then once they're done seizing, right, once we feel they can maintain their airway, then the mask goes on, right, and then we can go and roll into left lateral, right, and do whatever treatments we have to, consider possibility of spinal injuries, musculoskeletal injuries, et cetera, et cetera, et cetera. Okay, so for those older kids, our seizure treatment doesn't change. Okay, what else do we have to worry about as far as complications following a seizure, Axel?
Trauma to the head.
Okay, besides trauma, what else?
Spinal injury. Oh, besides trauma. Is there some type of shock to the head?
What was your question again?
What other complications do I have to worry about following a seizure besides trauma?
ALOC and big hypoxia.
Well, hypoxia is the big one. What else?
Another seizure.
Besides status epilepticus.
Hypoxic. Oh, and hypoglycemia.
Right, hypoglycemia. Okay, so again, while they're seizing, are they really breathing? No. So we want to give them blow-by, so whenever they do manage to catch a breath, they get a little bit extra oxygen. Okay, and as their muscles are convulsing, they're using up their primary fuel source, that source being glucose. Okay, and can hypoglycemia cause seizures?
Yes.
And seizures can cause
Hypoglycemia.
right, and it goes back and forth, back and forth, back and forth until they run out of sugar, and then they die. Okay, so we want to go and try to replenish that glucose however possible. If the kid's able to maintain their airway, how do we give it?
Between the gums and cheek.
Right, so we give them oral glucose. Right, do that. If they can't maintain the airway, then medics have to go and give them IV glucose instead. So, moving on to trauma. All right, so when it comes to trauma, again, this is the #1 killer of pediatrics overall. Okay, specifically, what type of trauma?
Head trauma.
Head trauma. Okay, so head trauma is #1 killer of pediatrics overall, whereas pneumonia is #1 medical killer of kids. So again, if a kid dies from a medical issue, it's going to be respiratory in nature. All right, now as far as our general trauma treatments, it's all the same. We see it, we
Treat it.
We see it, we
Treat it.
So if they have a musculoskeletal injury, what do we do?
Treat it. Or
How? We splint it. If they have bleeding control, what do we do? Control bleeding. Right? If they have a sucking chest wound, what do we do?
occlusive dressing.
Occlusive dressing taped on.
Three sides.
Being
One
grab the side open.
side.
If they got a jugular vein laceration, what do we do?
Occlusive dressing, 4 sides.
If they got evisceration, what do we do? Multi-trauma dressing. Okay, right, soak in saline, put the guts on top, and then seal off with an occlusive dressing. Okay, so again, treatments don't change for trauma, but we do have to consider certain things. For example, right, am I going to put a big old leg splint on a 3-year-old? No, right? But if we have cardboard, what can I do?
Form it.
Cut it. Yeah, cut it in half, and there we go. Now we got a pediatric size splint.
Will we still use the big ass dressing on kids since it's probably like their entire body count?
Well, we're not going to be using 4x4s, right? We can just go ahead and use that, fold it up as needed, and then put it on top of there, right? So we're going to be treating them up as normal. Okay. Now, as far as other factors, we have to worry about anatomy and physiology. Again, kids are freaks. Okay. So they have these big old fat, heavy heads, right, upon very weak necks. Going back to the whole bowling bolt on a toothpick analogy. Okay. Now, when kids fall, because of that big old fat, heavy head, they fall from a decent enough height. Their head actually pitched down, and they land head first, just like a lawn dart. Okay, most of you are probably too young to know what those are. Yeah. Okay. But basically, it's a giant ass dart with a weight on it, so when it lands, it's going to land point first. Okay. And kids, if they were to jump off of a tree and land feet first, or fall feet first, that big old fat heavy head causes them to pitch down and land head first. Okay. And when it comes to fall assessments, Daisy, what do you have to consider when it comes to assessment of falls? Like, to let me know if it's going to be a really bad injury or not, what do I have to look at and assess?
If there's any contusions.
How far they fell.
Right. How high they fell. What else?
The position you found them in.
I'm sorry?
The position that you found them in.
Not really.
Do you want to know what the fall is? Like, if it's like 20 feet or 3 times?
Well, we already said that. Height of the fall. What else?
What did they land on?
What do you mean?
Like, what body part did they land on?
Okay. And? So how do they fall? What part of the body hit first, and what else?
Are they bleeding?
What else? George?
How they landed, how the height of the fall,
Uh-huh.
and internal bleeding.
What is it, sir?
It's what they land on, so like the material that they
Right.
land
You learned something this morning.
on. You said the part they landed on,
Yeah.
so like their foot rather
Part of
than
the body.
I said what they landed on first. in the
Yeah, but then I asked, what exactly do you mean? Because then you followed up with part of the body, which is true. But again, we have to consider the surface that they fell onto. Okay. So as far as right, those different things. Okay, for adults, right, it's 15 to 20 feet. Okay, or 3 times your body height. With kids, if I remember correctly off the top of my head, it's about 12 feet, I believe, 10 to 12 feet, or 2 times their body height. I have to double check. Right, but it's a little bit different for kids. You don't have to worry too much about that. As far as the part of the body that hit first, again, with kids, okay, they got that big old fat heavy head, so they tend to land where first?
Head
first. Okay, and we need to consider the surface they fell on. Did they fall on concrete versus that spongy playground material? Okay, letting us know, okay, if it's concrete, it's not going to give, whereas that spongy playground material may give just a little bit, but we still have to worry about the type of injury. Okay, as far as neck injuries with deceleration injuries, aka whiplash, okay, again, bowling ball on a toothpick. Okay, so you're going to have a lot of cervical spine injuries with that big old fat heavy head whipping back and forth. Okay, Ku-conjugate injuries, things like that. If they do have increasing pressure inside the head, what begins to bulge?
The frontal.
Literally just covered it.
Pantanella or frontanella?
Fontanelles. What is it?
Fontanelles.
What is it?
Fontanelles.
Right. Okay. Fontanelles will begin to bulge as they have increasing ICP. So, when it comes to O2 administration, obviously for our major trauma patients, we want to give them high flow too. So any kids with any suspected head injuries, neck injuries, chest injuries, abdominal injuries, and spinal injuries, okay, you want to give them high flow too. Now, as for types of injury patterns, okay, we do have to consider that in kids because kids are freaks. So besides that big old fat heavy head making them freakish, okay, their internal organs, especially the solid organs, are larger and more anterior compared to that of an adult patient when it comes to proportions of their body. So their liver takes up more space in their abdomen compared to our liver in our abdomen. It's going to be closer to the skin, right? Therefore, it's a bigger, easier target to be hit. The spleen is the same, the kidneys are the same, but obviously closer out to the skin. Okay. Now, as far as abdominal injuries, is that common for kids?
Yeah.
Yeah. Okay. Think about it, right? If they're riding their bike and they hit the curb, what are they going to do?
Stomach.
Yeah, hit their abdomen, go over the handlebars, and we're like, oh, that's just boys being boys, right? But we do have to worry about them hitting their solid organs, causing laceration to the liver or the spleen. Okay, when they start getting involved in contact sports, right? Football, right? They get hit in the back. Now we got to worry about kidney injuries. Okay, and solid organs are of course full of blood. So now we got to worry about internal bleeding, causing hypovolemic shock. Okay. As far as auto versus pediatrics, who's going to win?
Auto.
Right, car's going to win. Okay, and we're going to have different injury patterns compared to us. So like we were saying earlier, right, when we covered trauma, we as adults, we get hit, we go up and over cars, whereas kids, they go down and under. Okay, so these kids might get ran over after they get hit by the car, depending on the speed, or they just get thrown, right? And just as a FU to this kid, right, you made her hit her head on a rock. All right. So we have to worry about that type of injury pattern with kids. Also for us, because we're adults and we're somewhat smart, okay, we know that if a threat's coming, we try to get away from it as best we can. Kids are dumb, okay? So they hear a car coming as they're chasing after it to get their ball in the street, they go, huh? Right? And then catch the car directly in the chest, right? And then get hit. Okay? So, as far as these injury patterns, again, we can see that that car is hitting pretty much right where all the important stuff is at. Whereas for us, because we're taller, it's going to go and hit lower to our body. Okay? So, we just have to look out for that stuff in kids, right? Obviously, it's going to be a lot more severe. When it comes to sports injuries, again, we have to worry about them getting hit for certain types of sports, especially in different locations like the back. When it comes to head injuries, okay, signs of head injuries that we see in us are the exact same in kids. Okay, so the first thing to change when a patient suffers a head injury is going to be their what?
Eyes.
Right, their mental status. Okay, so the ALOC is going to be the first thing to change, and then we see pupillary changes shortly after that. Okay, but the pupil changes just let us know that something's up, right? But they will have mental status change first. Is this a sunken fontanelle?
No.
No, because the location, you're right, is on the side of the head. Okay, now it is kind of diamond shaped, but if it were a sunken fontanelle, it'd be up over here or back over here. All right, so here we have a depressed skull fracture. All right, now we do have to worry about signs of ICP in kids. Okay, now with them, they might be able to vent out a little bit of extra pressure through those fontanelles as long as they're open. Okay, where we get the bulging fontanelles on either side. Okay, so head injuries, again, will not present with sunken fontanelles at all. It'd be the opposite. It'd have bulging fontanelles since there's increase of pressure. As far as chest injuries, okay, we're not always going to see obvious signs of trauma to the chest for kids who sustain chest injuries. Okay, so we're not always going to see decap BTLS, but we have to assess the mechanism of injury. All right, with kids, again, their bones are fairly flexible. So in the case of a kid receiving blunt trauma, okay, that chest and the ribs may flex in, transfer energy to internal organs, and then spring back out to its normal position. And if this kid gets hit the exact wrong time in their heart's electrical cycle, Brent, what is that going to lead to?
Commotio coit?
Close.
Yeah, it's not.
Commotio cordis.
Cordis.
Okay, so that kid's going to have commotio cordis, which means they're going to go into what rhythm?
AFib?
No.
Is it TFib?
No. What rhythm are they going to go into with commotio cordis?
Don't we just flatline?
No, they don't just flatline. Ignacio, what rhythm do they go into? All right, it's VFib. Okay, because Grandpa has AFib. There's no such thing as TFib, right? So we get VFib. Okay, so because the kid's in VFib, Mr. Fox, what can we use to treat that kid? What's going to be the best thing for them?
AED.
AED. Within what time frame?
Wait, like, what?
When should I use the AED to give them the best chance of survival?
2 minutes after CPR, or continuous CPR. Compressions? So you do like 2 minutes of like rigorous CPR.
It's within 2 minutes.
Right, within 2 minutes. Okay, doesn't matter about CPR. We'll be doing CPR. Okay, we want to use the AED within the first 2 minutes to give them the best chance of coming back. Right, and if we can get them zapped in the first 2 minutes, they got a pretty good chance of coming back. But of course, time after that, chance of survival start to decrease. Okay, so again, think of the chest as like a net, right, where it's going to curl in a little bit, absorb some energy, and then spring back out. Okay, and that energy transfer is going to happen to their internal organs, so we do have to worry about contusions of the other stuff inside as well, to the heart, to the lungs. Okay, kids can obviously get cardiac tamponade, where we're going to see what triad, Daisy? If they have cardiac tamponade, what triad are we going to see?
Beck's triad?
Which is?
It's when there is there's a hypertension.
I'm sorry?
There's hypertension.
Hyper or hypo? Which one are you saying? That's why I always emphasize the or or the o.
I said hypertension.
Nope. Erica, what is Beck's triad?
Heart murmurs, narrow.
It's not heart murmurs.
It's low pressure in the artery, so hypotension.
Okay.
And JVD.
And?
Muffled heart sounds.
And muffled heart sounds, not heart murmurs, because that's an improper valve working. Okay, so we're going to start seeing that even in pediatric patients, okay, because that trauma is not going to affect them in any differently than we are going to see with us. Right, with the abdominal injuries, like we said, okay, they're going to have larger, more anterior solid organs that are easier, bigger targets to get hit, especially again if they go over the handlebars on their bicycle. Okay, so we have to look out for signs of shock. All right, treat them as such. For extremity injuries, right, we just follow the rules of splinting. Rule number 1 is to check what?
CIEMT.
Right, before and after, and then we just keep going from the rest there. Okay, these kids are going to have a higher risk of green stick fractures because our bones, right, are more brittle, so when they break, they snap, right? Whereas kids, they're a little bit more flexible, so when they break, they just kind of bend a little bit. So we are going to see some deformity, right, with their injuries. Okay, but we go ahead and just splint it up. Nothing changes. We just use splints that are pediatric sized. Right? If we have cardboard splints, then we just cut it to pediatric size. All right? When it comes to burns, okay, whatever's modeled for us will be critical for them if they're under the age of 5. right? So we need to identify that, right? We do have to consider the type of burn that they may have as well, and consider the possibility of child abuse, right? So we'll be like, hey, this burn isn't necessarily normal for kids. That may be an indication of abuse, right? For example, okay, would I expect a kid to have some burns on their fingertips?
Yes.
Yeah, right? They found out that the stove hurts, right? So that's going to be something normal, right? But if they were to have cigarette burns on their palm, is that normal?
No.
No, okay? Other types of burn patterns we'll talk about when we hit child abuse, again, may be indications of abuse. And if we see it or suspect it, we report it. Okay, and we'll talk about that stuff in a bit. Now, as far as the pediatric rule of nines, okay, remember kids are freaks. Okay, so they got these big old fat round heads. Okay, so their head and neck, right, is now worth a whopping 18% of body surface area, whereas their face and neck is worth what percentage?
9.
What is it?
9.
What is it?
9.
Because again, the face and neck is only half of the head and neck, since we only have a face in the front half. Okay, because they got short little stubby legs, each leg is worth 13.5% apiece. Okay, but the core of the body, right, is all the same. So the torso is 18%, the posterior torso is 18%, the groin is 1%, the upper extremities are 9% apiece. Okay, so right here in the center of the body doesn't change, just on the top and bottom. All right, now you can all take a deep breath because there won't be any burns questions on your quiz tomorrow. Okay, now I don't know what's on your final because I haven't seen the number one final, right? But you may have burns questions on that. Okay, your national registry, again, they're a bunch of sadists, so will they ask you burns questions about kids?
Yes.
Yeah, because they know you guys do well with burns. Exactly, and they know you suck with kids too, so they're really going to screw with you and ask you those burns questions on kids.
So can you clarify for me, the head, the front part of the head is 19, and the back of the head, 9. The front part of the head is 9, and the back of the head is 9?
For a grand total of?
18.
Yes.
And but for the baby's head, is it?
No, I thought you were talking about the kids. Okay, so the whole head and neck, so everything from the clavicles up, right, all the way around is 18% for a kid. For us, because our heads are more normal size compared to everything else, it's only 9% of everything. The face and neck for us is only 4.5%.
Oh.
Okay, it's all based on proportion, right? So that's what makes it different. Okay, so as far as drowning, okay, kids are obviously at high risk of drowning, especially younger kids because they don't know how to swim. Right, we have to worry about diving emergencies as well, because again, kids are going to want to jump into the shallow end of the pool. Right, that's why again we have the no diving signs. Okay. So we have to worry about the possibility of spinal injuries. Now, as far as hypothermia, okay, drowning patients are at risk of hypothermia, and remember, they're not dead until they are
warm dead.
So we want to go and try to warm them up, still work them up as a cardiac arrest patient until, right, we warm back up, and okay, nothing changes. All right, now they're dead. Okay, but we can't do that. It's just up to ALS and Higher Medical Authority. So if they do drown or nearly drown, we have to worry about that fluid buildup in their lungs, and we call that what? Pulmonary edema, right? As they may aspirate some of that fluid. Okay, so we just work them out, try to maintain the airway as best as we can. Now, when it comes to spinal immobilization for kids, okay, we can use pediatric backboards, right? So the kid's actually on a pediatric backboard; they're just kind of outlined to their body. Strapping orders, obviously, or strapping placements different than regular backboard. Okay, so we have like a vest that goes over the shoulders, different straps that go there. Each leg is going to have its own individual board that we're going to secure it to. There's no cheese blocks, okay, but there's going to be a strap that goes around that, straps that go around the head as well, and we're still going to use C-collars on kids. Okay, so we want to go and use that. If we don't have these boards available, can I use a regular longboard? Yeah. Okay, we just pad that kid in so they're not sliding around all over the place. Okay, so take rolled up towels or pillows and just secure it so we can stuff that kid to the board so they're not moving. All right. So this kid they obviously paid. This one not so much, right? But, right. If we have a car seat that's intact, okay, all we do is stuff that kid into the car seat and that's it. All right. As long as the kid's also stable. Okay, so we just stuff it in and we immobilize them that way. Now, if the car seat is not intact and the kid is unstable, okay, then we have to extricate from the car seat. Okay, so we can use a short board in that case for infants, right, where we go ahead and put them on that board. Again, for the infant, they got them padded in there with rolled up towels, some pillows and whatnot. We're not going to put C-collars on infants because they have short, little, tiny, fat necks, so we just can't get a collar around them. Okay, so we just improvise. We'll go and secure them down, so they're using tape to hold this kid down. All right, and generally with infants, we leave the extremities free. Okay, reason is, again, can I tell an infant to stay still? No, because they have no idea what I'm saying. Okay, when they're crying, they will be flailing their extremities. Okay, and I want that movement so they're not moving their core. But if I tie their extremities down, then they start crying and start squirming. Now we're going to have movement of their spine. Okay, so we just want to leave those free. As far as pain management, okay, we do the best we can to try to make this kid as comfortable as possible. Okay, but there's only so much we can do. ALS, depending on their protocol, they can give them pain medications. Now, part of our lecture for ALS Assist, right, is going to be going over being medic's little helper. So we can go and be medic's little helper when we are assessing and treating pediatric patients. So here we have what's known as the Broslow resuscitation tape. Okay, so it's a chart that we're going to line up next to the kid. Okay, it is color coded, right? And depending on the color that the kid is going to be falling under, it's going to have dosages for kids that are going to be approximately that weight, right? Or size of equipment for kids that are that size. Okay, so it's a little cheat sheet for ALS to use. So they can be like, okay, this kid falls in yellow, so it'll have their doses that they're going to use here, different size equipment on this side, other doses for different types of medications like ACLS drugs and whatnot. Okay, and it's all approximately based on their weight too. So if they're yellow, we would expect them to be anywhere between 12 and 14 kilograms, right? We basically double that to get pounds. So that is an option we can use. Right? The other thing we might be able to use to help them out with that is the Pedi wheel, and it's two-sided, and it's just a spinner. That's all it is. So here we have age, and it's going to show different things like vital signs for kids of that age range. So here I have it dialed into 9 months. So it's got approximate weight. So a 9-month-old kid should be somewhere between 8 to 10 kilos. Right? There's systolic blood pressure, right? Pulse rate, all that kind of stuff is going to be there, right? Different equipment sizes. It's going to have rule of nines calculator there. So again, a little cheat sheet because they know you guys do what with burns. So little cheat sheet here. Okay, APGAR assessment. We'll talk about that when we cover childbirth, right? And all that kind of stuff. On the other side, right? It's going to be based on weight. So this is going to be more for the medics to use to calculate drug doses. So we can ask the parents, hey, how much does your kid weigh? Oh, they weighed about 25 pounds at their last checkup. Okay, so we're going to dial it into approximately that many kilograms, which would be, we're going to get close to 15 kilos here. So it's going to go ahead and show how much they need for that weight. Okay, so we'll just go and dial it in, hand it to the medic, and they'll go and take a look at that stuff. All right, so I'll pass this around because the Broslow is kind of old and falling apart. All right, but you can go and spin it around and see what it does. Right, take a look at that stuff. As far as the pain assessment, okay, these kids may not understand the 1 to 10 pain scale, how bad does it hurt, okay, but instead we can use the Wong-Baker-Faces pain scale. You may not know it by name, but you know it by sight, okay? That's the crying face to the happy face, okay? So we want to go ahead and pretty much line it up to the kid, and we can even ask them if they're old enough, how do you feel, and see if they can point to it, right? And it gives us an idea of how bad it hurts for them. Of course, that's completely subjective. Now, when it comes to shock, whatever causes shock in us can cause shock in them. Okay. Does their compensation for shock change compared to us? No. Okay. They don't change. They don't compensate any different than we do. They just do it a little bit better for a little bit longer. Okay. But once they run out of those mechanisms, they just what?
Crash.
They just crash. Okay. So they're going to tank super duper quick. So again, they got the long stage of compensation, very short stage of decompensation, and then they go into irreversible shock. Right. As far as management, it's the same. O2 blanket, proper positioning. Okay, so nothing really changes there when it comes to kids. All right, so you guys can go and pull out your little triage sheet that was given to you on the very first day of class. Okay, little one-page algorithm.
Yeah.
Yep. If you don't have it with you now, okay, you should have it with you for Thursday when we cover ALS Assist. So it's going to be this paper right here. Okay, double-sided. All right. So we're going to cover jumpstart triage because this is what I use for pediatric patients that are under the age of 8 and or weigh less than 100 pounds. Okay. Now, when it comes to jumpstart triage, we use the same color criteria as regular start triage, but obviously different actual triage assessments. So we have green, yellow, red, and black. So for our green tag patients, okay, we generally call them walking wounded. What do we call them?
Walking wounded.
What do we call them?
Walking wounded.
Not walking dead, but
walking wounded.
Right, walking wounded. Okay. Now, for our green tag patients, they're the easiest ones to triage. Because once I get on scene, after I declare an MCI and call for additional resources, I say, hey, if you can hear me and you can walk, go stand by that tree over there. And all the patients who are able to get up and walk to that tree over there are automatically green tagged because they're what? Walking wounded. Okay, they can walk and they probably have some injuries. All the patients that are left on scene, then we start triaging them. Okay, now green tag doesn't apply to infants because can infants walk?
No.
Can they understand what I'm saying?
No.
No. So we don't really tag infants as green. Okay, but everybody else, hey, if you can hear me and you can walk over there, go walk to that tree or whatever point you designate to. As far as yellow tag patients, okay, these are patients who have injuries, but they're not life-threatening injuries. Okay, and therefore they may not be able to walk. So they need to have all of the criteria present to be considered yellow. So they have to be breathing on their own. Okay, so they must be breathing on their own at a rate between 15 and 45 breaths per minute. Okay, so they have to be breathing on their own at a rate of between 15 and 45 breaths per minute. Okay, so breathing on their own at a rate between 15 and 45 breaths per minute. They need to have a palpable peripheral pulse, which means I got to be able to feel some radials on them. And they have to at least be responsive to painful stimuli. Okay, so breathing on their own at a rate of 15 to 45 breaths per minute. Have a palpable peripheral pulse. All right, and at least be responsive to painful stimuli. So if I were to do painful stimuli on the skin and they go, ouch, and they wake up, okay, that's still enough to be tagged as yellow. Now, if I were to pinch that kid and they're really lethargic, that's not enough to be considered yellow. All right, obviously verbal stimuli is fine, and if they're alert, that's totally fine as well. Okay, so they have to meet all the following criteria. Yeah,
I'm sorry. You said breathing 15 to what?
45.
What if, because like they could have that, but what if they say had like a piece of metal through their abdomen?
They're stable. So signs of yellow, right, even for STAR triage, we'll talk about on Thursday, this is at the very least compensation. Right, so either totally fine or they're compensating.
They could still handle it.
Mm-hmm. Right? When it comes to red tag criteria, we'll cover that. Okay, they're now decompensating. Okay, so for yellow, they got to meet all of the following criteria. Have to be breathing on their own at a rate of between 15 and 45 breaths per minute. They need to have a palpable peripheral pulse, and they have to at least be responsive to painful stimuli. All right. Now, as far as red tag criteria, they only have to meet one of the following. So, if their breathing rate is less than 15 or over 45, automatic red tag just like that. Okay, so if they're bradypneic or tachypneic, okay, above or below those numbers, then it's an automatic red tag. We just continue the rest of our assessment and triage. Okay, now if we walk up to the kid and they're apneic, okay, we get to open up the airway. And for a pediatric patient, what airway position do I want to use?
Sniffing.
Neutral sniffing. Okay, so we'll go and pull back on the head just a little bit to see if they start breathing on their own. I don't care about spinal injuries when it comes to triage. Okay, so we just go and pull back on that head to open up to a neutral sniffing position. All right. Now, if the kid starts to breathe after that, cool. We red tag them and you move on to the next patient. Okay. However, if the kid does not breathe after airway positioning, now we move on to rescue breathing. Okay. So if after opening the airway, the kid is still apneic, we move on to rescue breathing. And we're going to provide ventilations, right, at a rate of 1 breath every 2 to 3 seconds for 15 seconds. Or we provide 5 rescue breaths. They're pretty much the same, as long as you're ventilating at 1 breath every 3 seconds. So I just opt to go with 5 rescue breaths. It's easier to remember. Okay, so I go and do those 5 rescue breaths. And if after those 5 rescue breaths, the kid is breathing on their own, you red tag and you move on. Okay. So, as far as walking up, I walk into this kid, I see no obvious signs of chest rise and fall. What do I do first? No. We open the airway. Okay. Again, we're talking about triage. So I open up the airway. Cool. Kid's breathing. Now what?
Red tag.
Red tag, and you move on to the next person. Okay, let's say I open the airway, crack, kid's still not breathing. Now what?
Rescue breaths.
Right, how many rescue breaths?
5.
5, right? So we do our 5 rescue breaths, and the kid's breathing. Now what?
You move on.
Red tag and you move on. If the kid's not breathing after that, we black tag and you move on to the next patient. Okay? So if after those rescue breaths, the kid's still not breathing on their own, we black tag them and you move on to the next patient. Okay? With triage, again, it's about doing the most we can with the least amount of resources that we actually have. Okay? So we don't have time and the resources necessary to treat this kid up, right, when I've got 20 other patients I got to worry about. Okay? So if they're dead or they're expected to die, sorry, and you move on to the next one and that's it. Okay? For adults, it's a little bit different. Okay? And we'll talk about that on Thursday. So that's that. If we see signs of respiratory failure, right, because we know they're going down that chain that we talked about earlier, respiratory failure, hypoxia, bradycardia, cardiac arrest, automatically red tag them. Okay, breathing without a pulse, that just means they don't have a palpable peripheral pulse. Okay, so if I check a radial and it's not there, but they're breathing, we know they're not what?
Dead.
We know they're not dead, but we know they're at the very least hypotensive. Okay, and then an inappropriate painful response. So if I were to provide that an elbow pinch and they're, again, really lethargic, or they're unresponsive, right, then we go and red tag them. Okay, and they only have to meet one of those criteria to be tagged as red. Okay, so once we find one of them, red tag, move on.
So for yellow, it's all of them?
Yellow, it's all of them. Okay, for black tag, again, those are patients who are dead or those who are expected to die. Again, kids still apneic after we provide ventilations. If you don't breathe, what happens to you?
Die.
You die. And again, we don't have the resources necessary to take care of one patient when I've got 20 others on scene that we have to manage. Okay, so here we have a layout of our triage. And triage is just algorithmic. That's all it is. That's why if you look at your sheets, it's an algorithm. Okay, what do we see at this step? Take care of it. All right, move on to the next step. What do we see? Take care of it, and so on and so forth, right, as we're running through our assessments. Okay, with start triage for adults, it's much more simple. Okay, but with pediatrics, right, we want to try to give them a little bit extra chances, and it's a little bit different since their bodies work different. Okay, and just like burns and diabetes, when it comes to triage, you guys what? Right. Okay, and again, we'll
Burns,
go over that again. Triage. Okay, we'll go over that on Thursday. And we'll go back over Jumpstart again. Okay, so now we get to the sad, depressing part. So when it comes to child abuse, okay, we are mandated reporters. So if we see it or suspect it, we report it. Okay, now as far as reporting child abuse, okay, we have to give verbal notification ASAP. Okay, so we have to give verbal notification as soon as we can.
To the parent?
No.
Oh.
Yeah, we're like, you're abusing them. Yeah. All right. No, it's going to be to somebody who can do something about it. So law enforcement, child protective services, a hospital, supervisor, dispatch, somebody who's got power of authority that can work it down the chain. Okay, now as far as abuse, there's multiple different types of abuse. There is physical abuse, right? There is emotional abuse, right? Neglect, sexual abuse, things like that. Okay, now as far as cases that are reported every year, right? About 2 million. And does every single case of child abuse go reported?
No.
No. Okay, that's why if we see or suspect it, we what? We report it. Okay, now, just because we report child abuse does not mean that they're going to break up that family. Okay, so if you suspect something's going on, right, don't be afraid to report it. Okay, just like diagnosing patients with medical conditions, can we do that? No, because we're not doctors. Okay, nor can we diagnose child abuse. Right, we're saying, hey, something isn't quite right over here. You guys might want to come take a look at this, and the proper authorities will go in and investigate to see if it is in fact child abuse. Okay, so it's always better to err on the side of caution. Hey, this might be child abuse going on, or it is. It's cool, you saved the kid, or it's not. It's just some misunderstanding. Okay, no harm, no foul. That's it. Okay, but it's always better to try to do something instead of not saying anything at all. Okay, so there's a bunch of questions that we would need to ask ourselves to suspect the possibility of child abuse, right? So one, is the injury typical for that stage of development? Okay, so with toddlers, again, do I expect some bumps and bruises on toddlers?
Yes.
Yeah, right? Scraped knees, scraped elbows, scraped palms. I expect that on kids. Okay, but if they have, bruises to half of their body or even some broken bones, depending on their age, is that normal? No. Okay, so again, if I got a 2.5-year-old with a broken arm, that's not normal for 2.5-year-olds to break things. Right? Versus a 12-year-old with a broken arm, would I expect something like that? Yeah. Especially if the method of injury is consistent with the injuries. Does the story match the proof? Okay, so an example I use, right, is a 2-year-old with a black eye, right, and dad says, oh yeah, he ran into the doorknob, but the doorknob's up here and the kid's down here. Does that make sense?
Mm-hmm.
No. Right, or that classic kid fell down the stairs at home when they live in a 1-story house. Right, so again, that stuff doesn't add up. We have to look at the caregiver and the child, both acting and behaving appropriately. Like we talked about at the beginning, not only do you have to worry about the kid, but who else do you have to worry about? Parents. Okay, so obviously if the kid's injured or ill, they may be stressed out. But the parents are like, right, kind of nonchalant about it, something's not quite right. Okay, the kids should be going to parents for comfort, and if the kids are staying away from them, right, that too is an indicator of something going on. Okay, so see how they're behaving with one another. Right, as well as evidence of drinking or drug abuse. Again, as we said, okay, parents may, give the kid alcohol to calm them down. Obviously, that's not, again, how parenting works. But we also have to look about drug abuse and stuff like that on the parent, because that may indicate neglect on the child. Right, so as far as verbal notification, again, we have to do that as soon as possible. Doesn't have to be right then and there on scene, but as soon as it's safe for me to do so, I want to tell somebody about it. That way we can get the wheels rolling on this reporting. Okay, as far as the written report, that has to be filed within 36 hours of us noticing the actual abuse. Okay, so we have to have written notification, right, and a written report submitted within 36 hours of us noticing the event. All right, once we submit that written report, people go in and they start running their investigations to see what's going on. Okay, other questions? Right, was there a delay in seeking care for the child? Okay, so for example, if this kid broke their arm 2 weeks ago, okay, why are you just now bringing them to the hospital? All right, so that may be an indication of abuse. The relationship between child and caregiver, we've already talked about that. Injuries at various stages of healing, and what does that tell us?
Repeated abuse?
Exactly. Okay, it's been happening more than once. Okay, so bruises of different colors, right, lacerations at different stages of healing. Okay, that tells us that there have been multiple instances of child abuse going on for X amount of time. Okay, scarring, right, again, tells us that it's been going on for a while. Any unusual marks or bruises. Okay, so again, things that are not quite consistent with what we see. So for example, these are what are known as ligature marks, where that kid is tied with something very, very thin and sharp, probably like wire. Okay, is that normal for kids?
No.
No, okay, even if kids are playing, they don't play like that, right? So again, that's not normal. Okay, bruises like that, that's more than just a spanking, right? That's going to be excessive physical abuse. All right, we'll see some other marks as well, okay? But when it comes to burns in the hands and feet involving a glove distribution, okay, so that's where you have circumferential burns up to a certain point, right, of the body. Right, as well as an unexplained decreased level of consciousness, typically seen with shaken baby syndrome. Okay, so if they were to start shaking the baby, we're not going to see a lot of obvious signs to the actual baby itself, but there's going to be internal injuries, especially to the brain, as the head's whipping back and forth, causing conjugal injuries. All right, so again, these are all things we're going to be asking ourselves and looking for, right, when it comes to suspicion of child abuse. So here we have the burns of a glove distribution. Okay, where again, it's a circumferential burn up to a certain point of the body. Okay, so this indicates what's known as dunking, where they take the kid and dunk them into hot liquids. Okay. As far as scars, right, we have that kind of stuff there. Now, when it comes to other types of burn injuries, again, we have to consider what's going on. Right. For example, me, when I was 2 and I moved into the house that I grew up in, we have a floor heater. So me, 2-year-old, right, being stupid, walk on the floor heater and just stand there and start screaming. Right. My parents were taking care of my sister, who was just born a few months prior to that. Right. So they ran, scooped me up, took me to the hospital, where I had second-degree burns at the bottom of my feet. Right. So as I go to the hospital, they're pretty much asking my parents, like all these questions. Right. Kind of running their own assessment. They have to report it because it's a burn that's not typically normal for kids, right, to have second-degree burns on their feet. But my parents are like, yeah, no, we have a floor heater. Right. His sister here, who's just a couple months old, was crying and. My sister normally was, right? We're busy with her, and he's running around the house, and stepped on the floor heater, so we scooped him up and brought him right over. So they're still running the whole questions, but obviously it's not child abuse, it's just me being a stupid 2-year-old and standing on the floor heater and not knowing what to do as I burn my feet, right? So it's not always going to be a case of abuse, but again, just got to report it anyways. The worst they're going to say is, okay, nothing's going on here, it's totally fine. Or, hey, yeah, I was abused and you saved the kid. So again, really not a lot of no harm, no foul when it comes to that stuff. As far as the kid being of appropriate weight, okay, obviously kids that are severely underweight will be considered neglect, but also kids that are severely overweight, okay, that could also be considered a form of abuse. Right? Any type of rectovaginal bleeding, indication of any type of sexual assault. Okay, so we have to go and treat those kids for any trauma that they may have sustained, right? Encourage them not to wash, urinate, defecate, anything like that. Okay, obviously, who do you want to get involved with this? Law enforcement. Okay, you want to do it as safely and as quickly as you possibly can. All right, as far as the actual appearance of the house, okay, what does it look like? Is it clean? Is it dirty? Right? Is it too hot, too cold? Okay, with this one though, we have to be a little careful, right? As far as is it actually abuse or not? Okay, if the kid is the only one being subject to those conditions, it's clearly what? Abuse. It's clearly abuse. Okay, usually in the form of neglect. Okay, but if everybody in the house is living that way, it's probably not going to be abuse. Okay, so again, just kind of use your judgment on that one. But when in doubt, right, we see it or suspect it, we report it. Okay, maybe if it's not, abuse, it's not intentional, but maybe we can get social services in and they can help the whole family, right, kind of fix that issue, right? Now, as far as example I like to think of, not real, but Harry Potter, right? He's the only one that's shoved in that little tiny room in the staircase, whereas everyone else, right, is totally fine. Okay, so that is clearly going to be neglect. Right? Of course, not all of our patients are going to have magical powers and get to go to Hogwarts. So, here we have other burn patterns that, again, are not typical for kids. Cigarette burns on the palms. Okay. So, when it comes to shaken baby syndrome, it's exactly what it sounds like. Somebody does what?
Shakes the baby.
Shakes the baby, and again, we never shake the baby. Okay. With that big old fat bowling ball for a head on a toothpick of a neck, okay, going to cause a lot of cervical spine injuries as well as cou-contra-cou injuries, where we may start to see swelling up inside the brain. And what external signs are we going to see to indicate that?
Bulging
fontanelles.
Fontanelle.
Okay, so again, that kid may have bulging fontanelles, right? But other than that, we're not going to see bruising, no decap BTLS, just those bulging fontanelles. Okay, so we have to go and take a look and see what's going on. Ask ourselves all those questions of abuse to determine, hey, is it child abuse or is it not? To see what's happening. So for sexual abuse, again, we've already covered that. Oops. Want to go and treat them for any type of trauma that they've sustained. Okay, so as far as rectal bleeds, what do?
Pack the crack.
Pack the crack. Okay, in the case of any type of vaginal bleeds, we'll take an OB pad, place it there, just leave it as is. Again, encourage them not to wash, urinate, defecate, anything like that, until we get them to the hospital to get assessed and treated. For patients, okay, we want to have EMTs of the same gender doing the physical exam. So female patient, female EMT, male patient, male EMT. Okay, if we don't have that available, okay, when we contact law enforcement, we can request for an officer of the same gender to at least be a witness to the physical exam. So if you have a female patient but a male EMT crew, okay, that's fine. We go ahead and get female officers, and you can always ask and request it when you call for law enforcement. Hey, we have a female patient, possible victim of sexual assault. Can we request a female officer on scene? Right. That way, when dispatch calls them, we're like, hey, can you guys send over a female officer just as a witness to the exam? All right. That way, they can go take care of that. Okay. As far as reporting it, okay, again, we have to make sure that who is safe on scene besides the patient? Ourselves. Okay. So we may not want to contact law enforcement right then and there in front of the abuser because can that scene become violent?
Yes.
Absolutely. Okay. So we may have to do something kind of discreet, right, where we can go and get the resources that we need. Okay. So your partner hopefully is smart enough to realize that this isn't normal, right, and they're also going to be suspecting child abuse. So if your partner's smart, for example, you can go ahead and have them fetch the equivalent of headlight fluid, right, from the ambulance, where they go, oh yeah, I know that's not a real thing, but they want me to leave, so I can go and get on the phone. Hey, we need law enforcement, blah, blah, blah. Come back with some funny piece of equipment. Here you go, partner. Right, we do that, and again, the abuser has no idea that's what's going on until PD shows up, right? And sometimes with abuse, you just have to play stupid. As clearly obvious as it is, again, your safety is paramount. So if you start going on the defensive, right, then they may start attacking us. So just be like, oh yeah, they fell down the stairs. Oh dang, that kind of sucks, right? Just go with it until, again, that's safe for us to go and actually start being more aggressive with management and whatnot. All right. Now, as far as reporting abuse, like we said, it's not our job, okay? Or at least as far as determining if it's abuse, we report it. Okay, but law enforcement or child protective services, they go in, run their investigation, and be like, yeah, that's clearly child abuse. Or, nah, it's just a misunderstanding. Okay, so that's their responsibility. We're just basically waving a flag saying, hey, something's not quite right here. You guys may want to come take a look at this. Okay, now, if we don't report child abuse, okay, we can be held partially responsible for whatever happens to that kid. Okay, so if we show up and we're like, oh yeah, this kid's covered in bruises, right? Oh yeah, they give us some BS story and we buy it, and then something happens to that kid later on, they're gonna be like, come on, seriously? You believe that with all these signs, right? And then we may not get the full brunt of it, but again, we are gonna be held partially responsible. So here's the LA County standard, right? Stating what we have to do if we see or suspect child abuse, which of course, we see it or suspect it, we report it. So we give verbal notification when? As soon as possible, ASAP, okay, and we have 36 hours to fill in the written report. Okay, now once you're done with that call, you can always call dispatch or a supervisor and be like, hey, we suspected child abuse on the previous call, we reported law enforcement, can we come in and fill out the paperwork? All right, that way we get it done, get it submitted, get that ball rolling as soon as we can, instead of having to wait. Okay, so you can always call in and ask, the worst they'll say is no, but then you just do it at the end of shift. All right, that way it's done, we get that whole paper trail started. All right, when it comes to SIDS, all right, sudden infant death syndrome. Okay, when it comes to SIDS, again, we have no idea what causes it. It just happens. Okay, there's no warning signs. All right, the kids are totally healthy. Right, there's no trauma, no injuries, nothing like that. Kids are healthy. When they go to sleep, they just don't wake up. Okay, now as far as SIDS, it's unpreventable or unpredictable rather. Therefore, unpreventable. But these are examples of accidental death. Right, where it may initially look like a SIDS case, but upon investigation and autopsy, they're like, yeah, it's actually not, it's just an accidental death. Okay, so as far as kids, they should be sleeping by themselves, right, in their own crib, free of a lot of debris. Okay, so no toys, right, excessive pillows, blankets, things like that, because the baby can just simply roll over it and then suffocate themselves. Okay, again, not SIDS, just an accidental death. Just as them sleeping in the same bed as their parents, where mom or dad may roll on top of the kid, right, and then smother them. Again, not intentional, just accidental death. Okay, so we have to think about that kind of stuff. Where were they discovered? Where was the baby found? Right, what position were they in? Things like that. Okay, are we doctors? No. Can we diagnose it? No. Okay, but we want to gather as much information as we can for the coroners to determine what's going on and whether it was SIDS or not.
So it'd be like just the baby just ran out of battery and like just died. No reason.
No reason. Baby's totally healthy, right? And then they just don't wake up. All right. So don't worry about writing this down, but okay, SIDS is not caused by any of these things. It's not caused by vaccination. It's not hereditary. It's not caused by infection. It's not caused by trauma. Right? Kids are totally healthy. They just don't wake up when they go to sleep. All right. So it happens in infants. That's why we call it sudden infant death syndrome. With most SIDS cases happening around the 2 to 4 month range. Okay, that's where most SIDS cases occur, but it can happen anywhere in that first year. Okay. Again, not predictable, not preventable. Kids are totally healthy, put them down to sleep, and they just don't wake up. Okay, as far as determining if it's SIDS, we can't tell on scene if it is a SIDS case or not, right? But the coroner has to do a complete autopsy, and they rule it out via exclusion. So they go, okay, I'm not seeing signs of pneumonia, no signs of meningitis, no signs of trauma, no signs of internal bleeding. Guess it was just SIDS. Right, and that's that. Okay, as far as our job on scene, because we have an infant in cardiac arrest, what do? CPR. Okay, unless they show obvious signs of death. All right, as far as obvious signs of death, Brent, what's one of them?
Depending on it.
Which is?
A blood pool going towards the gravity.
Right. What's another one?
Decapitation.
Which is an example of?
The head over there and the body here.
Well, yes, that's what decapitation is. But again, decapitation, example of what specific death criteria?
The decapitation of any extremity at the spine.
What's that an example of?
Mortal death?
Well, still death, but obvious mortal. Ignacio? Obvious mortal.
Obvious mortal injury.
Right, obvious mortal injury. Okay, so again, decapitation is not the only example of obvious mortal injury, but it's the most common one. Okay, so obviously the baby's head is off, it's not SIDS. Okay, but what else? What else? Daisy? I'm sorry? What is that?
Stiffening of the body.
All right, stiffening of the body. And Erica, what's the last one?
Putrefaction.
Which is a fancy word for
Body is rotting.
right, decomposition. Say it a little bit more elegantly. All right, so, right, decomposition. Okay, so we're going to look out for any of those obvious signs of death. And if we do see it, we don't provide resuscitation. Okay, now as far as the common ones that we see with SIDS, we are going to probably see rigor mortis and or dependent lividity, right? Because again, we don't see obvious mortal injury because then it's not SIDS, right? And the baby's not going to be decomposing by the time that parents put them to sleep and we find them, okay? So with SIDS, again, we're going to see that type of rash that we see with meningitis. With meningitis, we know what causes it, right? It's a septic infection that causes rupture of capillaries around the body. With SIDS, we don't know why it's there. Okay, but again, it's not going to be ruled a SIDS case if they have an infection. They just died from the infection. Okay, so they don't know why that's present. There also tends to be some blood-tinged fluid in their nose and their mouth. Again, don't know why it's there, it just is. Okay, but that is going to share a sign with another type of thing we're going to talk about that they don't really know what caused it either. Right, but some people think that's happening. So that rash, we call it a petechial rash for both the meningitis rash and what we see with SIDS. Okay, but that's going to be that splotchy pinpoint rash all around the body. All right, and with the obvious signs of death, rigor mortis and dependent lividity. Okay, but up until we see these signs, we just go and start doing CPR. If we do see rigor mortis, dependent lividity, we don't provide any resuscitation because they're obviously what?
Dead.
Obviously dead at that point. So, again, do not start CPR, right, if you see those obvious signs of death. So if the body's still limp, right, and there's no blood flowing to the bottom, then we start doing CPR. Okay, as BLS, do we have the authority to stop CPR once you've started?
No.
No. Okay, so if you come across an infant, right, who's died of SIDS, and they're having rigor mortis, and you start doing CPR, can you stop?
No.
No, again, you can't be like, oops, my bad. Okay, you have to keep going until ALS shows up, and they have to call the hospital, and they're going to look like idiots because of what you started. Okay, where you have to go ahead and basically tell them, oops, my bad. Right, you got to call in the hospital and tell them what's up. Right, now as far as family, do you think family's going to be there?
Yes.
Yeah. Okay, and if you start doing CPR on their dead baby and you have to stop when they're showing obvious signs of death, is that good for them?
No.
No. Okay, so again, you have to know what to do, otherwise you're going to look like a complete asshole. Okay, starting CPR on an obviously dead infant. Okay, so if that's the case, we'll talk about what to do for obvious death. Right, where we can't do anything at all, but you cannot start once you stop, or stop once you started. All right. So we need to go and check for signs of illness. Okay, so if we can, try to gather medical history. Has the kid been sick recently? Because if they were sick, is it SIDS?
Maybe.
No,
Oh,
it's not.
No.
Right, they died from the illness. Okay, so if we were to see that rash and bulging fontanelles, right, and the parents say, yeah, you know, my kid's had a fever for the last 3 days. Okay, well, they probably died from meningitis. It's not a SIDS case. Okay, general condition of the house. If it's too hot or too cold, is it a SIDS case?
Could be.
No, right? It's an environmental emergency. Because again, kids and old people don't do well in extreme environments. Okay, family interaction, right? Because again, this may be ruled as homicide, right? If it was something like shaken baby syndrome. Okay, and with family interaction, again, people tend to kind of be on either end of the extreme, right? When they commit something like shaken baby syndrome, either extremely overwrought with guilt or totally nonchalant about the whole thing, right? We don't really see too many people that are going to be in the middle. Okay, site where the infant was discovered. So if they're found in mom or dad's bed as they were sleeping, is it SIDS? Probably
No.
not. Okay, because again, mom or dad may have simply rolled onto them as they were sleeping and smothered the kid. Okay, and again, we have to document whatever we see. Okay, so document condition of the house, right? Condition of family, right? Presentation of the baby, things like that. Right, because this is one of the things that is going to get an investigation further, right, with the medical examiner as they're going through the stuff. So we need to document as much as we can. Now, with an apparent life-threatening event, okay, some people think that this is SIDS adds to actually happening before it kills the kid, because there is a little bit of overlap between the signs and symptoms of ALT and the signs of SIDS. Okay, so once we find this out, okay, this is one of our very few immediate load and go calls, where we pick the kid up and we start hauling out to the hospital right away. Okay, we do have to be very, very careful with airway management because these kids are going to have some type of airway issues. They're usually apneic when we get there, or they are apneic when we get there. Okay, and they may have some secretions in the airway as well. Sometimes blood-tinged fluid, and that's where the overlap starts to occur between an ALT and SIDS. All right. So as far as what ALT is going to look like, kids are going to be cyanotic and apneic, okay, as well as a distinct change in muscle tone. Now, we're not the ones who are going to find the kid in the state of ALT. Okay, mom or dad put the kid down, right, to go to sleep, and they go and they check on the kid, and they notice the kid's cyanotic, not breathing, and limp. Okay, so naturally they want to start, stimulating the baby to try to wake up, right, going hey, hey, and start shaking it to wake it up. Of course, that's when we get the call. By the time we get there, right, the baby's going to start to improve its condition a little bit. Okay, so they may go from being limp to having a little bit of muscle tone, a little bit of rigidity. Okay, they may be breathing a little bit. They may have some choking or gagging because of the possible airway secretions they have in there. So again, we want to suction out. Because we have an infant, how long do we suction for?
5 seconds.
5 seconds, right, as we're going on the way out. Okay, so when it comes to ALT, pay super strict attention to that airway. Okay, immediate load and go, take them to the hospital. The doctors are going to be the ones to determine the cause, just like SIDS. Okay, and just like SIDS, they rule out with exclusion. Okay, no recent signs of illness, no signs of infection, no signs of this or that or that. Apparently, it was just a life-threatening event. Hence where we get ALT. Okay, so we want to go and transport as quickly as we can. As far as family riding in the back, that depends on company policy. Most of the time, if we've got critical patients, we don't want any family in the back because we need the space to be able to do our job. Okay, and we're going to have other people in the back with us, such as ALS. Now, when it comes to death of a child, okay, so we found a kid who suffered from SIDS, right, or other cardiac arrest, okay, and we tried providing resuscitation and it didn't work. Okay, at this point, I always say we just go from being an EMT to just being a good person. Okay, so at that point, we're just trying to help the family out as best as we can, right, up until the medical examiner, law enforcement comes to take over the body. So, as far as managing with the family, okay, if they ask questions, okay, we can try our best to answer questions, but should I pull something out of my butt to make me sound competent? No. Okay, if you don't know, just say, I don't know, right? Maybe they can tell you later on. Okay, as far as talking to them, it sounds super backwards, and we kind of talked about it in intro. Okay, but use the terms dead and died as opposed to passed away or gone. Okay, is the family going to be processing things, as they normally should right now? No. Okay, they're super stressed out. Okay, so they may be going through that state of denial, right, as the first stage of grief. Okay, so if you say, I'm sorry, but your child is gone, they assume the kid just may have got up and went down a liquor store. Okay, but if you say, I'm sorry, your child has died, it's kind of hard to misunderstand what's being said. Okay, so again, it sounds super hard, super blunt, right, but kind of have to do that to start kickstarting this grieving process. Okay, like I said, be a good person, so offer to call for help if need be, right? Offer food or drink or something simple like that. Again, just do the best you can to try to calm them down until somebody else can come and take over the body. Depending on the issue, okay, we can allow them time with the body, but use your discretion on that. Okay, if you have a traumatic full arrest, do you want family to see that?
No.
Probably not. Okay, if they got hit by a car, family probably shouldn't see that. Okay, but if it's a case of SIDS, right, or other medical death, again, use your discretion. Maybe family can go and spend some time with the kid. Okay. Like I said, if they ask questions, okay, if you can answer. If not, don't be afraid to say, I don't know. Okay, I don't know. Maybe the medical examiner can tell you afterwards. All right. As far as speculation on cause of death, again, same thing. If you don't know, don't say it. Can't diagnose death anyway, so we'll say, we don't know what happened unless it was obvious. Dealing with kids, again, as you said, stressful, just kids as a whole. Okay, dealing with critical kids, super stressful. Dealing with dead kids, super duper stressful. Okay, so if that's the case, we need to make sure that we're looking out for ourselves, right, and seek help as needed. Okay, so obviously you can contact your supervisor, say, hey, we ran a SIDS case 2 days ago. I haven't been able to sleep, haven't been able to eat, right? Can't do this, can't do that. I may need to take some time off. I may need to go, seek counseling, blah, 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 blah. Okay, start going to the whole CIEMT, right? Critical Stress Incident Management, to go ahead and get help for ourselves, right? As far as passing information, we may be responsible for that if we're working in the ER. Okay, so we can pass on resources to family, right? If, of course, resuscitation wasn't successful, contacting support groups and things like that, right? So, we'll end on that depressing note. All right, we'll go and take a little bit of time to reset, and then we can talk about life and childbirth. Yay! So happiness. All right, so be back at 8 o'clock. All right, and then we'll move on from there. So between ALS and BLS, who's gonna be the one getting dirty? Right. Okay. So, right, we have to know what to do. Now, when it comes to it, right, as Matt was saying earlier, okay, mom is doing most of the work. Okay, all we're doing is we're playing the catcher. What are you playing?
Catcher.
Right, because we're just here to catch the baby. Right, when it comes out, do a handful of things, and that's it. Okay. So, like you were saying earlier, break it into your pre-delivery issues, your delivery issues, and I usually just call it post-delivery. Right, because there are things that will happen after delivery that we have to be concerned of, like neonatal resuscitation. Okay, most of the time, if we are delivering a baby, it goes pretty smooth, but you have to know what to do and when to do it, because if you hesitate, even for just a little bit, and do the wrong thing or do the right thing, but too late, okay, you're obviously going to have a negative effect on that baby. Now, we have to keep in mind, how many patients do we have when we have a pregnant woman? Two. We got mom and we got baby. Okay, and for class purposes for right now, we're just going to assume baby is a boy because it's easier to talk about the different patients, right, when you have a female and a male patient. So, as far as changes to anatomy, okay, the baby is going to be developing in the uterus. And remember, the uterus is the muscular organ that is designed to expand with fetal development. Okay, the fallopian tubes, do they expand?
No.
No. And if we have an egg developing in the fallopian tube, what do we call that?
It's ectopic pregnancy.
Right, it's an ectopic pregnancy.
Ectopic.
Okay, so with a female patient of childbearing age with unilateral lower abdominal pain with a history of a missed menstrual period or two, okay, we now have to be worried about the suspicion of an ectopic pregnancy. As far as skin signs, because she's losing a lot of blood, what skin signs would she have? Cool pale diaphoretic, right? Since it's essentially rupture of a solid organ, right, because of how vascular it is, not the fact that it's a filter. Okay, but for right now, we're going to talk about regular childbirth where things are working as they should. So, the baby is going to be developing inside of the amniotic sac, which is going to be full of amniotic fluid. Okay, the amniotic fluid acts as a cushion and insulator for the fetus as it develops. Average volume of amniotic fluid inside the sac is anywhere between 500 to 1,000 mLs. Okay, so anywhere between half a liter to a liter of amniotic fluid, right, is what that baby's going to be suspended in. All right, as far as the placenta, okay, the placenta is what I like to refer to as a quote-unquote temporary organ because it's only there when mom is what? Pregnant. Okay, after delivery of the baby, shortly after, the placenta also gets delivered and therefore it's no longer in the body. Okay, so we have to keep in mind that it's temporary and we'll talk about why that's relevant in just a bit. But the whole purpose of the placenta is to allow stuff to go from mom's blood into baby's blood via diffusion. However, okay, mom's blood and baby's blood do not mix during pregnancy. Mom has her own blood in her body, baby has his own blood in his body, but they don't actually mix while she's pregnant. Okay, but the placenta will allow stuff to go from one person's blood to the other without actual mixing of blood. So for example, mom is going to suck in what? Oxygen that's going to be transported through her different blood vessels all the way to the uterus. Through diffusion, okay, oxygen is going to start diffusing into the placenta and into baby circulation, whereas the baby is going to get rid of what gas? CO2, which gets diffused through the placental barrier into mom's blood for mom to exhale it out. Okay, so a lot of different things are able to pass through that placental barrier from mom to baby. Something's good, something's bad. Okay, now as far as what connects the baby to the placenta, that is the umbilical cord. And just like pulmonary circulation, okay, umbilical circulation is flip-flopped. Okay, so the umbilical vein carries oxygen-rich blood, whereas the umbilical arteries carry oxygen-poor blood, right, since it's going away from the baby. Okay, so the umbilical arteries are going away from the baby, whereas the umbilical veins are coming towards the baby, carrying oxygen-rich blood.
Why did they just switch the names then?
Because they have to make it fancy. Right, again, arteries go where? Away.
Oh.
Right, so when it comes to mom's blood volume, right, the body is obviously going through changes. We'll talk about some normal ones and abnormal. The mom's blood volume goes up by about 45 to 50% during pregnancy. Okay, so she's going to get more blood, one, to have more red blood cells to transport oxygen to the uterus, and two, right, in compensation for blood loss during childbirth. Okay, because during childbirth, there will be blood. Right, so she's going to be pretty much expecting that, right, so she can compensate a little bit better. So, as far as the placenta, again, stuff is able to go from mom's blood to baby's blood without actual mixing. Okay, so oxygen, carbon dioxide, nutrients such as glucose, okay, will go from mom's blood to baby's blood. Medications, right, as well as drugs and alcohol can go from mom's blood to baby's blood. And of course, that's the bad stuff that we don't want, but we want good stuff like oxygen and glucose, right? Other stuff like CO2 that's normal to go back out.
What was the increase of blood volume?
About 45 to 50%. All right, so the placenta will be attached usually somewhere along the superior half of the uterus. Okay, somewhere along the top half, that placenta will be developing. If it gets too low, that's going to be one of our complications we'll talk about. Okay, one thing we have to be considerate of. So, changes that will happen in mom's body. Okay, there's going to be some cardiovascular changes. So, again, with that, we're going to have more blood volume, which means the heart has to work even harder to move blood around the body. Okay, now every single woman who's going to be pregnant, right, is not totally healthy. Okay, so if her heart's not 100% working, okay, that may lead to cardiac compromise, which can kill who?
The mom.
Mom and
Baby.
And baby. Okay, so some women are going to have those high-risk pregnancies, right, where they may have to be on bed rest or things like that. Okay, because cardiac compromise is a possibility for them, which can be fatal for both mom and baby. All right, again, mom's blood volume goes up, heart rate also goes up, again, leading to things like cardiac compromise. Okay, so pregnant women, if they're a little tachycardic, should you be concerned?
No.
All right, if you got a pregnant lady at rest and her heart rate's, in the high 90s, low hundreds, okay, she's pregnant. All right, it's kind of to be expected. Okay, same thing with tachypnea. Right, if she's breathing a little bit faster, right around 20, just give or take a little bit above or below, okay, that's normal. Now, as far as respiratory changes, okay, that's all because of anatomical changes inside of the actual abdomen. When the uterus expands, it goes up and it goes out. Okay, and that upward movement is going to displace different types of abdominal organs. Okay, as we inhale, where does the diaphragm go?
Down.
It goes down. And if that uterus is going up, the diaphragm can't go down all the way, so therefore she has decreased tidal volume. And to compensate for that decreased tidal volume, what happens to her rate?
It increases.
It goes up, hence why she's a little tachypnic. Okay, so again, if you got a pregnant lady at rest who's breathing at 22 times a minute, okay, she's pregnant. Big deal. All right. When it comes to musculoskeletal changes, okay, weight gain is to be expected during pregnancy. Okay, the center of gravity also changes, where we have an upward-outward movement of that center of gravity. Again, commonly injured joint, of course, being the ankles, right, more so in pregnant women because of that shift in balance, right, and additional stress placed on those joints. Okay, we'll talk about what to do if there's a pregnant lady who suffers trauma, because we have to keep in mind there's two different patients now. So, as far as our pre-delivery complications, okay, these are all things that happen when? Before delivery. Okay, so starting off, we're going to talk about pre-eclampsia. And pre-eclampsia is pregnancy-induced hypertension. So pre-eclampsia is pregnancy-induced hypertension. So it's high blood pressure that comes on during pregnancy. Right, usually happens in the later stages of pregnancy. Right, and the patient will be complaining of headaches due to increased pressure in the head, visual disturbances, so like some blurred vision and whatnot, edema, anxiety, and of course, high blood pressure because it's what? It's high blood pressure. Okay, so she will be a little hypertensive. Okay, now the thing we have to worry about with pre-eclampsia, when it follows it, are eclampsia, which are seizures. Okay, so pre-eclampsia leads to eclampsia, which are seizures. Now, if mom were to have an eclamptic seizure, okay, we treat her the same as any other active seizing patient. So if she's actively seizing, protect her from trauma, administer a blow by O2. Right, when she stops seizing, if we feel she can maintain her airway, put an RB directly on the patient. Okay, keep her left lateral. Right, do all our other treatments for seizure patients. However, our major concern with the mom who's having an eclamptic seizure is not so much for mom, but for who?
Baby.
For baby. Okay, because if mom's not breathing, what's that baby not getting?
Oxygen.
Oxygen. Okay, do you think that baby's going to be happy if it's hypoxic?
No.
No. So there's another complication we're going to talk about, okay, that we have to be looking out for if mom were to have an eclamptic seizure. Okay, so besides mom flopping on the floor like a fish, right, we have to worry about the baby and the effects it'll have on the baby. Okay, another issue we have to worry about is supine hypotensive syndrome, which is low blood pressure in what position?
Supine.
Supine. Okay, now this has a relatively easy fix. Because it's caused in a supine position, we get her out of
supine
position. And the position we want to use is the left lateral position. Okay, so get mom out of supine position, put her in the left lateral position. Right, and the reason why this happens is the weight of the baby, okay, it's now heavy enough to start squishing the inferior vena cava. Okay, so because the baby's developing in the lower part of the body, just below the heart, right, it's going to be squashing down that inferior vena cava. So when you squish that down, blood's not able to come all the way back up, and because there's not a lot of blood going into the heart, there's not a lot of blood going out of the heart, therefore taking blood pressure, causing hypotension. And when that happens, is the uterus able to get perfused?
No.
No. So the baby's not getting what?
Oxygen.
Is that baby going to be happy?
No.
No. And again, we'll talk about what's going to happen if that goes untreated. Now, by getting her into the left lateral position, I get the weight of the baby off the inferior vena cava, and yeah, we roll it more to the aorta, but the aorta can handle that additional weight because it's a higher pressure vessel. The inferior vena cava is not, so it's going to start squishing down, reducing blood flow coming back up. Okay, so this happens in later stages of pregnancy as that baby gets heavy enough, and that's why pregnant ladies can't sleep on their back, right? They have to sleep on their side because it'll cause supine hypertensive syndrome. Okay. Another issue we have to worry about is gestational diabetes. Okay, and this is diabetes that happens during pregnancy. Now, this type of diabetes is going to go away on its own shortly after delivery of the baby. Okay, but because diabetes is an endocrine issue, right, since insulin is a hormone, right, when she's pregnant, hormones are going to be a little off balance, right, she may develop diabetes. So, mom's going to start to have excess glucose in her blood. Right, now because the body doesn't need glucose, mom's body says, hey, I got some extra fuel, do you want it? Baby goes, sure, I'll take it. Right, so now that baby starts getting more and more glucose, acting as a primary fuel source, and then we get what I like to call a big old baby. What do you get?
Big old baby.
What do you get?
Big old baby.
Right, okay, not a bagel baby like some students have said in previous classes. It's a big old baby. Okay, so we get this larger baby because baby has more fuel to grow. Again, I like to give my patients nicknames. I like to call this baby 10-pound Bubba, right, because it's just so damn big. Sounds better. Sometimes 12-pound Bubba, depending on how big I want it to be. Okay, but this baby's going to be way too big to deliver. Now, we can't really get too much of a sense of scale, right? But here we have this big old fat head, okay, having to go through the cervix. Now, the cervix will dilate to a certain extent, okay, but if this baby's too big, is that baby able to get through the birth canal? No. Okay, do you think that baby's going to be happy if you can't get out? No. Okay, so we're going to start having complications with baby and mom, right, that may require a C-section delivery, which we can't do in the field. Okay? Because, yeah, we can't do it.
What do you mean, you can't pull a scalp on
No.
We can probably figure it out. It's not that hard.
No. It's about putting them back together. You hand the baby out.
No, if you throw them back in, they'll go back to normal. It's fine.
Until you go and accidentally decapitate your baby. Oops. Alright.
How am I going to decapitate the baby by throwing babies back in?
Or maybe I'll think I'm like that.
Stab anywhere.
So, as far as gestational diabetes, right, the main concern is with the actual delivery itself. If mom were having any diabetic complications, we treat her like any other diabetic patient. So if she happens to be hypoglycemic, what do we give her? Glucose. Right, we give her oral glucose. If she's hyperglycemic, is there anything I can do about his BLS? No, we go, okay, you got high blood sugar. Let's go. Okay, but the main issue, again, has to do with actual delivery if we're doing it on scene.
Don't most moms know beforehand? Because, like, actually, the mother of my child has that, but she was notified like 2 weeks in, so she just watched her diet beforehand. So
Well, keep in mind, is everyone going to get prenatal care? No. Okay. So if they're receiving care, yeah, they may know, but again, not every single woman's going to do that when they're pregnant. Okay. So we just have to ask, and again, if she says, I don't know, we can ask the 3 Ps. Have you been peeing a lot? Been drinking a lot? Been hungry all the time? Besides being pregnant? All right. Again, that's going to let us know what's going on.
But that's usually pregnancy.
Skin signs. Again, skin signs will also tell you if she's more warm, dry, probably diabetic. Okay. So as far as ectopic pregnancy, again, it's going to happen in the first 6 to 8 weeks of pregnancy. Okay, so it's going to be in the first trimester. So the embryo is going to develop in the fallopian tube. It's going to expand, expand, expand. Can't get any more room, and then ruptures. Okay, with this fallopian tube, again, quite vascular, she's going to start losing a lot of blood, and therefore can go into what kind of shock?
Hemorrhagic hypovolemic.
All right, hemorrhagic hypovolemic shock, causing the pale proliferative skins. Okay, now as far as frequency, like I said, 1 out of every 300 pregnancies is ectopic. Okay, so we're more likely to run this kind of call than actual delivery of the baby itself. Okay, so we really have to pay attention to those key indicators. Female patient, childbearing age with unilateral lower abdominal pain with a history of a missed menstrual period or 2. Okay, so when I get through my sample history, when you get to L, we say L is last oral intake, but if you look in the skill sheet, it's also last bowel movement, which I don't necessarily always have to ask, and last menstrual period, which again, I don't always have to ask. But in the case of this, would I want to know when the last menstrual period was?
Yes.
Yeah, of course. But if she sprained her ankle, do I need to ask?
No.
Okay, we don't care about that. Nor, when was the last time you pooped, right, if it's a sprained ankle. Okay, so we just go ahead and switch up those questions as needed. All right, now with this, there's nothing we do, just transport to the hospital. Okay, they have to go in surgically repair it. And again, this will not be a successful pregnancy. Okay, it will be counted as a miscarriage. All right, as far as our placenta problems, okay, 2 different placenta problems, placenta previa and placenta abruptio. All right, so placenta previa and placenta abruptio, which sound like things you will learn in Hogwarts, but actual placenta problems. So with placenta abruptio, okay, this is where we have a premature detachment of the placenta from the uterus. Okay, this is usually going to happen with trauma. Okay, so placenta abruptio is typically caused by trauma, or it's going to be directed at the abdomen itself. Okay, so assaults, falls, car crashes, things like that. Okay, that's where we can see placenta abruptio. All right. Now, as far as recognition of it, patient's going to have lots and lots of pain, but very little vaginal bleeding that we can actually observe. Okay, so lots and lots of pain, but very little observable vaginal bleeding. Okay, now as far as the pain is going to be coming from the uterus, not the placenta. Because again, I call a placenta what kind of organ? Temporary. Okay, and because it's temporary, the body's not going to wire nerves to the placenta. It's like, why bother? It's going to be out in a couple months anyways. Okay, but the uterus is always there, right? And that's where the pain signals originate because it will have nerves going to it. Now, as far as why we don't see a lot of bleeding, okay, that's because most of the blood is going to be stuck between the placenta and the uterus whenever it's detached. So it kind of bubbles out a little bit. And some of it may trickle out in the form of a vaginal bleed. Okay, so we need to assess the possible mechanism of injury that caused it. All right, and see if there's any type of vaginal bleeding. And the way she's going to describe the pain is a ripping or tearing pain, since that placenta is being ripped or torn off of the uterus. Okay, so it's described as a ripping, tearing pain, since it's being ripped or torn off of the uterus. Okay, treat for any shock and we transport. Now on the flip side, we have placenta previa, and that's where the placenta develops over the cervix. Okay, and the cervix is the opening from the vagina into the uterus. Okay, and I had a female student who actually didn't know what the cervix was, which was kind of scary. Okay. Right? So, guys, I completely understand. Okay, but
that's not an excuse. I don't know what the cervix is, but
you procreated, sir?
Do you have any?
So, as far as
these guys need an excuse, you know women.
I need a recap. That's what it is.
Yeah, sure. So, you'll get one. So, as far as placenta previa, okay, that's when the placenta develops over the cervix. Right. Now, as far as placenta previa, it's the opposite of placenta abruptio. Okay, little to no pain, but lots and lots of bleeding. All right. Again, little to no pain because the placenta doesn't have what? Nerves. All right, there's no nerves to go to the placenta. All right, so as that baby's being delivered and it goes through the placenta, there's no pain signals coming from that aside from childbirth pain. However, okay, because that placenta is pretty vascular, there's going to be a crap ton of bleeding that we're actually going to see. Okay, now as far as development of placenta previa, she's not going to know she has it unless she's receiving prenatal care and receiving an ultrasound. Right? So again, if she's not seeing a doctor, she's completely unaware that this is present until it's too late. Okay, because when she delivers, right, that baby's only coming out the only way it knows how to, which would be tearing right through that placenta, and by the time that baby's delivered, it's already dead. Okay, and mom might have also died as well due to excessive blood loss. Okay, so we have to just go ahead and be really careful with that, where if I were to expose and see a crap ton of vaginal bleeding, oh shit, okay, that's probably what this is and we gotta go.
How do you rule out a miscarriage?
It'll be happening beforehand, and we'll talk about that in a bit. It's really timing that's going to determine what we call it. Okay, so total opposite, and again, you guys get confused all the time because you don't understand why they present that certain way. Okay, so again, what placenta abrupt show? Lots and lots of pain because it's being ripped or torn from the uterus, sending out pain signals. Okay, but most of that blood is stuck between the placenta and the uterus, therefore not causing a lot of vaginal bleeding. Whereas placenta previa, it develops over the cervix, so as that baby's delivering and going through, lots and lots of blood, right? But because there's no nerves, little to no pain, aside from whatever pain she has from childbirth. All right? And again, when this happens, by the time the baby's out, it's already too late. Okay, so there's really not much we can do. When it comes to our different stages of labor, the National Registry, for whatever reason, for the status that they happen to be, okay, they love asking questions about different stages of labor. So, 3 stages, first, second, and third. Okay, the first stage of labor happens with the onset of regular, consistent uterine contractions. Okay, so stage 1 happens with the onset of regular uterine contractions, okay, where they're consistent. Mom can develop what's known as Braxton Hicks contractions, right, which are going to be irregular and they go away. They're not consistent. And those Braxton Hicks contractions are kind of warm-ups, right, for the uterus to kind of get ready for delivery. Okay, so she may have contractions and then they go away for hours and hours and hours and hours and hours and hours and doesn't have another one. Okay, but once they start becoming consistent and regular, okay, now she's entering labor. Now, as far as time that it takes for her to go through the different stages of labor, okay, it depends on how many kids she's had before. And the more kids she's had, the faster this whole delivery is going to go. Okay, if mom's never had a vaginal delivery, right, never been pregnant, okay, this first childbirth can take 10 to 20 hours, if not more, to deliver. Okay, and if that's the case, do we have to really deliver on scene? No. Where are we going to take her?
Hospital.
Take her to the hospital. Okay, and we'll usually show up around this first stage, right? Oh, contractions are starting up. No one's around. Guess I'll call an ambulance. Okay, what's going on? Yeah, my contractions started. Never had kid before, blah, 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 blah. Okay, well, take it to the hospital. Nice code 2 call. All right. So, again, time is in abundance when she's in that first stage. All right. Matt likes to say that you can go ahead and take her to take ice cream, but don't do it because that's technically kidnapping. Whereas I like to say you can at least go to Vegas and back. All right, but again, don't do that because that's also kidnapping. Okay, but again, gives you an idea of time. No.
What do you think of the hospital in Vegas?
Maybe that's a long distance transport. We're not doing that. No, so, again, first stage, right, is the onset of regular uterine contractions all the way up to full dilation of the cervix. Okay, we cannot see the cervix in the field. Okay, so we don't know when she's gone from first stage and transitioned into second stage. However, second stage is when the cervix is fully dilated until we have delivery of the baby, or as they like to say, expulsion of the infant.
That's so weird.
Sterile medical terms. All right. So obviously we'll know second stage, and this is where we're actually going to be doing the skill of delivery because at the end of it, baby's already out.
Do we measure at all? Because I know you do like the finger measurements.
No.
That's asking. Delivery, I know it's part of it. I'm just asking if we measure the cervix like that.
No, we don't. Like I said, we don't measure it in pre-hospital setting. It's the first thing I said. So, okay. Doesn't know the cervix. Yeah, sure. So, as far as third stage, okay, that's when you have delivery of the baby all the way up to delivery of the placenta. Okay. Now, as far as second and third stage, again, the more baby she's had, the faster these processes may go. Okay, to the point where she may have a explosive delivery. Okay, where a cough, a fart, or sneeze, that's hyperbole, that baby's coming out in one push. All right, so when we run our assessment, we have to ask how many times have you been pregnant, and how many kids have you had, and how are they delivered? Okay, because that will have a direct effect on the speed of delivery.
Can you repeat this question?
We'll see them later.
Okay.
All right, so these are our different stages, right, that are going to happen. So again, first stage, onset of regular uterine contractions, all the way up to the cervix is fully dilated. Stage 2, right, cervix is fully dilated and the baby's been delivered. Stage 3, baby's been delivered up to delivery of the placenta. As far as rupture of the amniotic sac, okay, that is not going to be an indication of imminent childbirth. Okay, imminency means it's happening right here, right now. Right, now there are some times where the amniotic sac doesn't rupture at all when the baby's delivered. Okay, so the absence of water breaking, right, doesn't tell me anything about, okay, we got time, or the presence of the water breaking doesn't tell me anything, oh crap, we have to go. Okay, all it tells me is the amniotic sac is ruptured. Now, as far as delivery, okay, we are going to have to ask ourselves, is birth imminent? What do you have to ask yourself?
Is birth imminent?
What do you have to ask yourself?
Is birth imminent?
Right. Okay, and we'll talk about the imminent signs of childbirth in a little bit. But if I were to see one of those signs, this baby's being delivered right here, right now, on scene. And if the imminent signs are not present, where are we going to transport?
Hospital.
Transport to the hospital, and that's where they're going to deliver the baby. Okay, so again, we can have, women who are in labor, but again, they may typically call us out in the first stage where we have plenty of time to get them to the hospital. Okay, but we have to look for those imminent signs where we have to deliver right here, right now. Okay, now as far as getting ready for delivery, okay, it is going to be a nasty, messy call. Trust me. Okay, so we want to make sure that we are gowned up, okay, as much as we possibly can. At a minimum, we're going to need gloves and eye protection, okay, as well as face protection, okay, because we are going to be in the splash zone. All right, playing the catcher. So, all right, if we can, we'll gown up head to toe. Okay, and call for ALS. Now, if ALS is there, are they going to get dirty?
No.
No. Who's going to get dirty?
Us.
Right. They're just there to be like, all right, good job. Right, and that's it. Just in case, right, something happens. Okay, that's all they're there for. Right, but they're not going to be the ones getting dirty. Okay, they're going to be like, all right, there you go. All right. So, when it comes to delivery, right, if it's not imminent, okay, we're going to transport her and we're going to put her in the left lateral position. Okay, we don't transport supine because it's going to create what complication? But what do we call it? Supine hypertensive syndrome. Because it's exactly what it sounds like. It's low blood pressure in the supine position. So to fix it, get her out of supine, roll her left lateral. Okay, with most childbirth calls, as long as there's no complications, right, and she's not delivering and everything checks out, it's simply code 2 to the hospital. Right? Because we got time to get her there where they can go and deliver. And if we do deliver on scene, if mom or baby are okay, it's a code 2 call. All right? There's nothing super duper special or fancy about it. Okay? So, as far as our signs of imminent childbirth, there are 4. Again, 4 is the magic number for this class. Okay? The most obvious sign of imminent childbirth, where this baby's coming out right here, right now, is crowning. Where you see the top of the baby's head coming out of the vaginal opening. Makes sense. Okay? If you can see the baby, baby's here. Okay? So the first one that we'll talk about is crowning. All right, another imminent sign of childbirth is mom having the urge to push. Okay, so mom may have the urge to push, where she's going to phrase it as, I have to push, or I have to go to the bathroom. Okay, and if she says, I have to go to the bathroom, do you let her go to the bathroom?
No.
No, okay, because again, nasty, messy call, everything's coming out anyways. All right, and if we were to let her go to the bathroom, where is she likely to deliver?
In the toilet.
In the toilet, and again, we do not do any water births in EMS. Okay, so we just let her go, all right, and that's it. Okay, next up we have the frequency, the what?
Frequency.
The what?
Frequency.
The what?
The frequency.
You guys suck with the terminology, hence why it's in yellow, bold, and underlined. Okay, it is the frequency of contractions. Okay, now we measure the frequency of contractions from the start of one contraction to the start of the next contraction. Okay, so that's how we time it out, from the start of one to the start of the next. As the labor begins, okay, the frequency of contraction is going to be really far apart. Let's say, for example, 15 minutes. Okay, so one contraction happens, right, she's done, and then it's going to be 15 minutes right before the next one starts. And we measure from start point to start point. And as imminency becomes closer, the frequency is going to get closer and closer and closer and closer until we get to 2 to 3 minutes apart. Okay, and that is where it's going to be considered imminent. So the frequency of her contractions has to be how many minutes apart?
2 to 3.
Measured from what point?
Start of the first
Right.
contraction.
Start to start. okay, so the frequency of contractions being 2 to 3 minutes apart, measured from start to start, is a sign of imminency. Okay, we don't care about duration. Okay, duration doesn't mean anything to us in the field. Okay, it's the onset, right, and the frequency of those contractions. Okay, if we're within 2 to 3 minutes apart, crap, this baby's coming out right here, right now. Okay, and then lastly, we have a bulging perineum, or perineum, however you want to pronounce it. Okay, so you may have a street term for the perineum. Okay, but again, we are medical professionals. So the perineum is the space between the vaginal opening and the anus. Again, you may have a different name for it. Yes, exactly. Okay, but again, medical terms. So, right, as that perineum begins to bulge, we know the baby's on its way out. Okay, so again, all we need is one of those imminent signs. Now, we can determine imminency when we get to E in our primary assessment, when we expose and visualize, and clearly we're not palpating, right, but we're going to go and take a peek. Okay, so if we have a female patient who looks to be pregnant, having intermittent abdominal pain, where the pain comes and goes, probably suspecting, right, that she may be pregnant, okay, and may be delivering. So we'll just simply ask her, hey, we're going to go and take a peek just to make sure, everything's going on. We're going to check to see if the baby's counting out, look for these imminent signs, take a peek and be like, oh yeah, I see the head, all right, and then we get ready to deliver. Now, in a perfect world, okay, we're going to have time to ask these 8 key questions. How many key questions?
8.
How many key questions?
8.
Right. Now, as far as asking the questions, there's no particular order to asking the questions. We just have to ask the questions. Okay? Now, as far as the first one, expected due date or last menstrual period, okay, those are either or questions, but you have to know both. Okay, the expected due date or last menstrual period will give us a timeline of pregnancy. Okay, so expected due date, how much time she's got left in the pregnancy, whereas last menstrual period, how far along she is in the pregnancy. Okay, so expected due date, how much time you got left in the pregnancy, whereas last menstrual period, about how far along she is in the pregnancy. Okay, is every single pregnant lady going to know their expected due date?
No.
No. Okay, if they're not receiving prenatal care, they're not going to know their expected due date. They're not going to sit there and be like, well, July 17th. Right? They're not going to do that. Okay? They're going to be like, oh, my doctor said it was July 17th. Okay? But we can always ask about the last menstrual period. Okay? When did you have your last menstrual period? Oh, it was about 8.5 months ago. Okay? And then, all right, we know it's pretty close to full term. All right? Gravida, how many times you've been pregnant? Okay. So adding in some Latin. All right? Gravida, how many times you've been pregnant? And then para is how many kids have you had? Okay, so gravida, how many times you've been pregnant? And para, how many kids have you had? All right, and with para, okay, we want to ask, how were they delivered? Were they vaginal? Were they C-section? We'll talk about other in just a second. Okay, so gravida, how many times you've been
Pregnant.
How many times you've been
Pregnant.
Pregnant. Para, how many kids have you had, and how were they delivered? Were they delivered vaginally? Were they delivered via C-section? Okay, now the reason why we asked that second part, how are they delivered, okay, has to do with number of previous vaginal deliveries. The more vaginal deliveries she's had, how is that going to affect this delivery right here? It's going to make it quicker, even explosive. Okay, we're getting that cough, fart, or sneeze, and that baby's coming out in one push. Okay, and all it takes is one. Right? One previous vaginal delivery is going to exponentially increase times, or decrease times rather, for previous deliveries. So let's say the first one takes 20 hours for her to deliver. Baby number 2 is probably going to take 12 hours. Baby number 3 is probably going to take 8 hours. Baby number 4, 6 hours, and so on and so forth. Where she's like, oh, my water broke, and then, oh crap, it's a baby. Right? So, again, it just depends. We have to ask that so we know, oh crap, right? Do we have to start getting ready to go, or do we have time, right, to go ahead and get ready to deliver and set up our stuff? Now, as far as C-section, okay, there's that old myth that says, oh, if she's had a C-section, she can't deliver vaginally in the field, okay, or in general. That's a myth, okay? As far as C-section, yes, there may be medical necessities for C-section deliveries, okay, such as babies that are too large due to gestational diabetes, right? Babies that have been turned and are going to be delivered breech or limb presentation or, placenta previa, whatever, okay? But C-section can also be optional, okay, where she just doesn't want to ruin the hardware downstairs with vaginal delivery, okay? Now, think about it. Babies only know one way to come out. Okay? It's not like the baby's going to punch through that previous C-section scar and then come out that way. Okay, it's only going to be coming out through the birth canal, but there may be complications. Okay, and again, we can't do any C-sections in the field. Now, as far as other, okay, that's going to be in relation to miscarriages and abortions. All right, now we only ask that question if it's indicated. Okay, the indication to ask about miscarriages or abortions is if gravida and para do not match up. Okay, now, barring any multiple deliveries like twins, triplets, or anything like that, we should always have one more gravida compared to para. Okay, for example, if she's pregnant 3 times, she's gravida 3. She's had 2 kids, she'd be para
2.
Is that okay?
Yes.
Yeah, because this would be baby number 3. Okay, cool. So she's gravida 3, para 2, baby number 3, everything's fine. But if she's gravida 5, she's been pregnant how many times?
5.
She's para 2, how many kids has she had?
2.
Is that a problem?
Yeah.
Then we ask about, okay, what happened to the other pregnancies? Were they miscarriages? Were they abortions? Okay, and again, that's the only time we ask that question, right? Only if it's indicated. And it's not the first thing we should ask because we wouldn't know the indications. All right, next up, rupture of the amniotic sac. Okay, so did your water break? And we want to know if there's any color or smell with that. Okay, so did your water break and was there any color or smell? What we don't want to see, right up here in a second, is meconium. Okay, and meconium is fecal matter caused by fetal distress. Okay, so meconium is fecal matter, it's poop, caused by fetal distress. And as far as the fecal matter, it is the baby's fecal matter caused by distress of the baby. Okay, so if that baby's distressed, it will quite literally shit itself inside the amniotic sac. Okay, and now we have free-floating meconium, right, which has the potential to get into the baby's airway. And should you have poop in the airway?
No.
No. Okay, so those questions we asked, or those pre-delivery complications we asked earlier, gestational diabetes, preeclampsia leading to eclampsia, supine hypotensive syndrome, okay, all that stuff will happen and cause distress in the baby, causing it to shit itself, and now we have to worry about amniotic fluid tainted with meconium. Okay, so when we get to prenatal care and complications, that's what we're really asking about. Okay, so ask her for amniotic sac rupture, did your water break, and was any color or smell? Okay, if she says, yeah, it was kind of greenish and brownish and smelled like poop, that's an indication of meconium. All right, as far as prenatal care, again, are you seeing a doctor for anything related to pregnancy? That's all she'll know, expected due date, and about complications. Okay, and the 2 complications we want to know about if we're delivering on scene are preeclampsia, which is pregnancy-induced hypertension that can lead to eclampsia, which are seizures. Okay, and again, if mom is having a seizure, is she really breathing?
No.
Which means baby's not getting what?
Oxygen.
Which means that baby's going to be in distress and produce what?
Meconium.
Which is,
Poop.
well, fancy term for it,
Fecal matter.
fecal matter caused by
Fetal
distress. Okay, same thing goes for gestational diabetes. If that baby's too big to come out, okay, that baby's going to be stressed out, it's going to shit itself, right? And now we have to worry about amniotic sac being tainted, or amniotic fluid being tainted with meconium. Okay, and if meconium is present, we'll talk about what to do, because if we see it, we treat it. If we see it, we treat it. Right, because meconium aspiration more than likely will be fatal, right, for neonates. Okay, so we have to identify it and again take care of it right away. All right, and this is what Matt was saying, where hey, childbirth's usually pretty good, but if it's not, it's really bad. All right, when it comes to drug and alcohol use, okay, we want to ask specifically about drugs and alcohol. Okay, as far as prescribed medications, vitamins, supplements, when do I ask those questions? Sample. And who gets sampled?
Everybody.
Right, including pregnant ladies. Okay, but we specifically want to know about drugs and alcohol because is that going to have an effect on delivery?
Yes.
Right, and fetal development. Okay, so we're going to have a higher risk of resuscitation if she has been using drugs or alcohol. All right, and then lastly, multiple births. Okay, when multiple births, we're asking how many babies are you expecting for this delivery? Okay, so how many babies are you expecting for this delivery? Usually it's how many? One. Okay, but twins, of course, are an option, right? Triplets, and God forbid an octomom situation. Okay, but right, we need to be ready for multiple deliveries just in case. Because if she says, "Yeah, I'm about to have triplets," okay, we have to call for additional resources to have more OB kits. Because usually we only have 2 kits in our rig. So we can handle twins, myself and my partner, that's fine. But add in any extra babies, now we got to call for help. All right, so those are all of our questions we have to ask. Now, if you guys have even bothered looking at your skill sheet yet, assuming you haven't, okay, there's 15 questions on that list. Okay, so we've done you the favor and trimmed out the fat, right, and only reduced it down to 8 questions. Okay, some of the questions are part of sample anyways that we ask for everybody, so we just kick it down the road, right, stated later. All right, so, oh shoot. Actually, I gotta fix something. That's it on the slides.
Go ahead.
There we go. All right. So, I had to edit the slides for another class I did. So, as far as getting ready for delivery, okay, once she started labor, okay, we cannot stop it, we cannot slow it down. Okay, so once labors began, we cannot stop it, we cannot slow it down. Right, so we're not going to have her close her legs because that's not going to help. Right, we're not going to elevate pelvis because that's not going to help. We're not going to tell her don't push because that's not going to help. Okay, so
Can't plug the hole up?
No.
Pack the
okay. So we just have to get ready to go, right? If those signs are imminent. Okay, and again, we're just playing the what?
Catcher.
Playing the what?
Catcher.
Because mom's doing most of that work. Okay, so we just go ahead and catch the baby, do a handful of things, and that's about it. Now, everything in our OB kit has to be sterile. Has to be what?
Sterile.
Has to be what?
Sterile.
Right, has to be sterile. Okay, so as far as the contents of our OB kit, you don't have to write it down because we'll go over it in a bit. Okay, but everything we have in here has to be sterile. So, when it comes to prepping for delivery, okay, we want to go ahead and try to place mom in a relatively private area. Okay, so if it's not happening at home, but at the Walmart down the street, okay, we may want to go ahead, shut off the aisle, do things like that to protect her modesty as much as we possibly can. All right, we also want to elevate mom's pelvis about 2 to 4 inches. How high?
2 to 4 inches.
How high?
2 to 4 inches.
Right, so that way we can go and give ourselves some room to work, right, once that baby comes out. And we want to use something that's sturdy enough to actually support mom's weight, right, to elevate her pelvis. Okay, so rolled up pillows, towels, blankets, whatever we have to elevate those 2 to 4 inches high. We also want to try to support the head, neck, and upper back, if possible, okay, to where we have her seated in almost like a semi-Fowler's position. Okay, we're going to have an assessment area for the newborn, so once the baby's been delivered, have a separate area close by to where we can do what we need to do. All right, and again, try to keep things as sterile as possible. However, setting up the environment at the very least has to be medically clean. Has to be what?
Medically clean.
Has to be what?
Medically clean.
Now, the difference between sterile and medically clean, sterile means that we're using sterile BSI to handle the equipment. Medically clean means that we're handling sterile equipment with non-sterile gloves. They're so clean. Okay, so not soiled or anything like that. Okay, that's the difference. All right, now there's 2 ways to start the skill, and I'll show you both ways. One sterile, one medically clean. Either one is fine. Okay, but we want to try to make sure that we're keeping things as clean as we possibly can. All right. So as far as positioning, we want to have something like that. So we're going to have a chuck underneath, elevate mom's pelvis 2 to 4 inches high. Okay, we'll have some drapes over the legs, another one over the top. Okay, trying to keep things clean, protect modesty, things like that.
What if the mom doesn't want to be in this position?
Then we just try to encourage her to do so. Because if she wants to go in that squatting position, there's really nothing we can do. We're not going to go underneath like we're working on the car. Right. So, as far as prepping for delivery, okay, we're going to have our regular non-sterile BSI at this point. Okay, and we're going to take OB wipes. Okay, we're going to start cleaning around the vaginal opening. All right, now there's a certain way that we have to wipe. It's not just doing whatever we want. Okay, pretty much go anterior to posterior. All right, so we start at certain landmarks. We start at the pubic symphysis. Where do we start?
Pubic symphysis.
Okay, which would be up on the, again, most anterior portion of the pelvis. We wipe down the labia to the perineum. Okay, so we go from the pubic symphysis, wipe our way down the labia to the perineum, one wipe, one swipe, discard that, and then I take my other OB wipe and I do the same thing on the other side, going from the pubic symphysis down labia to the perineum. Okay, so again, pubic symphysis down labia to the perineum, discard your wipe, same thing, pubic symphysis down labia to perineum, discard your wipe. Okay, again, childbirth is a nasty, messy call, but we want to try to keep it as clean as we possibly can. Now, once we've cleaned the area with our non-sterile BSI, we discard the non-sterile gloves and we put on our sterile gloves. Okay, and once we have our sterile gloves on, to resist the temptation to touch everything, okay, you're going to clasp your hands together like a surgeon, and you're going to wait until mom has the urge to push. Okay, when mom says she's ready to push, then we go ahead and position our hands. Okay, now when mom says she's ready to push, we take 3 fingers of our dominant hand or the entire hand itself and we cup over the top of the baby's head. Okay, now the purpose of doing this is to prevent explosive childbirth. Again, a cough, a fart, or sneeze, baby's coming out in one push. Right? And if, again, this is her 7th kid and they've all been vaginal prior to this, that baby should shoot halfway across the room. So putting that hand there, again, just hyperbole. Okay? Alright, so as far as placing our hand there, okay, we're going to try to slow down delivery. And our non-dominant hand, with either 2 fingers as is or with a 4x4, okay, we go and cover the perineum to minimize perineal tearing. Okay, because with childbirth, again, there will be blood. Okay, and yes, tearing. Okay, so one hand, dominant hand over the top of the baby's head, 2 fingers of our non-dominant hand on the perineum to minimize perineal tearing. Okay, and again, we're going to put gentle pressure as mom is pushing. Now, once the baby's head has been delivered, normally the shoulders will provide a natural pause point for delivery. Okay, and that's going to give us some time to look for 2 things. The first thing we're going to look out for, right, is going to be checking for a nuchal cord. Nuchal means neck. What does it mean?
Neck.
So a nuchal cord is a cord around their neck. If we see it, we treat it. If we see it, we treat it. See it, we treat it. Right. So the first thing I try to do with the nuchal cord is we try to slip it over the top of the baby's head. Okay. So if that baby presents with a nuchal cord, okay, we try to slip it over the top of the baby's head. All right. If I cannot slip it over the head, okay, now we have to clamp, cut. What do we do?
Clamp, cut.
What do we do?
Clamp, cut.
Right. So we take our OB clamps, clamp the cord, make sure there's no pulse in the middle, and then we cut the cord. Okay, and we have to cut the umbilical cord because if I don't, and that baby's getting delivered, that cord around the neck gets tighter and tighter and tighter, strangling the baby. Okay, so again, we see it, we treat it, and we have to take care of it right then and there. Always go least invasive to most invasive. So try to slip the cord over the top of the head. If it works, all right, cool, we'll continue with delivery. If it doesn't, clamp, cut. Once that baby's delivered, we automatically get ready for transport. Okay. The other thing we're looking out for is meconium, which again is fecal matter caused by
stress.
Who's stress?
Babies.
Right. And whose feces is it?
Beetles.
Babies. Okay. So again, fecal matter caused by fetal distress. Now, if meconium is in the airway, should he have poop in the airway?
No.
No. So we want to suction out the baby's airway. And when we suction out mouth and then nose.
What do you do if the mom poops herself?
It's gonna happen.
So like, why your hand is right there?
That's why you do this, not this. Okay, so right, we're gonna go ahead and suction out meconium. Okay, suctioning the mouth first and then the nose. And the reason why we go mouth and then nose is babies have what's known as a gasping reflex. Okay, so these babies have a gasping reflex. So when I suction out their nose, they do that. Okay, and they're going to aspirate whatever they have in their mouth and their nose. And the reason why they have this gasping reflex is because babies are nose breathers. What are they?
Nose breathers.
All right, they breathe through their nose. Okay, and if you think about it, it makes total sense. Okay, when they're breastfeeding, right, they're latched on with their mouth and they can only breathe through their nose. Okay, so pretty much anything that's going to be in the airway is going to stimulate them to gasp, try to clear the airway out a little bit. Right? So we go and suction out mouth first, then nose. Okay, using our bulb syringe that I'll show you how to use when we demo the skill. Okay, we always go mouth first and then nose, not to trigger that gasping reflex when they got a mouthful of crap. Okay, yeah.
The baby shouldn't be eating the crap though, right?
Exactly. Nobody should be eating crap. Okay, so as far as assessment of meconium and treatment, whenever we see meconium, we see it, we
treat it.
We see it, we
treat it.
We see it, we
treat it.
Where do we suction first?
Mouth.
And then
Nose.
Because they have what kind of reflex?
Gasping.
Yeah.
Do you only
suction if it's meconium? Like,
Correct.
Can you tell that it's meconium?
Yep. Okay, so we ask her, hey, did your water break? Yeah. Was there any color or smell? Yeah, there was some greenish chunks in there. It smelled like crap. Oh, crap. Okay, so no pun intended, but now we're worried about meconium. All right, and then we'll see it staining on the baby's head, and again, we'll smell it. Okay, so we'll go ahead and suction out the area whenever we see it. Now, once mom is ready to push again, we encourage her to push. Okay, at this point, baby's coming out. When she's ready to push, just tell her to push. Okay, for the shoulders, right, we want to pop those out one at a time. And once his shoulders are free, right, the rest of the baby comes sliding right out. Okay, and as you can tell, they're pretty wet and very slippery. Okay, so you want to make sure you have a very good grip on that baby, okay, because you do not get points for recovery if you were to fumble the baby. So just make sure you hold on to it.
So you said, when you brought up earlier about a splash zone, was that a joke?
No, it's not a joke.
What is this? What is a splash zone?
It's all the fluids that are coming
These
out.
things,
There's a lot of fluid in there.
the
Like,
baby's
is it
really
really
big. It's like
spray
a
out?
cork. It's a cork, and there's a lot of fluid in there. So when the baby comes out, shit comes out like the tube.
Shit, piss, blood, everything.
Oh, parachute
Dirty,
on
nasty
mine.
call. Right, so once that baby's out, okay, we want to make sure we keep it supported with the level of the pelvis. All right, so here's what we do if the baby does have meconium aspiration, or meconium, right, and nuchal cords, stuff that we saw earlier.
So if the baby doesn't have nuchal cord, when do we cut?
We'll talk about that. All right, so we'll go ahead and just check for that stuff. Now, as far as our partner, okay, because they probably drew the longer end of the stick, right? They're going to be over by the head to soothe, comfort, right? They're going to stay out of the splash zone, but they may catch some verbal abuse, so at least they won't get dirty. Okay, all right. If baby daddy's not there, then unfortunately, partner's going to have to deal with it. All right. So that's the stuff we'll be taking care of. Okay, with the perineal pressure, again, using your gloved hand as it is, or 4x4, right, to go ahead and catch any blood or anything like that, and so we don't have direct contact on the perineum. Now, as far as the rest of delivery, again, pop the shoulders out, baby comes sliding right out, and we want to keep it level with mom's pelvis. Okay, so we'll keep that baby level with mom's pelvis because that baby's still attached to the placenta. Now, if I were to pick it and be like, it's a boy, okay, all that blood, right, goes from the baby and then goes back down to where?
Mom.
Not mom.
Uterus?
Placenta.
Oh.
Right, because again, mom's blood and baby's blood don't mix. Okay, so that blood's going to start going back down to the placenta, and what happens to the baby's blood pressure? It drops. And if I bring that baby down too low, where does all that blood go?
The head.
The baby, and then baby's blood pressure is going to be
Shooting up.
pretty high. Okay, so you want to keep it level with the pelvis, that way we have even blood flow going from baby to placenta. Okay. Don't pull the baby, because we're just playing the what?
Catcher.
The catcher. So let mom do all the work. We're just going to there catch the baby. Okay. Again, very, very covered or slippery, so make sure you have a good grasp on it. But don't poke the baby's eyes or the fontanelles. Okay, because the fontanelles are opening right from the skull into their what?
Brain.
Right. And again, that explains what happens to some of you. Okay, exactly. All right. So, as far as that, just be careful. So when we are assessing, right, infant stuff like that, always use a cupped hand, right, when it going over the head. Okay. So when the baby's out, okay, we're going to go ahead and do 1 minute of what is known as tactile stimulation. 1 minute of what?
Tactile stimulation.
1 minute of what?
Tactile stimulation.
Right. Tactile stimulation, not tactical simulations. Okay. Tactile stimulation. Tactile referring to touch, right? And we're trying to stimulate this baby to get it to cry. Again, a crying baby is a relatively healthy baby. Okay, and that's the whole point of tactile stimulation, is to piss this baby off to get it to cry so we can clear out the airway. All right, by having the baby cry, it's going to clear out any amniotic fluid that it has in the lungs. Okay, and if it's just straight, regular amniotic fluid, is that okay?
Yes.
Yeah, that's what the baby's been in for the last 9 months. That's fine. But if there's any feces in that amniotic fluid, is that okay?
No.
No, right? Because then that's going to be indication of meconium aspiration. Okay, so we want that baby to cry. We can also flick or tap the bottom of the baby's feet. Okay, so we flick or tap the bottom of the baby's feet. Bless you. Okay. We don't do the Babinski test where you hold a baby up by its feet and slap it on the butt. Okay, if you want to do that and slap babies, just go to medical school.
Good.
All right. Again, we can legally hit them if they're choking. All right. So we'll go and do that. We'll do that for a minute. Again, all in an effort to try to get that baby to cry. If we have to, we'll suction out. Suctioning where first? Then because they have what kind of reflex?
Gasping.
Gasping reflex. Okay. Now, when it comes to doing our 1 minute of tactile stimulation, after that time frame is done, we're going to go ahead and do a very special assessment that we use for newborn babies. Okay? That assessment is called APGAR. What is it?
APGAR.
All right, which is appearance, pulse, grimace, activity, and for whatever reason, you guys always forget that second A. Okay, that second A is activity and respirations. Okay, so appearance, pulse, grimace, activity, and respirations. Okay, and we check APGAR a total of 2 times during this process. The first APGAR assessment is done 1 minute after childbirth. The second one is done 5 minutes after childbirth.
Why is that?
Just how they did it. Okay, so the first APGAR is 1 minute after delivery. The second one is 5 minutes after delivery. Okay, so let's say the baby was born at 21:45. When do I check my first APGAR score?
21:46.
21:46. Right. When do I check my second one?
21:50.
Right, 21:50. Here's one. I don't know. Okay, 1 minute and 5 minutes after delivery. All right. Now, as far as newborns, okay, peripheral cyanosis is okay. So blue hands and blue feet, that's fine. Central cyanosis, however, is not okay. Now, the reason why peripheral cyanosis is fine, that baby's been crunched up like this for the last 9 months, so it's going to take a little bit of time once it's actually out for that blood to go all the way out to the distal extremities and give it decent color. Right? So blue hands and blue feet, totally fine, but if the baby has central cyanosis, okay, that's not good. That means that all the vital organs are not getting enough oxygen, right? And we're going to see some other deficiencies to go along with that. Okay? Now, as far as the newborn's respiratory rate, okay, we're going to calculate that based on its cries. So every time the baby goes, wah, okay, we count that as a breath. All right, and it shouldn't go anywhere past 60 breaths per minute. So basically 1 wah per second. Okay, and we'll use that in our APGAR assessment. Now, as far as a perfect APGAR score, a perfect APGAR score is 10. How many?
10.
Okay, not to be confused with the Glasgow Coma Scale. Bless you. Okay, so perfect GCS is of course 15, but a perfect APGAR is 10. Okay, and with APGAR, scores range from 0 to 2. Right, and that's per letter. So starting off with appearance. Okay, baby gets 2 points for appearance if it has a pink core all the way through. It's pink all the way throughout. Okay, so baby gets 2 points for appearance if it's pink all the way throughout. That includes the core and the extremities. Baby gets 1 point for peripheral cyanosis. So blue hands and blue feet. Is that okay?
Yes.
Yeah. Okay, peripheral cyanosis is fine for a newborn baby. What's not okay is if they have central cyanosis or they're pale, and therefore the baby gets no points for appearance. Okay, so unlike the GCS, right, in APGAR, babies don't get just participation points for being there. Okay, whereas the GCS you do. Everyone scores at least 1, right, per category. But the APGAR, you can score a big fat 0, which means the baby's dead. All right, so as far as appearance, again, the only point that they can get docked and still be okay will be here. So perfect is 10, acceptable would be 9. If and only if the only point taken away is under the appearance category. Okay, because everything else that's going to score a 1 is not good. Okay, and may require some form of resuscitation. So when it comes to pulse, this one's pretty easy. Okay, it's over or under 100, right, to determine 2 versus 1. So if the baby has a heart rate over 100, they get 2 points. If it's under 100, they get 1 point. No pulse, no points. Okay, so the baby's got a heart rate of 110, for example. All right, cool. Baby gets 2 points. If the baby's got a heart rate of 88, not the greatest. Baby gets 1 point. If the baby's pulseless, baby gets no points. All right. As far as grimace or irritability, okay, we want to see if the baby's crying, and we're going to assess the cry if it's a nice, good, strong cry. And we're also going to do a little bit of tactile stimulation, okay, where we go and flick or tap the bottom of the baby's feet. Okay, now this baby is having totally new experiences, right, and has no idea what the hell we're doing if I flick the foot. So its natural reaction is to flinch and start going away from that stimuli. Okay, so as I flick the feet, the baby should kind of start jerking in that extremity away from that stimulus. Okay, and if it has a nice quick reaction, baby gets 2 points. But if I flick the bottom of the foot and the baby's like, and slowly brings it back up, okay, baby gets 1 point. And if the baby's limp, it doesn't do anything when I flick the foot, baby gets no points. Okay, so a good strong reaction as we flick the feet, 2 points. Slow, kind of reaction, baby gets 1 point. Baby's limp, baby gets no points. All right, now as far as the second A, activity, okay, we're going to be checking to see if the baby's flailing his extremities, which usually they are. Okay, and we're going to gently, again, that is gently, the key word is gently, okay, pull on that baby's leg. Okay, so very carefully and very gently pull on that baby's leg. All right, and again, that baby's not going to be happy about that, so it's going to try to pull its leg away from it. Okay, so you want to see if the baby has a nice, strong pull as I'm gently pulling on the leg. If the baby has a very weak pull, baby gets 1 point, baby's limp, doesn't do anything, baby gets no points. Okay, so that is going to be activity. And then respirations, there's no numbers that you have to worry about, it's just fast versus slow. Right, but most people go based off 40 to 60, right, being okay. So again, 40 to 60 whams per minute, okay, will be considered 2. If it's under 40, baby gets 1 point, and if baby's apneic, baby gets no points. Okay, so 40 to 60 for 2 points is considered rapid respiration, where that's okay, since that's about their normal breathing rate. If it's less than 40, baby gets 1 point. If baby's not breathing, baby gets no points. Okay, so be running this assessment how many times? How many times?
Twice.
When do I check the first one?
First minute.
1 minute after delivery. Second one being?
5 minutes
All right,
after.
5 minutes after delivery. Okay, not 5 minutes after my first APGAR, but 5 minutes after the baby's been delivered. Okay, we go on document and we go from there. All right, so any questions on APGAR? Yeah.
What if the baby's born asleep? Because I personally, and I know people have been born asleep. Like babies are just born asleep. They just don't cry and they're just.
Then we try to wake them up.
That's what I'm saying. Like I know, like I'm not in sleep, but babies just won't cry because they're asleep. What would we do then?
If the baby's not responding to stimuli, then we're going to start doing resuscitation.
Oh.
Yeah. Right. So if that baby's not doing anything, just kind of limp, that's not good. Right. And again, since they're brand new, that kind of stuff is going to freak them out. Try and get them to start crying.
So like, do we clean the baby or do we just leave it with all the stuff on?
No, we clean it. So part of tactile stimulation is wiping and drying the baby now too. Right. Where we can also do the flicking, tapping the feet. All right. So when it comes to clamping and cutting the cord, okay, we do that after that first minute of tactile stimulation because I'm trying to see if that baby's ready to go. And once I do the first APGAR, baby has a 9 or a 10. All right, cool. Baby's ready to go. Okay, if the baby has a poor APGAR score, then we leave the baby attached because the umbilical cord is quite literally the baby's lifeline. Right, so that baby's still going to be getting stuff from mom's blood via the placenta, right, into the baby. So if baby needs a little extra oxygen, okay, mom might be able to deliver it. We'll talk about what to do for resuscitation. Okay, we want to leave that cord attached. Now, there's different clamping and cutting protocol based on LA County versus DOT. So for LA County, because they do not trust you with sharp objects around babies, justifiably so, okay, we're going to take our first clamp and go 4 to 6 inches away from the baby. Okay, so LA County, since they don't trust you with sharp objects around babies, okay, first clamp goes 4 to 6 inches away from the baby. We clamp that, and I take my second clamp and I go 2 inches closer to mom, and I clamp that. Okay, so my first clamp, 4 to 6 inches away from baby, clamp it. Other clamp's going to go 2 inches closer to mom, clamp it, make sure there's no pulse in the middle, and then we go and cut the cord.
Do you ever have to transport with the umbilical cord still?
Yeah. It's not going to be attached to mom directly, right? But it is still going to be hanging off. Right? We're going to have a buffer course. Very rarely do we have to. Yeah, if it's a poor APGAR score, then yeah. But again, we'll be clamping after 5 minutes because we'll talk about what to do for resuscitation because we're not just going to leave the baby there indefinitely.
The second clamp was 2 inches away from the mom?
2 inches away from the first clamp, towards mom. All right, now DOT, because they do trust you with sharp objects around babies, and clearly DOT hasn't met you guys yet, okay, our first clamp is going to go 1 to 2 inches away from the baby, with the second clamp 2 inches closer to mom. Okay, so our first clamp 1 to 2 inches away from the baby, second clamp 2 inches after that, clamp, make sure there's no pulse, and then we go and cord. All right, again, we just want to make sure there's no pulse between those clamps, because if there is a pulse, what's going to happen to the baby? It's going to bleed out. Okay, because we're feeling baby's pulse, not mom's pulse to the umbilical cord. All right, now once we have clamped and cut the cord, okay, we're now ready to wrap the baby up, because a cold baby is a dead baby.
If the mother's partner is there, we let the cut cord, or is it
Sure.
we have to do it?
No, we can do it. They can do it if they want to. That's fine. They haven't passed out yet. So we'll go ahead and get ready to wrap the baby up, because cold baby is a
Dead baby.
All right. Again, as we said earlier, kids don't have the ability to generate their own heat, especially a newborn baby that's just a couple of minutes old, if that. Okay. Baby's been in a nice, warm, wet environment, so we want to try to keep it as warm as we possibly can.
Keep room temperature.
Okay. No, not room temperature.
I said room temperature.
Right. So, if we can. So, again, we'll suction if we have to. Check APGAR 5 minutes after delivery. And usually after that second APGAR score, if the baby's fine, then we can pass the baby off to mom to start encourage breastfeeding and things like that. Okay, so 5 minutes after delivery, after our second APGAR, if everything checks out, give the baby to mom, encourage breastfeeding, start doing all that kind of stuff. And then we just wait for placental delivery. So, with the second stage of labor done, we're now going to get to the third stage. Right, so again, stage 1, onset of regular uterine contractions up to full dilation of the cervix. Stage 2, cervix is fully dilated up until we have expulsion of the infant. And then stage 3, delivery of the baby up to delivery of the placenta.
Wait, so I thought that if they don't pass APGAR, we don't cut the umbilical cord.
If they don't pass the first APGAR, we leave it, yeah. After the second APGAR, then we cut it. We'll talk about resuscitation in a bit as far as if we have to do it. Okay. After that, we're just going to wait for delivery of the placenta, and there's going to be imminent signs that we'll cover on the next slide. That way we know that placenta is ready to come out. Okay, then we'll get ready for bleeding control and whatnot, right, as we move on from there. So as far as stage or time of second stage, again, it depends on how many deliveries she's had in the past. The more deliveries she's had, the faster the whole process will be. Okay, that also goes for third stage when we have delivery of the placenta. Placenta parachute. So, as far as delivery of the placenta, okay, there are 3 imminent signs. How many imminent signs?
3.
How many imminent signs?
3.
Right. Okay, so the first one is going to be another urge to push or another round of contractions. She may phrase it as either way. Okay, whereas signs of imminent delivery for the kid, they're separate things. Okay, so when the placenta is ready to come out, she's going to say, oh, I got to push again, or I think I'm having more contractions. Okay, and as that placenta is going through the birth canal, we're going to have an elongation of the umbilical cord. Okay, because at this time, there's still going to be some of the umbilical cord hanging out of the vaginal opening. And as that placenta is going through, it's going to appear to get longer. And finally, right before it comes out, there's a gush of blood. Okay, so we have another urge to push / round of contractions, elongation of the cord, and then gush of blood, and then that placenta comes out.
Are we supposed to catch it like that?
With gloves, yes. All right. Now, once that placenta is delivered, okay, we have to inspect it for any missing pieces, any tears, lacerations, or abnormalities. Okay, so check for any missing pieces, tears, lacerations, or abnormalities. Okay, we also have to keep in reference time. All right, because that placenta should be delivered within 30 minutes or less. Okay, so placenta delivery.
Free?
No, it's not free. It's a complication. It takes longer than that. Okay, but yes, just like a pizza, it should be within 30 minutes or less. Okay, and also like a pizza, it should be round in shape. So now you guys are all craving cheeseless pizza right now.
I've never craved a cheeseless pizza in my life.
So you would look for missing pieces, lacerations, and what else?
Any other abnormalities? All right, so if there's any pieces of the placenta left, right, now we got to worry about possible hemorrhage and or sepsis later on down the road. Okay, and that's going to be CO3 call. We don't do anything about it. We just go, oh, crap, that's not good. And then we go. Okay, now after we have that placenta delivered, we've inspected it, we're going to place it in a plastic bag and then prepare it for transport.
Is this placenta okay?
Yep. All right, now once that placenta's out, that's it. Childbirth is done. Okay, so she doesn't have to go through it again unless she's about to have another kid, like a twin, or a triplet, or again 7 more kids in case of octomom, or if she's going to have another kid later on down the road. Yeah.
What if a patient or a patient's spouse asks to keep placenta?
we'll just go ahead and say, all right, we just need to check it. You can do it without the hospital, right? Because they need to at least assess to make sure that it's good to go. All right, then they can buy it back or do whatever they have to do. So as far as bleeding, okay, we're going to take an OB pad, place it over the vaginal opening, right? And when we have any type of vaginal bleeds, that's the only dressing we can completely take off and replace with a fresh bandage. Okay, all other bleeds, right, we leave the blood-soaked bandage on. Okay, but in the case of vaginal bleeds, especially after childbirth, okay, we can swap out vaginal pads as needed. Now, as far as excessive bleeding, anything more than 500 mLs of blood loss throughout the entire childbirth process will be considered excessive. Okay, so anything over 500 mLs is considered excessive, which again is a whole water bottle full of blood. But keep in mind, does mom have more blood in her body during pregnancy?
Yes.
Yeah, so could she tolerate 500 ml blood loss?
Yes.
Probably, right? But we just want to play it safe. Because again, that's external bleeding. Is there always a possibility of internal bleeding?
Yes.
Yeah. Okay, now to identify that, we can go ahead and check how many pads we've actually used. Okay, usually about 3 or more pads is an indication of excessive bleeding. Right, the pads can hold anywhere between about 125 to 150 mLs from what I've read. Okay, and again, that 500 ml total is the amount of blood loss from start to finish. Okay, so there usually is going to be somewhere between about 75 to 125 mLs of blood loss before the first pad even goes on, right? And we have to factor that into account as well. Okay, so once she's gone through 3 pads, that's enough to be considered excessive. As far as potential delivery, if it takes more than 30 minutes, right, that too is considered a complication. Any missing pieces, tears, lacerations, anything like that. Okay, these are all code 3 indicators. All right, now as far as bleeding control, okay, we can perform a fundal massage. What kind of massage?
Fundal.
What kind of massage?
Fundal.
Not fondle, but
Fundal.
fundal. Okay, where we do a fundal massage to massage the uterus. Okay, now there's a bunch of different ways to do a fundal massage. Okay, you can kind of roll it like this, like a ball of dough. You can go side to side. You can knead it like that. Just no shiatsu, right, over the uterus. Okay, and it's going to be quite painful. All right, so if baby dad is available, you did this. All right, so you go and have him do the fundal massage. That way he can get cursed out. If not, we want to do that. Okay, she can refuse the fundal massage, but we want to tell her what the purpose of it is, which is to contract the uterus to help control bleeding. Okay, so tell her, hey, it's going to be really uncomfortable, it's going to be quite painful, but we're doing this to help reduce the amount of blood you're actually going to lose. Okay, breastfeeding does the same thing, right? But it's going to release a hormone, all right, that's also going to help with that uterine contraction, but the fundal massage will help stimulate that to contract as well.
So that massage is only for complications?
No, just once we deliver.
Oh.
Yeah, we do it regardless. Okay, we just do it to help reduce bleeding. All right, again, if the OB pad gets fully saturated with blood, what do?
Change it.
Right, swap it out. Okay, we'll put it in another bag if possible. That way we take it and the doc can see, oh, she's bled through 2 pads, we're good.
Fundal massage still sterile BSI, or can we use the...
We can swap, but at this point we'll switch out. That way we don't have all this bloody stuff just massaging over the abdomen. All right, well again, once that sun is out, we can go and discard regular or sterile BSI, go back to sterile gloves. Or regular BSI. So we'll go and transport. If everything checks out and there's no complications, how are we transporting her? Code 2. Okay, it's a simple code 2 call if there's no complications with delivery. If we have any type of complications, now we go code 3. Right, so now we're going to start getting into our delivery and post-delivery issues. One issue that can happen after childbirth, and I don't know how frequently it happens, but apparently enough where we have to worry about it, will be development of a pulmonary embolism. Okay, so if we have a non-complicated childbirth, right, everything's good to go, and then mom all of a sudden goes, oh, and has a sharp pinpoint chest pain, has good tidal volume and crappy O2 sats, crap, right, we're suspecting pulmonary embolism. Okay, so now we go from code 2 and upgrade to
Code 3.
Code 3. Okay, and if we can, let the hospital know ahead of time, hey, we delivered in the field, everything was fine, but mom now all of a sudden has sharp pinpoint chest pain, O2 sats are decreasing, thinking possible PE, we're going to be coming here code 3. All right, that way the hospital goes, oh crap, now we have to start getting ready for that stuff too. Okay, so obviously there's nothing we can do about the pulmonary embolism, but just upgrade to code 3, rapid transport to the hospital. All right, so with our delivery complications, okay, we have unruptured amniotic sacs. Again, just because she's about ready to deliver doesn't mean the amniotic sac is rupturing right there, right now. If it does break, it can happen hours before she's actually ready to deliver the baby. Or it, again, may not rupture at all. Okay, so the water breaking is not considered a sign of imminent childbirth. Now, if the amniotic sac has not ruptured, okay, we pinch it, twist it, pull it. Don't bop it. Okay? So, again, we pinch it, twist it, and pull it. Okay, and you better have fast hands because now all the amniotic fluid starts rushing out. Again, splash zone. Okay, so we're going to see a thin film over the top of the baby's head. If we see crowning, we're like, oh crap, right? She says her water hasn't broken yet. Well, I guess we have to do it. Okay, and then once we manually rupture the sac, we just deliver as normal. Okay, we've already talked about nuchal cord. First thing I want to do is try to slip it over there. And if that doesn't work, what do we do?
Clamp.
What do we do?
Clamp, cut.
Right, we clamp, cut. Okay, so get your OB clamps wherever you can. Okay, there's no 2-inch spread like a regular clamping of the cord. Just get them wherever you can. Make sure there's no pulse. Cut the cord, and then once that baby's out, we haul ass to the hospital. All right. Now, the other complications that happen during delivery, one of them we can deliver, 2 of them we can't. Okay, so one of these 3 we're able to deliver, 2 of them we can't. All right, and we'll talk about them right now. So, starting off with breech delivery. Okay, breech delivery we are able to deliver in the field. Okay, so we can deliver breech in the field. With a breech delivery, this is where the baby comes out both feet first or possibly butt first. Okay, so it comes out backwards. Now, the main issue with breech delivery is that baby's weird big shaped head getting stuck in the birth canal after the rest of the body comes out. Okay, now if that happens where the baby's head gets stuck, we're going to give mom one chance to try to push the baby out by herself. Okay, so we'll give her 1 round of contractions to try to spontaneously deliver that baby on her own. If that first delivery is unsuccessful, okay, then we have to take action. Okay, and this will be the first of 2 times that we can take our gloved fingers and place inside the mother. Okay, no, we don't do it for a cervical check, sir. Okay. So, if mom has a breech delivery and the baby doesn't come out, okay, we take our gloved fingers, place inside the baby's, in front of the baby's face, right, and we make a V. Okay, so take our gloved fingers, place inside the mother, and make a V in front of the baby's face. Okay, the reason why we do that is to create an airway for this baby. Now, there's a lot of critical things that happen within the first few minutes, right, of this baby being delivered. Okay, this whole time while the baby's in the birth canal, the baby's like this, right, as it's going through. So there's no room for chest expansion, and because the baby's still inside mom, can it actually breathe? No. All right, but once that baby's out, it's got so much room for activities, okay, where that baby's now able to breathe, right, and start having chest expansion. Okay, and these babies want to be independent as soon as they can. Okay, now we still have that lifeline of the umbilical cord that can transfer oxygen, but again, the baby's stimulus to breathe is when that chest is no longer under pressure and it wants to expand, right? And if the baby's head's stuck and the body's hanging out, that chest is able to expand, therefore giving it the stimulus to breathe. But because, right, it's still in the birth canal, right, everything's still in its face. Okay, and we're going to stay like that until mom either spontaneously delivers the baby or we get to the hospital. Okay, so we'll keep our fingers inside the mother with the V in front of the baby's face until mom either pushes the baby out on her own or we get to the hospital, right, and they can go and deliver it that way, usually requiring a perineal incision to give more space for the head to actually come out. All right, but other than that, we just transport. Okay, obviously try to support the baby's head too, or the body rather. All right, don't just let it just sit there and just do this.
Baby got a cool mom-shaped hat.
All right. So, we'll go and transport. Now, as far as limb presentation, okay, we cannot deliver a limb presentation. All right, with the limb presentation, we have 1 leg or 1 arm, okay, they'll be coming out before everything else. Okay, so if you have a leg sticking out, and it's just kind of there, or you have an arm and it's waving at you, okay, we can't deliver that in the field. All right, instead what we do is take a dry sterile towel and we cover up the exposed limb because cold baby's a dead baby. Okay, so that extremity is going to start radiating heat off from the body, therefore cooling the baby down, even though most of it's still inside mom. Okay, with this, we go, oh shit, okay, and we go. All right, this is just a load and go because there's nothing we can do about it. All right, that baby's still going to want to try to come out. Okay, so it's just a race against the clock. Okay, so let's try to get to the hospital as soon as we can, where they will have to go into an emergency C-section to get that baby out. All right, so depending on what limb is coming out, since we have a leg coming out here, right, this baby's going to be too big to where it starts to get stuck in the birth canal, and if it does happen to get through, that foot is not going to be up over here, right? And again, it's just all too crowded and congested to where it can't be delivered naturally. All right. Now, the other one we cannot deliver is a prolapsed cord. And that's where the cord is coming out over the top of the baby's head. Okay, now the first thing we do if there is a prolapsed cord is we check the pulse. What do you check?
Pulse.
What do you check?
Pulse.
Right, we're checking the pulse and the umbilical cord. So you just pretty much pinch the cord to see if it's pulsating. If the cord is still pulsating, we don't do anything. Just keep reassessing the pulse. Okay, but as soon as that pulse is gone, then we have to take action. All right, now what happens to stop that blood flow is the baby's head is compressing the walls of the umbilical cord up against the walls of the pelvis, pinching it off like garden hoses. Right, and then we can't get any blood flow from the placenta to baby. Once that pulse is gone, okay, now we take action, and this will be the second of 2 times we can place our glove finger inside the mother. Okay, and what we want to do is displace that baby's head off the cord. Okay, that means shifting it anterior posterior, not pushing the baby back in. Okay, so you pretty much just have that baby flex their head either way to try to get that pressure off the cord. Okay, and we have to leave our hands there until we get them out to the hospital where they can go and do a C-section. Okay, so again, this is just another race against the clock. Just haul ass, right, where they can go ahead and get that C-section done.
So like you're like lifting the baby's head off?
We're just, displacing it off the cord. Yep. All right. So we'll go and transport, right? Support treatment as best as we can and just go. All right, but again, we only take our glove fingers in and place it once there's no pulse. All right. So that's going to cover all of our delivery complications, and now we start getting to post-delivery, primarily neonatal resuscitation. So with resuscitation, okay, you have to know what to do and when to do it, because if you don't know what to do and when to do it, what's going to happen to the baby?
Die.
It's going to die. Okay, now killing an adult, and that's one thing. Right? Killing a kid, bad thing. Killing a newborn baby, really, really bad. Okay, and you have to know, again, what to do and when to do it, because even if you hesitate to do the right thing, it's going to be too late. Okay, now as far as assessment, right, and what we have to do, okay, it's based on pulse and respirations, and I like to take skin signs into consideration as well. Okay, so pulse, respirations are the main factors to determine what we have to do and when we have to do it, but I also like to consider skin signs. Okay, now newborn heart rate should be somewhere between 120 and 160. That's where it should be. Should be textbook, perfect example. But as long as it's over 100, is that okay?
Yes.
Yeah, as long as heart rate's over 100, baby's got good skin signs, good respirations, good activity, good APGAR score, we don't have to do anything out of the ordinary. Okay, so with heart rate between 100 and 120, good skin signs, good respirations, just do everything we normally would. So nothing out of the ordinary there. However, if we have a baby who's got a decent heart rate, okay, so heart rate looks good, central cyanosis, that's not good, but they have adequate respirations, okay, all we have to do is get them blow by oxygen. Okay, so if they have a decent heart rate, crappy skin signs, but good respirations, all we have to do is give them blow by O2. Okay, now with the administration of blow by oxygen, okay, we just go ahead and take oxygen tubing and pretty much just blow in front of the baby's face. Right, we don't want to give it direct oxygen, bless you. Okay, because babies are prone to oxygen toxicity. Or of course, too much of anything is bad. Okay, now these babies are tuned to work on room air. Okay, a newborn baby is tuned to work on room air. So it doesn't take a lot of oxygen to fix this baby. You give them too much, you're going to cause detriments. Okay, and again, you have to know what to do and when to do it, because if you hesitate to do the right thing, okay, it can still be too late. Just recently I read an article about a paramedic in the UK. Apparently this was not their fault, but they were just super duper overworked, and the guy delivered a baby in the field, right, that had central cyanosis. Right, so mom was kind of borderline critical, so he's taking care of her and the baby by himself and no partner as they're going to the hospital. All right, so he's having to bounce back and forth, focusing on mom and not paying attention too much to the baby. Neglected to give the baby blow by O2, and the baby suffered brain damage. Right, so again, doing the right thing but too late, okay, can cause a detriment for this baby. And again, this is a newborn baby, right, that now has brain damage for the rest of its life. Okay, all because he simply didn't do what he was supposed to right at the time. Now, like I said, they even interviewed the mom, and it's like, it happens, right? So fortunately, she's one of the few people that actually says, you know what, this is what I'm dealt with. At least my baby's still alive, right? But now we got to worry about that kind of stuff. Other people, not always so fortunate. Okay, so you hesitate too long, right? You cause brain damage, right? And just straight up kill the kid if you don't do it right. Okay. Now, if they have inadequate respirations, if you have any patient with inadequate respirations, what do you do for them?
Ventilate them.
You breathe for them. Okay, so now we go and start using our BMV, but we use it on room air, and we ventilate for 30 seconds. Okay, so baby's got a good heart rate, crappy skin signs, and now we have crappy respirations. All we have to do is get that room air from the environment and into the baby's lungs. Because again, babies are tuned to work on
room air.
Now, as far as the ventilation rate when using a BMV on a neonate, it's 40 to 60 breaths per minute. Okay, so we're going to squeeze that bag at a rate of 40 to 60 breaths per minute. All right, I just want to get that air from the environment into their lungs, right, to bring their oxygen levels back up, get them breathing, and this should be fine. Okay, now if the baby starts getting worse, then we go down to the next step, where the baby's got a heart rate less than 60, above 60, but less than 100. Okay, so crappy pulse. With central cyanosis, we don't care about ventilations. Okay, so baby's got crappy heart rate, right? Less than 100, but greater than 60. And central cyanosis. So now all we have to do is, again, get that room air into their body by using the BMV on room air for 60 to 90 seconds. Okay, so we go and hook them up to the BMV, ventilate for 60 to 90 seconds at a rate of 40 to 60 breaths per minute, and then we reassess. If the baby hasn't changed, then we go and hook them up to oxygen for 30 seconds, continue ventilating, and then reassess and readminister as needed. Okay, so we just go and keep on ventilating, hoping the baby gets better. If they do, then we just move on to the next step. Or if they get worse, okay, where the heart rate gets below 60 beats per minute and they have signs of poor perfusion, what do we start doing?
CPR.
What do we start doing?
CPR.
What do we start doing?
CPR.
Right, just like we would for any other pediatric infant or neonate, again, this being neonates, with a heart rate less than 60 and signs of poor perfusion. Okay, now like I said earlier, with neonatal CPR, it's a totally different ratio. It is a 3-to-1 ratio. What kind of ratio?
3 to 1.
What kind of ratio?
3 to 1.
So that's 3 compressions to every
1 breath.
1 ventilation. So 1, 2, 3, ventilate. 1, 2, 3, ventilate. 1, 2, 3, ventilate. Okay, all in an effort to try to keep their respirations up super high. Okay, so knocking out that 3-to-1 ratio, 3 compressions for every 1 ventilation. Now, as far as the way in which we're going to be doing these compressions, okay, it's going to be the same as I would for an infant. So if I'm by myself, I do the 2-finger technique. If I got a partner, I use my 2 thumbs. Okay, but we still use the same ratio. 1, 2, 3, ventilate, or 1, 2, 3, ventilate. Now, as far as depth, okay, because these babies have pretty much no bones in their body whatsoever, they're super duper soft and squishy. Therefore, I only have to push 1/2 inch to 3/4 of an inch. Okay, so it doesn't take a lot of force to compress on a newborn baby. Okay, so if you even do infant CPR where you push 1.5 inches, okay, you can start actually causing damage to this baby by pushing too deep. Okay, so we just want to go 1/2 inch to 3/4 of an inch deep as we're doing compressions. 1, 2, 3, ventilate. 1, 2, 3, ventilate. 1, 2, 3, ventilate. Right, and we just keep on doing that until we see the baby getting better or we get him to the hospital. All right, so any questions on resuscitation? Yeah.
Is there the speed is for
same 100 to 120?
Okay.
Yeah. All right. Any other questions? Cool. All right. So as far as other complications, we have to worry about spina bifida. So that's going to be a defect in which part of the spinal cord is protruding out of the vertebrae. Okay, so sometimes we see it and it looks like a blister on the back of the baby. All right, there's nothing we really do about that to fix it. Okay, all we do is try to keep it moist. I don't know why. Right? It is going to be covered somewhat by skin. But we're going to use a moist dressing to go over the affected area. But, again, that cold dressing, okay, is going to start sapping body heat, and a cold baby is a
dead baby.
So we want to try to preserve that heat as much as we possibly can, okay, when we have to treat a baby for a spina bifida. Okay, so that means when you're transporting, you want to turn on the what?
Heater.
Turn on the heater, right? Keep them wrapped up, right, to try to maintain that core temperature. Okay, other than that, we just transport, take care of whatever else that we see. Okay, but again, for spina bifida, moist sterile dressing over the affected area. Okay, try to make sure you're keeping that baby nice and warm as you transport. Right. When it comes to abortions, right, so this is going to be termination of pregnancy before 20 weeks. Okay, and it can be spontaneous, where it happens medically. It can be induced, right? And the main issues we have to worry about with these are going to be excessive bleeding and/or possible infection, causing either hemorrhagic hypovolemic shock or possible septic shock. Okay, any tissue that passes through the vagina, we have to go and transport to the hospital just for them to go ahead and see what's going on, things like that. Right. Now, when it comes to fetal demise, aka stillbirth, okay, this is going to be ending in pregnancy after 20 weeks. Okay, because 20 weeks is like the cutoff for viable fetus at this point, right? Where if they're born after 20 weeks, they can be incubated, stuff like that, and they can still, live. Whereas before 20 weeks, there's not enough development going on, so usually it's not going to survive. In the case of obviously dead neonates, okay, we don't provide resuscitation. Okay, so that can include our signs like dependent lividity, okay, sometimes rigor mortis, but also in the case of a newborn baby, any deformities that are not consistent with life. Okay, so development or non-development of vital organs, things like that. All right, so if we see any of those, then we don't provide resuscitation because, again, once we start, can we stop? No. Okay, now as far as this, delivery is going to go as it would if the baby were alive. Okay, so she's going to be going through all the things. We do everything as we normally would. It's just once the baby's out, right, it's not alive. Right, and if there's obvious signs of death, we don't provide resuscitation. As far as substance abuse, okay, so that's why we ask about any use of drugs or alcohol, because obviously can that have a negative effect on the baby?
Yes.
Yeah. Okay, we have an increased risk of premature delivery, increased risk of respiratory issues. Okay, again, we may have developmental issues that occur. All right, so we just need to ask, right, have you been using drugs or alcohol during pregnancy? Is she always going to tell the truth?
No.
No. Okay, but you just tell her, hey, we're not going to get you in trouble. We just need to know. That way, if you are going to deliver, we have to know what we have to be ready for. All right, just tell her, hey, we just got to know, just so we know if it's going to make our job more difficult or not. That's it. Okay. So we'll be looking out for that. As far as any type of abuse, okay, all the questions we talked about earlier when it comes to child abuse, we'll use those same questions tomorrow when we talk about elder abuse. Just substitute child with geriatric patient. And in the case of a pregnant woman, okay, wherever it says child, we substitute with pregnant woman. Okay, so we have to look out for any type of physical abuse of the abdomen, which can lead to which of our placenta problems? Well, what do we call it?
Pre-E.
I got it.
Thank you. Right, placenta abruptio. What is it?
Placenta abruptio.
What is it?
Placenta abruptio.
Exactly. Placenta abruptio. Okay. Where, right, that placenta is suddenly and abruptly tearing off the uterus.
Abruptio.
Okay. So she's gonna have that ripping or tearing pain as the placenta is being ripped or torn, right, off of the uterus. Okay. So we want to look out for that stuff, right, and be worried about those kinds of things there. Now, in the case of trauma, okay, our trauma guidelines don't really change much for a pregnant woman, but how many patients do we have now? Two. Right, we got mom and we got baby. Okay. So as far as blood volume, again, mom is going to have more blood volume in her body, so she's more likely to tolerate blood loss. Okay, we're still going to use the same 500 mLs for everybody. Again, just to play it safe. Hey, if she loses 500 mLs, she might be going in a shock, but if she does lose it, hey, she's got a little bit extra blood to compensate. Okay, same thing with more platelets, all that kind of stuff. Now, when it comes to cardiac arrest, okay, cardiac arrest treatment doesn't change. And yes, we will still defibrillate, right, a pregnant woman. Okay, again, if mom's dead, who else is probably going to die? Baby. So, try to do whatever we can. The only difference is that we tell the hospital that she's pregnant and in cardiac arrest, and that's it. Okay, and they'll do whatever they can try to do at the hospital to try to save the baby and mom as well.
Do we ever worry about the placement of the lower patch? Because the onion is close to the abdomen, to be not like.
It's closer to the abdomen, but again, we still want to get it up pretty high right down here. Yeah.
If there's a scenario where it's clear like one or the other is going to die, do we focus on one before the other?
Yeah, and usually mom is going to save herself before trying to save the baby. Right. So that's where we may have things like, an early delivery where she's in, stress. At 6 months, she may just deliver the baby to get it out, right? That way she can save herself, right? So again, that may be an instance there. So as far as spinal mobilization, okay, we have to do the whole spinal mobilization process in the supine position, but what do I have to be considerate of?
The supine hypotension.
Yes.
Supine hypotensive.
Yeah, supine hypotensive syndrome. What do you have to worry about?
Supine hypotensive syndrome.
Which is?
Supine hypotensive hypertension.
Hypotension in the supine position that happens because the weight of the baby is compressing what blood vessel?
The inferior vena cava.
The inferior vena cava. Okay, so because that baby's squishing it down, that blood can't go back up to the heart, therefore causing blood to go out. Okay, so.
You lay in like left lateral and backward?
Well, once she's on the board, then we tilt everything left lateral. Okay, so we have to put her on the board supine, but as soon as that's done, put stuff on the right side so it tilts her to the left side. Okay, and we go and transport that way. All right, so we want to go ahead and try to prevent that and get that done as soon as we possibly can. Okay, so that's why we can't sit there and take 7 minutes to put mom on a backboard, right? We want to do that as quickly as we can to reduce that risk, because mom's going to be hypotensive, baby's going to be hypoxic, and is that baby going to be happy?
No.
No. So what's that baby going to do?
Die.
Before that,
Oh.
it's going to poop itself, and what do we call that? Meconium. Okay, so we got to worry about that and crap. Literally, now we have to go ahead and get transport. And if we don't do anything, then the baby dies. Not like mom's there and just, baby dies. Okay, right, we're going to start seeing that. Now, as far as our trauma guidelines, we still do the same thing as you would for any other patient. So if mom has a musculoskeletal injury, follow your rules of splinting, right? Bleeding control, treat it. Okay, so nothing's going to change much in terms of our general guidelines. We just have 2 patients to worry about now. Okay. Now, when it comes to multiple gestation, okay, usually it's just 1 delivery, right? But twins are fairly common, right? So about 1 out of every 30 deliveries, right, is going to be twins. Okay. Now, as far as delivery of twins, it doesn't really affect our skill that much. We just now have 2 babies to deal with. Okay. When it comes to identical versus fraternal twins, right, it's not anything you have to know. It's slightly different. So fraternal twins, baby 1 comes out, followed by placenta 1, then baby 2 followed by placenta 2, since there are 2 different babies developing at the same time. With identical twins, baby 1, baby 2, and then placenta will then come out. Okay. Now, as far as the delivery of twins, usually it's not a big deal. However, the twins are going to be a little bit smaller, even though they carried full term. Okay, and the reason why they're smaller is because
They share the same space.
right. So they got womb mates. Okay. So, okay, because they're a little womb mate, okay, they're going to be a little bit smaller. We had all class for that one. So, as far as that, okay, we'll go and deliver. Again, they look premature, but we ask, when's expected to, how long, when's the last period to determine what's going on. Now, as far as the twins, okay, we do want to record the time of each twin separately. So usually it's about 10 minutes or less between the twins, depending on the type of twins that they are. Okay, and you want to try to keep them separate so we know who's who. Okay, which one was delivered first, which one's delivered second. Okay, and you want to try to figure out ways to do it without taking your marker and writing thing 1 and thing 2. Okay, so wrap them up different ways. If you got resources, hey, you're responsible for this baby, you're responsible for that one. Okay, that way we know who's who. And again, we'll document times and stuff like that.
Yeah.
What's that?
Put a piece of tape on one.
Put a tourniquet in that one.
TK.
That's just like quote unquote.
You can just put a piece of tape without being a tourniquet.
So, as far as premature deliveries, okay, so a premature infant is defined as somebody who is born before 36 weeks or who weighs less than 5 pounds at birth. Okay, so low birth weight of under 5 pounds or delivery before 36 weeks, okay, will be defined as premature. So as we can see, right, they're going to be a little bit smaller. Okay, there's also respiratory issues we have to worry about. Okay, so depending on how early this baby was born, it may be apneic upon delivery. So what do you have to do for that at that point? Breathe for them, right? So we've got to start ventilating at a rate of
15. Oh, wait.
40 to 60 breaths per minute. Okay, if that baby's bradycardic with a heart rate less than 60 and signs of perfusion, then we start doing what?
CPR.
At what ratio?
3 to 1.
3 to 1. 3 compressions, 1 ventilation, right, and so on and so forth. Okay. As far as delivery of the premature baby, though, there's really not much that changes. We deliver it the same way. Okay, so wipe, sterile gloves, suction, blah, 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 blah. All that stuff's going to be the same. And we tell the hospital, hey, do we have a premature delivery? That way they can get us set up at the NICU to go ahead and deliver the baby there, or transport the baby there rather. All right. Now, on the opposite of premature, we have post-term, okay, which is going to be delivery of a baby after 42 weeks. All right.
That baby's about to throw hands.
That
baby to the left is like giving him mad dog eyes. He's like, why are you here?
20 pounds. I'm like, cut this.
He could beat the shit out of me without trying.
Exactly. All right. So, as far as this baby, right, it's not just straight up post-term. Right, it's post-term and mom had gestational diabetes, which creates what kind of baby?
Ultra big old baby.
Big old baby.
Big old baby.
Put 2 and 2 together, right? We got mega baby. Okay. So, obviously, this baby's not being delivered vaginally. Okay. So, yeah, again, normal sized baby going, God damn, what'd you eat?
I know.
Just staring at it. Okay. So, baby Michelin Man is just roaring over here. Right.
Yeah, he's still like,
So, as far as delivery, right, just do the best we can there. When it comes to delivery without sterile supplies, okay, so again, if we're off duty, do we have a duty to act? No. Okay, so we go, oh, dang, I'm going to call 911 and that's it. Okay, but if you want to be the hero and you want to help deliver, okay, just try to keep things as clean as you possibly can. Right, since we don't have our equipment, we don't have sterile supplies, okay, just try to keep things as clean as we can. We're not going to cut or clamp the umbilical cord because we also don't have any resuscitation equipment. Again, the umbilical cord is quite literally what?
Lifeline.
Baby's lifeline. So just leave it attached. Okay, but we have to keep that baby level with the pelvis at all times. Because if I pick the baby up and be like, it's a boy, again, baby's blood pressure goes down, keep it too low, right? Baby's gonna be hypertensive, so we gotta keep it level. And we gotta keep baby and placenta warm at all times. Because cold baby's a dead baby. And if I leave the placenta exposed, again, that blood is going from the baby, still going to the placenta, right, where it's gonna radiate heat and bring that cold blood back into the baby. Okay, so you want to wrap them both up, and once they're both delivered, keep them together, because again, I want to try to minimize blood shift as much as possible. Okay, so don't let that placenta just dangle down, right, because all that blood's going to go down there, right, and don't hang the baby from the placenta either, right, okay, where again, it's all going to go down the baby. So, we'll just go ahead and do that, right, and then we'll go on transport if EMS has not already arrived at this point. Okay, so just load mom and baby up, and we'll go.
You wouldn't wait for the EMS?
DIY baby delivery service.
You could, but again,
put on like siren sounds on your like speakers.
Just shout out the window.
Yeah.
Alright, so we'll go ahead and just transport. As far as wiping out the airway, okay, meconium or not, we're still going to use our glove finger because hopefully we'll have at least some form of BSI and just sweep it out just to clear it out. Okay, but that's about it. As far as teenage pregnancy, okay, we just go ahead and deliver as needed. Right, and like we said way back in the beginning, going back full circle, okay, teenage patients may be pregnant, and if that's the case, okay, she's going to be treated as an emancipated minor, so we don't need her parents' consent to deliver her baby. Okay, so she says, deliver my baby, and parents say no, we're just going to listen to her. Okay, so, I don't know, sometimes weird shit happens like that, so we just go and transport. Now keep in mind, the younger the patient is, the higher the risk of complications there are. Okay, so we got to be worried about that if we're delivering for, again, a 16 or 17-year-old, right? More risk compared to somebody in their mid-20s. Okay, so just be careful of that. All right, and that's that. So we're going to go ahead and demo the skill.
Yeah.
What? Did you bring up real life?
I know, yeah, who's pregnant?
It's you.
Oh my god, really? Do I have twins? I'll be here if you need a woman to. I got you. Wait a second. Look at it. It's a baby cherish. It's like.
All right. So, as far as delivery, okay, again, there's one question we got to ask yourself to know if we got to deliver. That question being what?
Is it imminent?
Is birth imminent? What is it?
Is birth imminent?
What is it?
Is birth imminent?
Right. And as far as signs, are there imminent signs of childbirth?
Yes.
All right. So, Brent, what's one sign of imminent childbirth?
Crowning.
What is that?
It's when the top of the head of the baby is coming out.
Coming out of what?
The vagina.
I'm sorry, what? All right. Okay, just get used to it. You're going to have to say it anyways. Okay, so if I see the top of the baby's head coming out of the vagina, we obviously know the baby's on its way out. Another one.
Bulging gooch.
It's medical terminology, sir. What's it called?
Bulging perineum? Perineum?
Perineum.
Perineum.
Okay, so the perineum's bulging. Perfect. What else?
Very
Awesome. And?
Wait, sorry, I got it. Like 1 second.
Damn.
Give me
Said you got it.
I was lying.
I want to beat him. Oh, I found it.
Yeah, you took it easy.
Frequent contractions, 2 to 3 minutes.
Okay, how do we time those contractions?
From the start to start.
Right. Okay, so the frequency of contractions has to be how many minutes apart?
2 to 3.
How many minutes apart?
2 to 3.
And measure them from what point to what point?
Start to start.
Right, start to start. Okay, and as far as those signs, how many have to be present? How many?
Just one.
How many?
One.
How many?
Just one.
Right, so do you have to know all 4?
Yes.
Yeah, because the one you don't know is the one you're going to see. And you're like, oh shit, now there's a baby. Okay, so all signs are present, or one sign is present, then we have to deliver. After that, there's a bunch of questions we got to ask mom. So, what's one question we have to ask?
How many times have you been pregnant?
What's the term for that?
Gravita.
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 Okay, what's another one?
Para.
Para.
Wait, how many have they delivered?
Okay, what do you want to know about the previous deliveries?
If they were successful.
Besides that.
Can you say that again?
What do I want to know about the previous deliveries?
If they were through either C-section or other, or natural, through the birth canal.
Right, or vaginal, you just say it.
Vaginal.
Okay, right, so if, again, we have previous vaginal deliveries, and which one of those do we care about and why?
Could it be other?
Okay, but why would I want to be concerned about that, and when would I ask that question?
If the parent and the leader don't line up.
Okay, so what would be an example of that happening?
If they had like 5 babies in the no, I don't know. If they had 5 babies, if they were pregnant 5 times and they've only had 2 deliveries.
Right, okay, so gravida and par don't match up. Okay, so what else do we want to know? Let's say she does have gravida and par that do match up. What do I want to know about the previous deliveries?
If they were C-section or like.
But why? Why do I want to know about that?
Because if it was through the vagina, then that means that if they had many, that means that the delivery would be faster.
It doesn't have to be many, it just has to be at least what?
1.
Right, okay, so one previous vaginal delivery, right, is going to decrease rather the time in which the baby's coming out. Okay, what's another question?
Are you prenatal care or has to be a doctor?
Well, prenatal care, we'll call it that.
Yep.
Okay, so prenatal care and,
Expected due date
or,
or last menstrual period.
right, so expected date, last menstrual period, what else?
Do they drink alcohol or do drugs?
Of course you would know that one. What else?
How many babies are expected for this birth?
Perfect. George?
What was the question?
What's another question we want to ask mom?
Well, what did you ask for?
Just pay attention, sir. You're going to have to know all of them. Just give me one. I'll tell you if we've said it or not.
Expected due date?
Yeah, we already said that one.
You already said drugs and alcohol. Yeah, most of them.
Just say them, and again, I'll tell you if we've said them or not. Your excuse, sir.
If their water broke,
Okay, so what do we not want to see?
brown or green coloration, like poop.
What would we call that?
Meconium.
Right. Okay. What else?
Any complications?
Such as?
Diabetes or preeclampsia.
Why am I worried about gestational diabetes?
Because then you might have a really big baby.
Right. Okay, so we got to worry about a big old baby. As far as hypertension, what do we call that? You said it. Yeah.
Oh, pre-eclampsia.
Which can lead to?
Eclampsia.
Which are?
Seizures.
Seizures. Yeah. Why? Why would I be worried about mom having an eclamptic seizure?
Because she's not getting oxygen, and therefore the baby's not getting oxygen.
Which is going to cause baby to do what?
Hypoxic. Die.
But because eventually.
Okay.
But what's the baby going to do when it becomes hypoxic?
Would it shit itself? Go into distress?
No, I don't know. What do you think, sir? The baby's hypoxic. You think the baby's going to be happy?
No.
No. Okay. So yeah, we're going to have to worry about meconium. Okay. So once we go over our key questions, okay, then we can jump to the skill itself. So again, recapping our questions. Expected due date or last menstrual period gives me a timeline of pregnancy, right? How much time do you have left, or how far along are you? Gravita, how many times have you been pregnant? Para, how many babies have you had? And of those deliveries, how many were C-section, how many vaginal? Okay. Prenatal care. Are you seeing any doctors, which will let me know about complications such as preeclampsia or gestational diabetes? Okay. How many babies are you expecting for this delivery? Okay. Did your water break? Was there any color or smell indication of meconium? And have you been using any drugs or alcohol during pregnancy? Okay. Those are going to be 8 key questions. Now, once we've gone through that, now we can actually get ready for delivery. So, we're going to go through the contents of our OB kit. Now, remember, everything in this kit has to be what?
Sterile.
It has to be what?
Sterile.
So, in no particular order, we're going to start going over the stuff. So, we're going to have the OB pad to control bleeding. Okay, we're going to have our bulb syringe to suction out the baby's airway as needed. We have our umbilical clamps to clamp the cord before we cut. We have the shears that we're going to use to cut, okay, once we have clamped. We have our OB wipes to go and cleanse the vaginal opening. Now keep in mind, these are not alcohol prep pads, okay, because this mom will call you and your mom names you never heard before if you use alcohol wipes, okay. And we have our 4x4s for tactile stimulation. Sterile gloves to make sure we keep things nice and sterile as we deliver. All right, nice warm blanket to wrap the baby up because cold baby is a dead baby. Okay, we have a plastic bag for the placenta, and we will have a chuck, right, to create a sterile or medically clean environment. And usually we'll have quite a few of these, but just to save space, we've just got the one. All right, now for class purposes, we're going to go and use the box to elevate mom's pelvis. How high?
2 inches.
How high?
2 inches.
But do I want to use a cardboard box in the field?
No.
because it's not going to hold her weight. So we want to use something that's sturdy enough to actually hold her weight, keep her elevated. Okay. Now, like I said, 2 different ways to start the skill. I like to call them the LA County method and the common sense method, and you can tell which one I prefer more. Okay. Now you can take your pick, whichever one you want. So I'm going to start off with the LA County method first. So we're going to find something to elevate mom's pelvis 2 to 4 inches high, and then we're going to go and have her sit on top of that like so. Now, for delivery, obviously you guys will be right over here, but for demonstration purposes, I'll be back here because you're not going to reach over mom like that to deliver. Okay. So, as far as the LA County method with our regular non-sterile BSI, we take our OB wipes. We start at the pubic symphysis. Where do we start?
Pubic symphysis.
Right. Again, symphysis like symphony. Okay, so the pubic symphysis, work our way down the labia. Down the what?
Down the labia.
To the perineum. To where?
Perineum.
One wipe, one swipe. And then I do the same thing on the other side, starting at the pubic symphysis. Starting where?
Pubic symphysis.
Down the labia. Down the what?
Down the labia.
To the perineum. One wipe, one swipe. Okay, so now that mom is clean, right, we now are going to make sure we stay clean. So we take off our non-sterile BSI and put on our sterile BSI. Okay, now here's the part that I don't agree with LA County. Okay, now that we have our sterile BSI on, now we can go and lay the chuck. Which means that I have to have this lady who's pregnant and about to give birth sit up so I can go and place this chuck down here and then have her sit back down. Okay, does that make sense? No, considering that childbirth is a nasty, messy gulp, so this thing's going to get dirty anyways. So, rewinding, okay, common sense method, keep this medically clean. I use my regular non-sterile gloves to grab the OB kit, take it where we're going to elevate, and lay it down. Okay, now as far as our chuck, we have a white side, which is the absorbent side, and a blue side, which is non-absorbent. If the blue side is up, whatever goes out of mom goes onto your lap. Okay, so you want to make sure you have that absorbent side right there. And then we can have mom sit down, and that's it. We don't have to move her anymore. Okay? Common sense. So, with our regular non-sterile BSI, we take our OB wipes, starting at the
pubic symphysis.
Work our way down the
labia
to the
perineum.
One wipe, one swipe. And it's perineum, not peritoneum. Okay? So, your turn, 100%, starting at the
Pubic symphysis.
Down the labia.
Down the labia to the perineum, one wide, one wide.
That was terrible. We'll work on it later. Okay? So, no, it's coordination. Okay? So, you guys all clap like that. So, as far as keeping mom nice and clean, okay, now that mom is clean, okay, we take off our non-sterile BSI and then we put on our sterile BSI. Okay? So, once we have that all set up and ready to go, now we clasp our hands together and we wait for mom to push. Okay, and when mom says she's ready to push, we encourage her to push. So we take 3 fingers of our dominant hand, place it over top of the baby's head or the entire hand itself. Okay, so again, this hand prevents explosive childbirth, whereas 2 fingers of our non-dominant hand goes over the perineum to minimize perineal tearing. Okay, and then when she's ready to push, we simply encourage her to push. Okay, so mom's going to push. Okay, as we're putting gentle pressure on the head to, again, keep that baby from shooting halfway across the room. Now, once the head is delivered, we want to make sure we're supporting the head at all times. Okay, because whatever we have it elevated may thump, right? Which again explains some things for some of you. Okay, so we want to go and keep that head supported. Right, at that point, we're going to be looking for 2 things. So what's one thing we're looking for when the head comes out?
I'm not thinking about it.
Something we're looking for.
The umbilical cord around the neck.
What do we call that if it's around the neck? What do you call it if it's around the neck?
I'm not sure. Like a nucleogenic cord?
Nucleogenic cord.
Neurogenic cord.
No. What is it?
Nuchal cord.
Nuchal cord. Okay. All right. It's a nuchal cord. All right. No, because genic means originating from. So it doesn't make sense that the cord originates from the neck.
That'd be really bad.
That would be very bad. Okay. Don't want to deliver this abomination. Right. So, okay, if we have the nuchal cord, what kind of cord?
Nuchal cord.
What's the first thing I try to do?
Slip it over the head.
And if I can't?
Clack, clack.
Right. Okay, so we try to slip over the top of the head. And if we can't, we get our OB clamps. Get them wherever we can. There's no 2-inch spacing. Okay, get them wherever we can. Clamp, make sure there's no pulse, and then we go and cut the cord. Once that baby's delivered, we go. Okay. What else are we looking for when the head's delivered? What else are we looking for? What else? Meconium. And if meconium is present, what do we do?
Suction, bulb suction through the mouth first and then the nose because of the gasping reflex.
Perfect. Okay, so we take that bulb syringe. Okay, and when we use a bulb syringe, it works the same way that we breathe. Okay, so as I collapse it, it creates positive pressure, and as I let it go, it creates negative, and that's the suction. So before you use it, you push all of the air out, and where do we suction first?
Mouth.
And then nose. Okay, so just to make it easier, we'll go and turn that baby's head. So we'll go and take our bulb syringe, keep it depressed, place it in the baby's mouth, let it go, and then we dump the contents onto the chuck. Okay, because we'll be taking this to the doctor so we can be like, hey doc, look what we saw and what we suctioned out. Okay, so we go and do that until the mouth has been suctioned, and then we go and suction out once per nostril. And whenever I see meconium from this point forward, we see it, we
treat it.
We see it, we
treat it.
So we'll go and have this handy just in case we have to do suction later on. So once you've assessed the head and neck, everything's good to go. We're going to wait until mom has another urge to push, and then we pop out the shoulders. Okay. Now the shoulder is going to come out one at a time. So pop, pop, and then once that happens, the rest of the baby comes sliding right out. All right. Just untangle this thing here. So once that baby's delivered, okay, we want to make sure we keep it level with mom's pelvis in a slightly left lateral Trendelenburg position. Okay, so left lateral to clear out the airway, Trendelenburg to have any fluids in the lungs, good or bad, start working their way out of the airway. And if we see meconium, we see it, we
treat it.
So where do I suction first?
Mouth.
And then
nose.
Because gasping reflex. Okay, again, we're not going to be like, it's a boy. Because if I do that, all that blood goes down to placenta, baby's blood pressure goes down. Okay, and conversely, if I bring it too low, baby's going to be hypertensive. Okay, so we're going to hold that baby there, and then we do 1 minute of tactile stimulation. Okay, so you wipe that baby down, front and back. Okay, try to get that baby to cry. We can also, again, flick or tap the bottom of the baby's feet. Now, per our DOT standard, okay, 1 minute after the baby's been delivered, what do we assess?
It's that acronym.
Mm-hmm.
Their skin color and their respirations and pulse.
What's it called?
And damn.
It's like cool effort.
I don't know.
What's it called? APGAR. What does APGAR stand for?
Appearance, pulse, curve, sensitivity, respiration.
Right. And what's a perfect APGAR score?
A 10.
What about acceptable?
9.
Right. Where they get doctor point where?
skin appearance if they're peripheral cyanosis?
Right. So if they got blue hands and blue feet, but everything else checks out, is that okay?
Yeah.
Yeah. Okay, so that's totally fine. So we'll go and do that 1 minute APGAR assessment, see what's going on. If the baby's got a good APGAR score, now we're ready to go and clamp and cut the cord. For DOT, George, where does our first clamp go?
With 2 inches closer to the baby.
Okay. And then second clamp goes where?
2 inches closer to mom.
Right. Okay, so 2 inches from that clamp closer to mom. We clamp, make sure there's no pulse, and then we'll take our shears, right, and then we go ahead and cut the cord. Okay. Now for LA County, where does our first clamp go?
4 to 6 inches away from the baby.
Okay, and then second one goes?
2 inches after that.
Right. Okay, 2 inches after that. Again, same deal. Clamp, make sure there's no pulse, and we go and cut the cord. Okay. Now once that baby's delivered, we want to wrap the baby up because cold baby is a dead baby. So there's a bunch of different ways you can wrap up your baby. Okay. All we want to make sure is that head is covered up because they lose most of the heat from where? From the head.
Do we tie the cord at all, or do we keep it just clamped?
Just keep it clamped. Yeah. All right. So I like to wrap the baby up using what I call the diamond method because you open up your blanket into the shape of a diamond, and it's just the best. So we go ahead and take the baby and place it in the middle of the diamond. You want to give yourself a minimum of 6 inches from the top of the head to the corner to make it work. If you have more, that's totally fine. Okay, and what I do is I very carefully fold this thing up and I bring it up to the level of the baby's eyebrows, just like that. Okay, and then we're going to gently, again, that is gently, the key word is gently, hold on to the side of the baby's head. I'm going to use, I usually fold the feet up over first so the baby doesn't fall out like a burrito. Then we go and fold the sides over just like that. Okay, to wrap the baby up and essentially swaddling the baby, not swallowing, but swaddling, okay, to where we go ahead and place it like that. Okay, that way all we have, right, is baby's face exposed. No. So, after that, okay, we'll go and give it to our partner, and they're going to do what after 5 minutes? APGAR. Right, do the second APGAR 5 minutes after delivery, and then they can bring the baby back to mom and encourage breastfeeding. Okay, so go ahead and right. And then, right, and then we'll go ahead and deliver the placenta. So, how long should it take for the placenta to deliver?
No more than 30 minutes after delivery of the baby.
Okay, what's one sign of placental delivery?
The urge to push.
Cool. What else?
Bleeding.
Okay, and?
It's the stretchy umbilical cord. It's making it longer.
Okay, elongation of the cord, sir. Fancy terms. Okay, so mom's gonna have another urge to push. Okay, so as that placenta detached from the uterus, okay, she's gonna have contractions that will push it out, and as that cord is going through the birth canal, the cord appears to get what? Longer. And then right before that, gush of blood, and then we're gonna have to deliver the placenta. So again, it should take 30 minutes or less, where we inspect for any missing pieces, tears, lacerations, or abnormalities. Right, and then we bag it and tag it. What do we do?
Bag it and tag it.
So we will go ahead and take mom's name, date, and time, place that on the bag of the placenta, right, as we have it ready for transport. And then from here, we'll go and take our OB pad. Okay, with the vaginal pads, there will be a sticky side, and we want to make sure that sticky side is out, right? And if she has any shorts or underwear, we can pull that up, and then we start doing what kind of massage?
Fondle.
Kind of massage?
Fondle.
Not fondle. Fundle. Okay. Where we go and massage that uterus, okay, to go and get it to contract. So again, going like this, like that, like that. Again, just no shiatsu. Okay, to get that uterus to contract in on itself to help control bleeding. Okay. Now, if that pad becomes fully saturated, what do?
Take it off, get new.
All right, we swap it out. Okay, and what's going to be considered excessive blood loss? What's considered excessive?
3 pads or 500 mils.
Right. Okay, so 3 pads or 500 mLs of blood, right, is considered excessive. Yes, sir.
My question was, if because we have to record the information about the baby, like you said, time of birth, all that stuff. If mother decides name of baby, we would put that on the patient.
Don't care about that. Nope.
But if you stay on it,
bro, this
name
is
the baby.
XYZ.
Yeah, it's just baby boy, is what they call it.
Literally
So,
Tesla.
as far as that, we'll go and put it on. Again, if the pad gets fully saturated, we go and swap it out. Now, if she does elect to put on any clothing, we'll just tell her, hey, if you feel anything dripping down your leg, let us know so we can assess the pad. All right, and if it's fully saturated, just swap it out. Okay. Now, if there are no complications, how do we transport her?
Code 2.
Code 2. And if there's any complications, we go code 3. Okay, so delayed placental delivery, excessive blood loss, right? Delivery complications, okay, anything like that, we automatically go code 3. But if everything's good to go, it's a nice, easy code 2 call to the hospital. Okay? So this is going to be one of your skill stations on Friday. So, do we expect you guys to know everything about childbirth come Friday?
Yes.
Absolutely. Okay, so, any questions?
Can we put used pads in the same bag as the placenta, or will we have another bag?
Preferably another bag, but if we don't have a choice, then we just put it in the same bag.
Oh, we get some hands-on training.
Okay? Any other questions?
I worry about him sometimes.
So do I. Okay. All right. So for tomorrow, okay, we're going to be doing our ALS assist and geriatrics. So for ALS assist, it's a lot of show and tell, right? As we're going over the stuff, since we're going to be medics' little helper. All right. Geriatrics is pretty much going to be a preview of our review lectures, right? Considering that most of the patients and conditions we've talked about are going to deal with what kind of patients? Geriatrics. Okay. So we'll be going over that, and then we're going to go ahead and start talking about WMDs, which will kind of lead on to what we're going to cover Thursday, being our MCI, ambulance operations, and other stuff like that. Okay? And that's it. Right? And then you guys don't have any new lectures and stuff like that, and then it is going to be skill day 3. All right, so really quick. Oh, I haven't said you guys are good to go yet. Okay, she's running out the door, because this pertains to you, since you brought it up. All right, so as far as tutoring, some of you are aware, okay, that's going to be going on Saturday, all right? I'm going to have you guys, I usually have you guys sign up Friday, but I'll just do it Thursday. Okay, I'll have you guys sign up for that. It's going to be from 5 p.m. to 9 p.m., since I will be working in the morning over at Hawthorne, so of course that will be happening here, okay? So that'll be going on, right? There is a fee for it. It's $15 an hour, okay? We're going to go through skills. It already is pretty much preset on the skills you guys typically have most issues with. Okay, I don't really cover a lot of stuff we cover on Friday because we're just doing it the day before. Okay, so kind of going back and doing the other skills that you guys suck at. So we'll be going over that. There does have to be a minimum though. Okay, it's got to be at least 4 of you guys, right, to go through, so that way you guys can actually have enough people to do your skills, right? Because it's not really worth your time if it's just one-on-one. Okay, so you guys can go and figure out. Okay, I do have space for everybody to show up if you guys want to, since you guys are so small, right? But it's got to be at least 4 minimum. Okay, so like I said, we'll do signups on that stuff on Thursday. Now you can go home.
So you could decide whether you only want to do like 1 hour, or
it's not really worth your time.
Yeah.
1 hour, but
no, it's just
Thanks so much.
determining of that.